Please start the meeting.
Good afternoon, everyone. I'm Dr. Sreeni Edakhlon, Chairman of Scientific Committee of the Kerala Society of Ophthalmic Surgeons. It's my great pleasure to invite you all to the 6th in the series of Kerala Society of Ophthalmic Surgeons Scientific Committee CME series. This 6th module of the Scientific Committee CME series is being organized by Kottayam Ophthalmic Society. It's my pleasure to invite Dr. Asha James, President of Kottayam Ophthalmic Society, to this meeting, and she'll be presiding over this meeting. I have with me Dr. Sujit Nayanar, who is a member of Scientific Committee of KSOS, and he's one of the pillars in all the very active Scientific Committee activities that we are doing for KSOS. Welcome, Dr. Dhrumil, Secretary of Kottayam Ophthalmic Society. Has done quite a bit of work in planning this program, getting the chairpersons, getting the faculty and all. Welcome, Dr. Dhrumil. It's my great pleasure to invite all the keynote speakers, Dr. Jitendra, Dr. Pradeep Sharma, Dr. Arun Samprathi, Dr. Subhadra Jalali, our guest speakers, Dr. Sumita Garkar, and Dr. Niranjan Fere, and all the guest faculty, and our state faculty, Dr. Elizabeth, Dr. Laila, Madam, and all the chairpersons. See, basically, when we plan the Scientific Committee CME series CME, the plan is to for the KSOS Scientific Committee to just act as a facilitator and improve the academic activities to activate all the district ophthalmic societies. And we were quite successful with that, with Kannur, Kottayam, Palgad and all, which were quite dormant till we started this program. And once this program started, they had Kannur, in fact, had 2 physical meetings. So here it is Kottayam Ophthalmic Society which is doing this, and welcome all the members of Kottayam Ophthalmic Society to this meeting. And we have our chairpersons. Basically, like all the Scientific Committee CME series programs are 4 hours, and it'll be split into 4 sessions of 1 hour each. And this is the scientific program of each session is planned and executed by the chairpersons. So it is sort of their instruction course. So we have Dr. Lakshmi, Dr. Thomas Matthew, Dr. Satish, and Dr. Natasha, who have done a wonderful job in getting all the faculty and the speakers. I welcome all of you. Now, I request Dr. Asha James, President of Kottayam Ophthalmic Society, to take over and preside over this meeting. Madam.
Thank you, Dr. Sreeni. Respected senior members, colleagues, and friends. We, the members of Kottayam Ophthalmic Society, are greatly privileged and honored to host today's CME on pediatric ophthalmology, the happy child, under the aegis of KSOS. On behalf of the Kottayam Ophthalmic Society, I welcome the Honorable President of All India Ophthalmological Society, Dr. Barun Kumar Nayak, the Honorable President of Kerala State Ophthalmological Society, Dr. Arup Chakrabarti, the General Secretary of KSOS, Professor Dr. Gopal S. Pillai, Chairman of the Scientific Committee, Dr. Sreeni Edakhlon, members of the Scientific Committee, Dr. Prashob Mohan and Dr. Sujit Nayanar, and Secretary of KSOS, Dr. Dhrumil Khirsariya. Kottayam Ophthalmic Society also extends a warm welcome to Dr. Rajiv Sukumaran, who is going to give a presentation on KSOS on demand, and to all the chairpersons, speakers, and expert panelists who are going to take us through the various sessions in today's CME. Now, Dr. Arup Chakrabarti, our Honorable President of KSOS, has sent his inaugural message.
Good afternoon, friends. A warm welcome to all of you on behalf of Kerala Society of Ophthalmic Surgeons to this wonderful webinar titled The Happy Child. This is actually the CME series module 6 that the Scientific Committee of KSOS is organizing in collaboration with Kottayam Ophthalmology Club. I am indeed honored and privileged to be asked to inaugurate and deliver the inaugural address for this prestigious webinar as President of KSOS. This is the 25th inaugural ceremony that I am participating in, which means KSOS has been a very, very vibrant organization. It has been active on all fronts. The Chairman Scientific Committee has been coordinating and collaborating with the various registered associations in organizing these very useful webinars. The Secretary KSOS, Dr. Gopal Pillai, has also been doing extremely well in terms of organizing the PG classroom sessions, in addition to looking after the day-to-day administration of the vibrant society. This is actually a historic webinar because we are fortunate to have our President, Dr. Barun Nayak, President of All India Ophthalmic Society, to inaugurate the dream project of KSOS called KSOS on Demand. In this project, we have all the contents that were presented during Drishti 2021, a program conceived by our former Secretary, Chairman Scientific Committee, Dr. Rajiv Sukumaran, and compiled extremely well by the current Chairman Sreeni and his team of Scientific Committee members. So everything is there on the site. It is accessible for everybody. It is absolutely free site. I think this is one of the first time in any state association this project has ever been attempted. And not only that, all these CME programs that are being conducted under KSOS, the PG classrooms sessions that are being organized by Dr. Gopal Pillai, and the Journal Club, which again has started from this year onwards. Everything is archived in the on-demand portion of the website. And so this is going to be very easy for us when you try to access a specific or a particular information. So KSOS actually has been doing quite well, being pretty busy. We also are going to embark on a membership drive. We want more and more of ophthalmologists in Kerala to become members of KSOS, members of All India Ophthalmic Society, and join the family benefit scheme of All India Ophthalmic Society. When you peruse of the program today, it is a wonderful program that has been conceived by Dr. Dhrumil and Dr. Asha in collaboration with the scientific committee. So thank you, Dr. Dhrumil and Dr. Asha, for spearheading this webinar. I'm sure this is going to be a great feast for all the members and the delegates who are, or attendees who are attending, listening to this webinar. I wish this program the very best and have a great time. Thank you very much.
Thank you, Dr. Arup. Next, I invite Dr. Sujit Naina, Member Scientific Committee of KSOS, to offer his felicitations.
Thank you, Madam. Hope I am audible. I've got unstable internet connection. Thank you for the chance for giving me a felicitation and to be part of this program. Like what Dr. Sreeni told, the CME series by KSOS Scientific Committee is the 6th module going on. We started in January with Calicut being the first club to organize the CME series part 1. And with that, after that, every CME series is gaining momentum and great interest. We are trying to involve all the clubs who have not been participating or conducting programs for the last 2 years because of the COVID. And every club is taking up this initiative with great interest, and they are living up to our expectations. And here again, we are seeing a lot of interest, a lot of participation. The YouTube videos are getting a lot of visibility among other clubs. also, I mean, outside Kerala, or what we have anticipated. And special thanks to Dr. Gopal S. Pillai and Dr. Sreeni for taking up the leadership under Dr. Arup. And as Dr. Arup has mentioned, all these will be archived on Ksos on demand, and which will be inaugurated today, and it will be available on the website. Especially to this program, actually, the background work was done, not able to join today, so I'm substituting him for this felicitation. Our special thanks, we appreciate the hard work of Kottayam Ophthalmic Society under the leadership of Dr. Asha James and Dr. Dhrumil. Dr. Asha James was one of my mentor. I started my private practice under her way back in 2007, and it was like one of my golden days starting my practice, doing my practice in Kottayam. So it is a great moment for me also to join in this program under her leadership. I wish this module of KSOS CME series all the very best. We have a very excellent session lined up covering all the practical aspects of pediatric ophthalmology and very good faculty. I wish this series and this particular program all the very best. Thank you.
Thank you, Dr. Sujit. Now I invite Dr. Dhrumil Khirsariya, Secretary of Kottayam Ophthalmic Society, to give vote of thanks.
Am I audible? Yeah.
Yes.
Okay. Good afternoon, everybody. On behalf of organizing team and Kottayam Ophthalmic Society, it is my privilege to propose a vote of thanks on this occasion. I convey my deep regards and gratitude to our Honorable President of All India Ophthalmological Society, Dr. Barun Kumar Nayak, and our Honorable President of KSOS, Dr. Arup Chakrabarti sir, and our General Secretary, Dr. Gopal S. Pillai, for gracing this occasion. I am also thankful to Chairman Scientific Committee, Dr. Sreeni, and Scientific Committee member, Dr. Sujit Nainar and Dr. Prashob Mohan, to give us opportunity to organize this event on behalf of KSOS. My heart fills with lots of gratitude and respect for our distinguished guest speakers who are very renowned faculties, then our distinguished chairpersons and expert panel member for not only sparing their valuable time for us to grace this occasion, but also to enlighten us with their vast experience, knowledge, and wisdom on the subject. I'm sure that we are going to learn and imbibe a lot from today's CME series and from their vast experience in the subject. My sincere thanks to Dr. Asha James, our Kottayam Ophthalmic Society President, and all our Kottayam Ophthalmic Society members for providing me constant support and motivation to move forward in this CME. And last but not the least, I would like to thank and I would like to extend my gratitude to all our beloved audience for making this CME a great success. Once again, I thank one and all present here. Thank you. Thank you very much.
Thank you, Dr. Dhrumil. Thank you all. Now let us proceed for the scientific session.
Yeah.
We will start the scientific session probably in 4 minutes time, at about 2:40. Welcome, Dr. Jitendra Jethani. Thank you for agreeing to be part of our meeting. So, Mahadevan sir. Mahadevan sir.
Yes, I am here, unmuted. Yeah.
Hi.
Fine.
Hi.
Thank you.
Sir, a few words from you before we start the session regarding the academic activities that are going on in KSOS and Dr.
I
Hello.
think he has lost connection, sir. He wanted you to say a few words before we start the program.
Yeah, no, I can hear that. I can hear that. Nice to join you all. It's a great experience again. I think by this time, even though the year is not even half the mark, almost all the subjects have been covered. It is a great experience. And I used to do, even though I did not join live, I used to replay with the video through the YouTube. Excellent programs. And I wish I could contribute something this time also in this. Thank you very much, and best wishes to everybody.
Thank you, sir. We actually were planning to have the inauguration of the Ksos on demand along with this inauguration. It was supposed to be done by Dr. Varun Nayak, but Dr. Varun Nayak, Dr. Arup, and all are in inspection at Mumbai for the this year's AOC venue. So we will be doing the inauguration of Ksos on demand at 7 p.m. today. Dr. Varun Nayak will be joining us from Mumbai at that time. So that will be when the Ksos. A few words about Ksos on demand. It was a sort of a dream project of our dear President, Dr. Arup Chakrabarti. See, basically, when I took over as a scientific committee chairperson, see, my basic idea was to split the talks, like what I've been doing, one talk, and keep sending it, either mail it or WhatsApp it at a regular basis. So, but Dr. Arup had something better and bigger in mind. So he took the initiative to create a Ksos on demand portion for our website. And through this Ksos on demand, it's sort of a link to another, because there are limitations for any website. But you come there, you go to Ksos on demand, you can see each and every session of the instruction courses held last year. I mean, we had more than 600 talks and beautiful talks. We had an international speaker session, absolutely world-class talks. So what has been done is like what is there for ESCRs on demand, ASCRs on demand, American Academy and all. You go to our site, go there, click for somebody's talk. Like if Dr. Jethani had given a talk during that, search for Dr. Jitendra, all the talks by him will pop up. And also for any like you want to see the sessions on cataract, you search for cataract, all the talks on this session will be coming. So on different sessions, whatever related to cataract will be coming. So it's a wonderfully designed section, and to that we have actually added links to the scientific committee CME series. As I said, this is the sixth of the series. Most of our the series talks have crossed 1,500, 3,000 and all views, which is quite huge, and so it's still increasing. So those talks are there. On our president's initiative, we started this journal club, which is also really wonderful. I mean, it's going on very regularly. Dr. Sudha is doing a perfect job with it. So you have the link to that, and under us really dynamic secretary, Dr. Gopalas Pillai, we are regularly doing PG classroom class, and just to just see the popularity. Let's consider it. It's all the PGs who are seeing it. So you see that 600, 700, 800 views. That means that it's not the PGs in Kerala that are seeing it. I mean, PGs from all over India are seeing it, and those PG sessions, we've actually surpassed viewership of the PG classes that used to happen before by different groups in India. So we have a link to that also. So this is an all-encompassing program, Ksos on demand. Please, all of you join us at 7 o'clock for the official inauguration by our dear AO's President, Dr. Varun Nayak. And we can start the first session. Dr. Lakshmi, are you ready?
Yes, sir. Yes. We'll start with the first session. I think I'm audible.
First of all, maybe I would like to invite Dr. Haripriya, who is a senior resident of Kottayam of Kottayam Medical College. I would like Dr. Haripriya to convene the sessions one by one.
Thank you, sir. Am I audible?
Yes,
Yes, Dr. Haripriya.
yes.
Yeah.
So, pediatric ophthalmology is quite fascinating, but at times frustrating for a general ophthalmologist because the art of examining a child is hard to acquire. It is also a constantly changing and evolving field. With these thoughts in mind, we are presenting this academic feast on pediatric ophthalmology. Without any delay, let us move on to the first session on myopia, which is gaining its importance in this COVID era of increasing screen time owing to the virtual education. For this, let me invite Dr. Lakshmi C., consultant pediatric ophthalmologist and associate professor, Malabar Medical College Hospital, Calicut. She did her MBBS in Government Medical College, Thrissur, and completed her MS from Aravind Eye Hospital, Madurai. She did her fellowship on pediatric ophthalmology in Aravind Eye Hospital, Madurai. She also has numerous national and international publications to her credit. I welcome you, ma'am, to chair the session on myopia.
Thank you, Dr. Haripriya, for those kind words. I hope I'm audible.
Yes, ma'am.
Is my screen visible to all? Yeah, thank you.
Yeah, screen is also visible. Yeah.
Okay. So thank you, Ksos and Kottayam Ophthalmic Society for this session on myopia. And with Khalil Gibran's words, he is short-sighted who looks only on the path he treads and the wall on which he leans. So let us ophthalmologists come out of the practice of just prescribing refractive correction for myopia and think broadly to assess regarding the myopia progression and think of ways to retard its progression. So we have eminent national and state faculty for this session. And I would like to invite the panelists for this session. Mahadevan sir, he needs no introduction to the audience of KSOS, professor and head in Sri Gokula Medical College. And sir has done eminent work in this field of myopia progression and control. Welcome you, sir, to this session.
Thank you.
We are pleased to have Dr. Laila madam here. She also needs no introduction. And she is currently the director in Comtrust Academy of Research and Training. We look forward to getting some pearls from you, madam. Welcome you. I would like to invite Dr. Soumya Nambiar, my close friend and consultant pediatric ophthalmologist in Calicut Comtrust Eye Hospital, to this session as panelist. Welcome you, Dr. Soumya.
Thank you, Lakshmi.
So it is my privilege and great honor to welcome a person who has vast knowledge, not only in his patients, but with regard to the particular approach, he has an experience. I'd like to invite Dr. Jitendra Jethani. Dr. Jethani did his graduation from BJ Medical College, Ahmedabad, followed by MS Ophthalmology in Ahmedabad. He is a fellow national board from Aravind Eye Hospital from University of Wisconsin as well. And he was assistant professor in RIO Ahmedabad, as well as head of pediatric ophthalmology in Dr. Thakur Patel Institute till 2000. He is the director of Baroda Children Eye Care and School. Not mentioned, he has more than 52 scientific publications in peer-reviewed indexed journals and several scientific presentations in state, national, and international conferences. And these are a few of the accolades in his account. And I remember Dr. Jethani as a passionate teacher, even from his fellowship days. And we look forward to having, getting some pearls and knowledge tips in this field of myopia progression control. We welcome you, Dr. Jitendra Jethani, to deliver your keynote address. Thank you, sir.
Are you muted? Can't hear you.
Am I audible?
Yes, now you're audible, sir.
Oh, so thank you so much, Dr. Thank you so much for the warm introduction, and it's my privilege to be speaking to such august crowd about tackling myopia, especially with atropine. So our journey started with atropine. I think it has now been almost 7 to 8 years when we started using low concentration atropine for controlling progression of myopia. And we all know these numbers, which were published by Bran Holden Eye Institute way back in 2010. I mean, they estimated, this was published in 2006. They estimated that by 2050 we would see a huge pandemic of myopia, and almost 52% would become myopes. This is just a distribution from the same institute. And we know about this, that it is nature versus nurture, and predominantly it also is affected by other activities like outdoor activities and near work, which also creates environment which makes the progression of myopia. This is just a timeline of all the papers, and essentially, we know all this. This is just a short revision of what happens in myopia. So with all that literature, we come to certain key messages that if parents have myopia, kids are more likely to have it. Outdoor activities do make a difference. Near work, amount of light does result in myopia progression. Height increase does correlate with the growth of size of eyeball. And all this was, these are all risk factors for myopia, especially in school-going children. And all this, we started reading about atropine for myopia. We all know that atropine is used for myopia. It has almost been 50 years since atropine was said to have some effect on myopia progression. And most of us thought that it was mainly because of its effect on accommodation. And mainly it was atom 1 study, which was, so these are some of the theories as to how atropine works. And this was the reason why I always start my talk on atropine with this particular article, is because this was published in 2006 from Singapore. Look at the size of, the size of numbers, 400 Singapore children, a good sample size, randomized, double masked, placebo controlled trial. They used atropine 1% eye drop in one eye and instilled a placebo in other eye for a period of 2 years, and proved that atropine 1% does have a very strong role in preventing the progression of myopia. I'm still surprised how they could get away with the ethical approval, because this was for 2 years, 1% atropine in one eye versus placebo in other eye. But it is there on paper. Wonderful study. If you go through the study, they have taken care of almost everything. It's a wonderful study on atropine 1%. In fact, their own study on atropine 0.01% was not as robust as was this particular atom 1 study. So they came up with atom 2 study, where they actually, so what they did was they tried to see if they reduced the concentration of atropine, what was its effect. So their primary outcome measure was to see atropine 0.1% and the role of 0.1% in comparison to 1% and 0.01%. So they used 3 drops, 1%, 10 times diluted 0.1%, and 100 times diluted 0.01%, taking into consideration, thinking that when you reduce or when you dilute the drops to as low as 100 times, it won't have any effect. And that particular arm would be serving as a control group. So they did not have a placebo in this particular study. Placebo was actually 0.01%. So that when they published atom 2 study in 2012, this was a follow-up 5-year-old study, which I am showing, but they published atom 2 study in 2012, and they showed that 0.01% still had a role, despite reservations that it was 100% diluted drops of 1%. So in pharmacology, normally we are taught that if you reduce an effective concentration, which was 1%, for all of us, atropine has always been used as 1% ointment or 1% drops. So when you effectively dilute it by 100 times, it would lose its efficacy. But they found that atropine 0.01% was quite good and was showing some results. So the advantages of 0.01%, obviously, there was hardly any effect on accommodation. and the chances of side effects obviously go down to very minimal because you are reducing the concentration of a sulfur drug, atropine sulfate. It is always a sulfur drug. So you are reducing the concentration by almost 100 times. So the chances of side effects like fever, flushing, all those, and even allergic reactions go down by almost 100 times or even less. So the retardation of progression, according to ATOM 2 study, was not dose dependent. We would see how this was challenged by Lamb et al. In their study of LAMP 1 and LAMP 2, where they found that it was dose dependent. But at this point of time, we are still in 2012, and we found that atropine 0.01% was not really a dose dependent concentration or retardation of progression. So everything is wonderful. Now we have got a drug whose concentration is 0.01%, minimal to no effect on accommodation, and doing well. And it was at this point of time when we also started using reconstituted atropine in India, whereas it was not available pharmacologically. It was available pharmacologically, I think, in September 2018, when Appasamy started making low concentration atropine. So this was, once we have everything in place, atropine 0.01% is doing wonders. Everybody is gradually getting convinced that it will be doing something. And yet we don't have, now we have 0.01%. So we are pretty sure that its effect on accommodation is not there. So we have to find out how it is working, number one. Number two, we also have to find out what is the optimum concentration, because this was truly a hit and trial thing. This was more of a placebo control arm, which actually started working. So it was more like 0.01% was the minimum concentration which would work. And so LAMP 1 study came where they had very small steps, 0.01%, 0.025, and 0.05. And they tried to compare these three particular concentrations with regards to myopia control. And they came up, I think they published their phase 2 report of 2 years in 2019. This was during the lockdown, and they found that atropine 0.05% was much better than 0.025, which was much better than 0.01. And they found that it was dose dependent, and they felt that 0.05% was quite good compared to 0.01%, and was almost double strong as 0.01 in controlling the progression of myopia. They also did some secondary studies where they found that if the child is young and is having myopia, the chances are that he would be a non-responder to low concentration atropine. A non-responder is defined as having a progression of 0.5 diopter in a year. Like if there's a progression of myopia of 0.5 diopters, that would be a non-responders. They also put to rest on all the theories if atropine can be used for hyperopia, astigmatism. So they found that it has got no effect on ocular biometrics except axial length. So this also puts to rest all the doubts about which particular myopia would be getting atropine. Like it would be axial myopes who would be progressing, and there is an axial progression, and those are the patients who would be the suitable candidates for low concentration atropine. So where does all this initial ATOM 1-2 and LAMP 1-2 lead us to? It leads us to the point that atropine eye drops are now the basis of treatment for progression of myopia. It is very important to understand that we are only treating the progression part. We are not treating the myopia, which is being treated with glasses itself. It is concentration dependent. However, 0.01% still does hold value, and there are possibilities that you can increase the concentration non-responders, since 0.015% is just a minute. So am I audible?
Yes, sir.
Okay. So what we come down to is that we come down to our own intervention. So our intervention, we did a randomized control trial for 3-year period, and we had 2 groups of atropine 0.01% versus no drops. And we in our own study found that the atropine group was much progressing. Atropine group had much promising results, was much better compared to control group. We just did this study for 3 years, and comparable results with other Indian studies we recently published our data on pre-myopes, and we found that atropine was indeed useful in pre-myopes also. And this we compared low concentration atropine once versus twice, and we found that twice a day usage of low concentration atropine is much better or much stronger compared to a daily dosage. Effect of atropine in non-responders. So as I said, if there's a progression of minus 0.5 diopters per year, these are the patients who are non-responders. These are the patients who are not responding to single day usage of atropine. And we found that if you increase the dosage to twice a day usage, the chances that these particular patients would respond, there would be almost 33.3% patients who would still be responding to low concentration atropine, same 0.01%. If you increase the once a day dosage to BID dosage, and this is not important. Yeah. So we also tried to do some work on children, pediatric cataract patients who have already been, we have operated them, and they are beyond their physiological growth of eyeball at the age of 4 years. And there are some small subset of pediatric cataract patients who have myopic shift even after 4 or 5 years of age. And we saw that low concentration atropine was useful even in those children. So the last time we looked into our data in 2019, when we were presenting our paper in AIUS, we saw that once it was almost 4 or 4.5 years, these children were still progressing. And once we started using low concentration atropine, their axial elongation started gradually slowing down. So this also puts at rest the theory that it has got any effect on accommodation, because these were all pseudophakic children. These were 7 children, some of them uniocular and some of them bilateral surgeries were done. And all these children did have a good effect of atropine, low concentration atropine. We did some small studies to find out whether it is safe to use low concentration atropine. We did pattern ERGs on eyes with installation of low concentration atropine, and we found that low concentration atropine was not affecting pattern ERGs. This is pre-atropine. This is my own eyes. Both are my ERGs. I had instilled eye drops in my own eyes and tried to find out whether low concentration atropine was indeed pattern ERG was normal or not, whether it had any problem or any effect on macula or not. And these are just slides on concentration of myopia. These are some of the other drugs which initially showed some interest, but not much of follow-up has been seen. Principine has shown initial effect on atropine, and 7-methylxanthine, especially from Scandinavian countries, 7-methylxanthine was used there, and that also showed some initial good results on controlling the progression of myopia, but there are not much follow-up studies on that. So thank you so much. Thank you again for giving me the opportunity to present on myopia progression and usage of atropine in myopia.
Thank you very much, sir. Thank you very much for those words of wisdom. And we would like to have the discussion towards the end of the session. Please hang on with us. So the next session will be next talk in this session. Is my screen visible?
Yes, ma'am, your screen is visible. Yeah.
Okay. We would go on to the next topic, that is optical methods and other factors which influence myopia progression and its control. So for this session, I would like to invite Dr. Rashmi Bhaskar, who is a senior consultant, pediatric ophthalmology and squint from Chaitanya Eye Hospital and Research Institute, Thiruvananthapuram. Dr. Rashmi Bhaskar did her MBBS from Medical College Trivandrum, DO from Calicut Medical College, and DNB from the prestigious RIO Trivandrum. And she did her fellowship in pediatric ophthalmology and squint from Shankar Nethralaya, Chennai. And she has various presentations and publications to her credit. I would invite Dr. Rashmi Bhaskar to deliver her talk on optical methods and other methods for progression of myopia. Over to you, Dr. Rashmi.
Thank you, Dr. Lakshmi. Am I audible?
Yes.
Yes.
Good evening. First of all, let me thank KSOS Scientific Committee, Kottayam Ophthalmic Club, Dr. Lakshmi and Dr. Soumya for giving me this opportunity. My topic is optical methods to control myopia progression. So we all know for the last 1 decade, we have been seeing an increasing in the number of myopic children throughout the world. I think this is one area where there are a lot of researches and experiments are going on. And along with the COVID-19, there was home confinement and digital classrooms. So we are expecting more and more children to be myopic. And as ophthalmologists, we are trying our best to do whatever possible to control the progression of myopia. These are the options available. I will be talking about the spectacle correction for the myopia control. The various spectacles that are available for the control of myopia is all this. We will be talking in detail about this. In 2002, actually, the myopia progression, people thought that undercorrecting myopia was a method to control the progression of myopia. So a study was done for this. They undercorrected myopia by 0.75 diopter, and for a duration of 2 years. After that, they found that instead of slowing the progression, it's actually worsened the myopia. So myopic eyes which are fully corrected are less prone to progression, and it was discarded. Then came the era of bifocals and multifocal lens for myopia control. The theory behind that was excessive near work will cause an accommodative dysfunction and hyperopic defocus, which will stimulate the axial elongation. So for by reducing the accommodation lag with plus lens, they thought the myopia can be controlled. A randomized clinical trial of progressive additional lenses versus single vision lens on the progression of myopia in children was done. And in this COMET study, 469 children were recruited at the age 6 to 11 years, and a progressive add of +2 diopter was given, and it was compared with the single vision lens for 3 years. They found that after 3 years, a small difference was there in the myopia control, but it was not clinically significant. Later, they did this continuation of this as in 118 children as a randomized trial for myopia low myopes, that is 0.5 to 3 diopters, with a progressive add of +2 versus single vision lens. And they selected children with large accommodative lag and near euphoria for children. In that, they found they had a 24% reduction in the myopic progression, but it was not widely recommended. The effect of bifocals and prismatic bifocal spectacles on the myopia progression in children, a 3-year study was done and in 135 children, and they found they used executive bifocal with a +1.5 diopter add. And for those with accommodative lag, they gave a 3 diopter based in prisms. At the end of 3 years, they found that bifocal slow progression with annual rate of progression of 0.5 diopters and prism bifocal were more effective with low lag of accommodation. And they found around 51% reduction in the myopia progression. Comparing the bifocal and multifocal with the other modalities of myopic control, they found only around 30 to 40% reduction, and it was not as effective as the other method. Then came the theory of peripheral plus lenses for the myopia control. So in this, they had a hyperopic defocus in the periphery, which was responsible for the axial length elongation. So the peripheral part of the lens was given a plus lens. So a special type of lens was given, and a study was done in 210 children, but after 1 year, they discarded it as it was not very effective. But the idea of this peripheral plus lens and peripheral hyperopic defocus led to a new innovations in the spectacle correction for the myopia progression. And thus came our DIMS glasses, that is defocus incorporated multiple segment glasses. It had a clear zone in the central of 9.4 millimeter, surrounded by a honeycomb area of +3.5 diopter lenses that was around 400 multiple segments of defocus surrounding the central clear zone. And usually when you give a single focus lens, what you see, the central focal point of the retina, the light is focused, but in the periphery, it is behind the eyeball. And this was thought to be responsible for the hyperopic defocus, was responsible for the axial length elongation. So in that DIMS glasses, what happens, because of the special designs of the lens, that hyperopic defocus is managed and the light is getting focused inside it. and this prevents the myopia progression. Only one study has been published regarding the dim spectacle glasses, that is in Hong Kong. It's a 2-year randomized clinical trial in 160 children. They compared with the single vision lens in age 8 to 13 years of myopia 1 to 5 diopters. After a duration of 2 years, they found that they had around 52% reduction in myopia progression with the dim glasses and almost 62% less axial length elongation. And daily wear of dim glasses significantly retarded myopia progression as well as axial length elongation. As a continuation of the 2-year DIM study, a 3rd-year follow-up was done, and which was very recently published in April 2022, that the children who were using DIMS continued to use it, and they found that it was myopia progression was controlled with the glass, and those who were using single vision glasses were switched to DIMS. They also show a control in the myopia progression. Another new glasses for myopia progression is HALT glasses or highly aspheric lenslet technology. Here they have a spherical front surface with 11 concentric rings of aspherical lenslet of diameter 1.1, creating a volume of myopic defocus. They have a 1-year clinical trial which is ongoing. 8 to 13 children in the of 8 to 13 years children in, of 161 over a duration of 1 year, and they found that there is a dose-dependent effect. Higher lens with asphericity have a greater myopia control, and full-time wearing HALT lens had a similar myopia control effect. After 1 year, there was a comparison between the DIMS and the HALT lenses. After 1 year, regarding the spherical equivalent, DIMS was little superior to the HALT lenses, while in case of axial length, it was almost similar. One more new glasses is available, that is the peripheral low contrast glasses. It was introduced by Niels based on an alternate theory that higher retinal contrast is another cause for the eye elongation. So they reduce the peripheral contrast of the glasses. That is a Cypress trial, which is an ongoing study, and the results we are waiting for it, and they have promising results for whatever that have done. Regarding the various spectacles and comparison about the myopia control efficiency, we can see that the undercorrected does not have any effect. The progressive lenses have around 20 to 30%, and executive bifocal with a near ad and with prisms at around 50, and the DIMS glasses have around 52% of the efficiency in controlling the progression of myopia. So what we have available with us is, if those with a near esophoria or an accommodation problem, they can have bifocal or a progressive glasses with basin prisms with a low accommodation lag. And DIMS is another option that can be given for those with atropine, where they are not non-responders, or for others if they don't want to put any drums. DIMS is an option available to us. For the last few months, we have available in all over the India. And in my personal experience, I have given to around 4 or 5 children for the last 2-3 months. None of them have any difficulty in adapting or any other vision-related problem. But how efficient it is, we have to wait and see, because we don't have much researches on this matter. And cost-wise also, it is not acceptable for all. But if we have an option, and if we have to wait and see how effective it will work in our children, that only time can prove. Along with the other factors, whatever methods we are using, whether it is atropine drops, whether spectacles, environmental factors play a very important role. Time spent outdoors and near work is most important among this. Among the outdoor activities, high illumination stimulate dopamine release, triggering photosensitive ganglion cell and dopaminergic pathway, and increased depth of focus will cause less peripheral hyperopic defocus. UV light exposure, all this emphasize the need that children should have a minimum of 2 hours of outdoor activities per day. Increasing the time outdoors at least 1 hour per day will reduce the risk of developing myopia by 45%. Likewise, reducing the near activity is also very important. More time spent on near activities associated with higher myopia prevalence. Maintaining a closer distance of less than 30 centimeter and continuous reading are all risk factors. So take frequent breaks in between. And more studies are coming on this matter regarding the digital smart device use, mobile use, and myopia. And smart device usage alone or in combination with other smartphones or computers are significantly associated with myopia. So in the future, we can see we have to use multiple modalities. In addition to the environmental factors, maybe a combination of the contact lenses with drops, or glasses with drops, or more researches will be needed in this matter to do whatever possible to control the progression of myopia. Thank you.
Thank you, Dr. Rashmi, for encapsulating that whole amount of information into your presentation. Thank you very much. So we'll move on to the last section of this session. I hope my screen is visible now. Am I audible?
Yes.
Yes, yes.
My screen visible? Yeah, thank you.
Yeah.
So the last session, last topic in this session would be a less talked about field in myopia progression. We thought of including this because orthokeratology is a concept which has been there in correction of myopia for many years. But this has also been implicated in controlling myopia. I would be touching upon the use of other contact lenses which are used in myopia control as well. So there are no financial interests. There are many types of contact lenses that has been used in myopia progression control, which includes bifocal, multifocal, soft contact lenses, RGP lenses, peripheral defocus contact lenses. And of this, orthokeratology lenses deserve a little bit more of importance because statistically it has proven to have a little bit of more effect in myopia progression and its control. So as already stated, the basis of myopia control strategies depend on the theories of myopia progression, and high lag of accommodation and a hyperopic retinal focus, defocus in the periphery are the most important mechanisms which have been stated and is the basis of all these strategies. And and all the principles of contact lenses used in the control of myopia boils down to the increased accommodation lag and the difference in the peripheral refraction compared to the central refraction. So these two are the main modalities used in contact lens control as well. So as already described, the peripheral hyperopic defocus that we get in a traditional correction is made into a peripheral myopic correction in an optimal correction. So that is the basis of orthokeratology lenses as well. So what is orthokeratology? Orthokeratology is a special type of lens. It has a base curve as well as a reverse curve, which causes a pull and flattens the corneal curvature, and it has alignment curves on the side. And this lens is typically fitted during the night time when the patient is sleeping. So this is the corneal curvature before the lens fitted. This is the orthokeratology lens fitted during the night time before going to sleep. And after the orthokeratology lens application overnight, the corneal curvature is changed like so. And the cornea is temporarily reshaped. And even after the lens removed the next day morning, this temporary reshaping of the cornea remains. So this correction, the optical correction, which is given for the contact lens, is based on the refractive correction of the patient. And this correction of the curve of the cornea would reduce the refractive error, and the patient can be off without the lens throughout the day. And even without a glass or a contact lens, they can walk around through the day and the contact lens will be worn during the night. So this was typically used for a myopia correction previously. The second question is, how does it control myopia? The same way as already described in the optical methods, the hyperopic defocus is shifted to a myopic refraction in the periphery, and the ortho-K changes that shape of the cornea, and the eye will no longer attempt to elongate because there is no hyperopic defocus in the periphery. The million-dollar question is whether it is an effective method. Orthokeratology lenses temporarily reduce myopia, we all know that. And the efficacy of orthokeratology lenses, unlike what is described for the other methods of myopia control, it has to be assessed on basis of the axial elongation only and not on the refractive error. The axial elongation is the only parameter or the primary outcome which should be assessed in assessing orthokeratology lenses. So is it effective? We have few studies, many studies to be in fact, but Romeo study and the CHARM study are one of the two of those randomized controlled trials that have been done. The Romeo study was done in younger children and the CHARM study was done in older children with higher myopia. And both the studies show significant slowing in the myopia progression of 43 and 63% respectively. And this is some point in favor of orthokeratology lenses. And this has been actually evidenced by the Cochrane review in 2020, which shows a moderate certainty of evidence. The orthokeratology lenses were compared with single vision lenses, and the forest plot clearly shows a favorable response to the ortho-K treated group based on the basis of these two studies. And the certainty of evidence is moderate according to the grade system. Another striking fact which was seen in the Romeo study was that in younger age groups, the control group showed a myopia progression of around 60%, whereas the ortho-K treated group showed a progression of only 20%. So a significant amount of reduction in myopia progression was noted in these two groups, especially in the younger age groups. So given all these factors, if it is so effective, what is the fact that is pulling us back from trying orthokeratology lenses, and why is it used only in certain select centers? From a logical point of view, microbial keratitis, because it is an overnight lens, is of major concern. Patient selection is very important, and most of the studies in orthokeratology are done in older age groups because younger population may not comply to usage of orthokeratology lenses. And more than that, lens centration and fitting is of utmost importance, and this may need repeated visits to the ophthalmologist and the optometrist before the patient can be sent off with an orthokeratology lens. So these are the factors which pull us back from using orthokeratology on a widespread basis. The other contact lenses, as Dr. Rashmi has mentioned in the optical methods, just like in the glasses, the principle behind the soft contact lenses and the defocus lenses are the same. They include either the accommodative lag addressed by near vision correction or by concentric rings of defocus, which will address the axial length elongation. So these are the basics of all the contact lenses that have been used till date. However, the bifocal soft contact lenses, rigid gas permeable lenses, spherical aberration lenses, all these lenses have been shown to be superior to their counterparts. But considering the level of evidence, it has low evidence rates to be suggested as a very good option of treatment in myopia progression. Yet there is a FDA approved contact lens called MySight 1-Day, which is being used in many countries, which shows promising results of the rate of 52% reduction in the axial length elongation. And it has the same basis as the other optical methods. It produces a peripheral hyperopic defocus is reduced, and they have treatment zones creating myopic defocus. So this is the basis for MySight contact lenses. So what is the advantage of MySight over Ortho-K? Ortho-K, as mentioned, it needs initial multiple visits, whereas MySight is a daily disposable lens, which corrects, but the problem is MySight has a lesser range of refractive correction, whereas orthokeratology lenses have a little bit higher range of refractive correction. And the single daily disposable type of lenses actually rules out that infection factor as well. So taking all these points into consideration, myopia progression is not a single factor dependent problem. It is actually a multifactorial issue. So treatments for controlling myopia progression may not be easy as tackling a single problem. So no single blanket treatment might be of help in myopia progression control. So customization of myopia control based on different factors like the accommodative lag and the peripheral refraction might help in assessing the type of control method that has to be employed in each patient. So etiology-based intervention studies might be the direction to look forward to. So we need to have more studies on that basis to assess these factors. Thank you.
Yes.
So for discussion.
Yeah, open to discussion. Yeah. Now, our speakers have been excellent. Now, I'll tell my opinion. I'll just summarize almost like that because, as Lakshmi had pointed out, it should be a multi-pronged attack on the myopia. So, what I suggest is a primary suggestion will be mine is to start the patient on a 0.01% atropine at night. 2 hours of sun exposure, I tell them very specifically, and the Australian recommendation is actually 4 hours, which is not possible here. All our children will fail in the exams if you ask for 2 hours of 4 hours of sun exposure. So I tell them 2 hours of sun exposure and adequately controlled myopia with glasses. Of course, so these three things are mandatory. But if you have facilities, of course, you can go for the DIMS or the PAL or the orthokeratology lenses. But there's one, so I usually aim at bringing down the myopia to, there are people with small myopia, higher myopia. So I tell them my aim is to bring down the final myopic power at the age of 21 to less than 3.5. So that will be LASIK treatable because that's the simplest way you can correct the myopia. Otherwise, you'll have to resort to ICL and so many complicated procedures. So my aim is to bring down the myopia to minus 3.5. There's one good research field still left here. That is a dopamine and its analogs, because that is supposed to be an important hormone in preventing scleral expansion. So I even asked a few of the neurologists and pediatricians, how can you start dopamine in a neurologically normal patient? That was their, but I read a few articles, but the others can also join in. So my opinion is ultimately to bring down to less than 3.5, what will be the myopia? If it's a minus 6, you try to bring it down to 3.5, the progression, but very difficult. But now, as from Jethani's talk, I think I will start a BID dose of 0.01% if it is not responding well. That is my take.
Thank you so much, sir.
My question to Jethani, sir. Sir, in your study for all pseudophakic cataract patients, so in your study, how did you feel like you use the low dose? From what age group do you start in these children low dose atropine? In your experience, how did you find it, and from which age group did you start? All like how it was in the 6-year age cataract or in the later age groups?
So you're asking about the post-pediatric cataract patients, right?
Yes. Yes.
So post-pediatric cataract patients, some of the children were as low as 4 years. So till 4 years, we were waiting for their physiological growth. And once we saw that, their growth was, they had already finished off whatever we had done hyperopic correction. They had already gone on the myopic side. So the minimum age in that particular small subset was 4 years. And we also had put drops in children who were 7 years also. So there are a subset of patients who keep on, have myopic progression despite the fact that they are well out of 4 or 5 years of age. So that was for post-pediatric cataract patients.
Wonderful points to ponder, Dr. Jethani. You have covered a lot of areas where you have to think about. Accommodation definitely has been found not the mechanism. And it has been found also that where outdoor activities have been increased, the effect of low dose atropine is not as much as those are not having outdoor activities. Again, pointing to the effect of sun and the effect of light on dopamine receptors and the retina. That this combination, of course, does work, but effect of atropine and other methods do not as effectively reduce the progression of myopia. So a lot of things to think about. And of course, as Dr. Mahadevan, one of the first persons to take up this prevention of myopia in Kerala with a lot of activities and in KSOS. As he said, one of the things which we can, it's not easy to convince people why we would prevent progression in especially when we are recruiting for some study. So as Dr. Mahadev sir was saying that we can tell them that at least we can do your treatment after you adulthood, at least by LASIK, rather than progressing to high myopia or beyond 6 or 3.5 will be a next, I don't know, big dream. So
you aim at that and you'll get down to 4.5. LASIKable power.
But of course, when parents come after doing LASIK and then their children are myopic, then we have to closely watch them. And I think we have to adopt all these measures, and we have to highlight the importance of starting. This awareness should be created. I feel there are quite a number of people who come with I think Dr. Jethani has personal experience on these matters with all the doses which he has reconstituted himself even by way back before the low dose atropine came into market. So, right?
I think, ma'am, I think one of the most important group are pre-myopes, because my older son was a myope and I was a myope, and I always looked after the second kid because I knew he would be a myope. So such children, when we do refraction of these children very early, like 3 years, 3.5 years, and they are like zero emmetropic with an axial length of around 22.5, and we know that these would be the patients who would trip towards myopia. I think those are a good subgroup of patients where myopia treatment should be initiated early, because that is the whole purpose of controlling myopic progression, so that we can start early in these patients. We can document their axial length for a couple of visits for a year. And once we see that, they are actually progressing, we can start the treatment in these patients, even if they are like -0.5 or very minimal myopia or not even myopic. And these all patients classically start at around +2, and they go to 0. These pre-myopes, there's a very small subset of patients, and I think that would be very, very helpful.
I think that is what they are looking at in ATOM 3, isn't it? The small minimal hypermetropes and which we consider as pre-myopes for age 3. Yes. So,
yeah, that's what I also do. The moment you find the pre-myopes or mild myopia at the age of 3-4, I start the treatment, because that is where the control should be done, so that they don't go beyond a huge number by the age of 15, 17. Then it becomes irreversible.
No, there's some the post cataract surgery people who in which you studied atropine drops. Was there any relation with the undercorrection, the amount of undercorrection done while implanting the lens and the myopia progression? Was there any correlation or?
So what we do for undercorrection is that we use a very standard formula. So there was no, we had not undercorrected them any differently than we did other patients. The only thing was that these patients were we have a normative data for our own patients as to what is the normal axial length for a certain age group, and all these patients were slightly more myopic, and that is one of the reasons we also came up with a correction formula for undercorrecting children under 2 years of age, saying that normally when we undercorrect in these pediatric cataracts, we undercorrect by percentage, and we should stop undercorrecting by percentage, because when you undercorrect by percentage, you actually undercorrect more in hypermetropes and less in myopes, whereas we should be undercorrecting more in myopes and less in hypermetropes. So we should take up axial length as another independent factor apart from the age that we normally take. So these were also some of these patients were also from the same study which we had presented in 2012 on undercorrection with regards to axial length.
Okay.
I've not tried aphakic myopes. I've never tried in those age groups, only simple myopia. And have you tried in ROP or preterm babies?
So we had tried them as a last resort, but most of the ROPs actually do not progress much. They are like already -8, or I mean, they are already very high myopes. So we have not, and we personally have not got good results. And already ATOM study said that it won't be working. So maybe our attempt was also half-hearted, because at the back of the mind we knew that these are not, it is not going to work in them. So we did not indulge them. I mean, we did not take them up in our trial because they were all straightforward simple myopia patients.
Yeah. Question to Dr. Rashmi. Dr. Rashmi, which is the minimum age which you have started giving the DIMS glasses?
I have given only about 10 years actually. Below that, I have not given, because I gave them always the option of atropine and DIMS glasses. So whichever the parents use, only that, and I convince them and tell them that it's only newly available, so we are not very sure. Only to 50 to 60% efficiency we can promise, and only when the parents are willing for that, I have given. Then that too about
we along with DIMS, do you prescribe atropine drops also?
No, I haven't.
Yes.
Yeah, only DIMS.
It costs about 40,000 rupees, isn't it?
Yeah.
No, 15,000.
15,000.
15,000. Yeah, 15,000.
For a pair, it is 15,000. We have started DIMS in almost 15 patients, but all of them are almost 10 of them are non-responders to atropine, and 5 of them are responding to atropine, but their control is not very good. So we have most of our DIMS patients have already used atropine, and they are still on atropine with DIMS.
With DIMS, oh, right.
We use both of them together.
So will that small pupillary dilatation will affect that central ligament? That's what I was little reluctant to start along with it.
No, it won't affect, because their central is 9 millimeters.
Yeah.
They have a 9 millimeter zone. So yes, I don't think it is going to affect at all.
So a few of our patients in the first 2 years, whom we were giving atropine, in the first 2 years, they had very good response. Yes. But after that, maybe we are not sure because of the lockdown and online classes or not. But after that, they have shown a progression. Then I have switched to twice daily doses. So you have any experience like that? Initially, they had a
no, a lot of patients. See, the problem is that some of the patients, that is the whole problem. I mean, maybe it becomes concentration dependent. Maybe once we stop them, there is a rebound in low concentration atropine. So that is, I mean, some of the patients, so we take it per patient to patient basis. Like if the patient, so we are also using 0.05%. If the patient is showing a greater response, even after putting 0.1, or once we stopped 0.1 has a rebound, we put them on 0.05%.
Oh, but then with the 0.05, you have to give bifocals or no?
No, at 0.05, they do not. I mean, the bifocals is not needed. They are happy with that. But yes, I think around 10 to 12% of patients did complain that they had a near vision problem, and we gave them bifocals. As such, also we do give bifocals if they do not respond to atropine, and if they don't have money for DIMS, we give them bifocals.
After checking the accommodation lag only, or
accommodative lag we check in all the patients.
Yeah, invariably you give to all non-responders.
But we measure the accommodative lag just to see whether it is working in which patient it is working, whether it is working in accommodative lag, higher accommodative lag or lower accommodative lag. So
I don't know how all of you feel. Of course, there is a large surge in the acute acquired esotropia in during this COVID time. But I have been seeing a lot of esophoria and esotropia in myopes during this period. Have you noticed that? I don't know.
Most of us, I think we have lot of patients of esophoria. But my question is always that if we see so many esophoria patients, why our exophoria patients are not improving? I mean, reverse should also be true, but it's not like that. In fact, exophoria patients are also worsening. I mean, esophoria patients are coming because of lot of convergence, but exophoria patients are not improving. There's some brain mechanism which prevents exophoria patients from improving.
So one question about that post-cataract. But
Yes.
I heard that after the cataract surgery, the eyeball growth actually doesn't progress that much as the normal patient. So is it true that myopia is a big factor there? There's a big danger, risk there?
I think
I
it's
heard that
variable.
after the cataract surgery,
There's a lot of controversy on pseudophakic and aphakic eyes. Some studies say aphakic eyes grow longer. Some studies otherwise also, so it's not proven yet completely.
Yeah, once the eye is inserted with surgery, it doesn't progress. Yeah, that's what I heard now. Grow.
Yeah, not conclusive.
Not conclusive.
Jitendra, do you have any experience with ortho-K lenses?
None, I think.
No, I don't have any personal experience in ortho-K lenses. JJ sir, you have any experience?
I have 2 patients on ortho-K lenses. So see, the problem with ortho-K lenses is, and that is an advantage also. I was going to say that, but I thought maybe we are not much into ortho-K. So the advantage of ortho-K is that even if your power increases by 0.5 diopters, you don't have to change the ortho-K lens because your flatter K would still remain the same. Whereas if you're using a DIMS lens or a HALT or a SLET myofocus, with every 0.5 increase, you have to change the glass, and those glasses are from 15,000 to 25,000. So that is one small advantage optically, ortho-K. The problem obviously is that we all, as pediatric ophthalmologists, we are very much, afraid of infections. But if DIMS is working, ortho-K would work. I mean, technically both are absolutely on the same principle and on the same ground. The only advantage of ortho-K is that child is not wearing glasses, so he behaves more like an e-metro. The only problem is that infection is a huge worry. So it is always at the back of our mind because we are in Indian conditions. We're always worried about hygiene and a lot of stress on pediatric ophthalmology. If there is a problem, we have created a problem in a healthy eye. So that, I mean, that always is there in the back of the mind. Cost, of course, is a big issue. There's no doubt about it. Ortho-K lenses are also very expensive.
Jethani sir, I have a question.
Yes, Rajesh, how are you?
And fine, thank you, sir. And pre-myopes, like when you start so early in the pre-myopes, what is the cutoff age you have when you think about stopping and just reassessing?
No.
Or do you want to continue till the age of 8 or 10?
I do continue it, or if I stop, I stop it by tapering it, and we are very cautious in the rebounds, whether it is very quick in rebound or not. But I do not start very early in pre-myopes. All the pre-myopes, we do have a follow-up, axial length elongation is there or not. So pre-myopes, as the name may suggest, pre-myope means we are starting early. We do not start before 4. It is not possible to start before 4 years because you don't have axial length data. So we need to establish that this is an axial elongation. Without proving that it is an axial elongation, we cannot start local suspension atropine. It may be something else. So and children don't cooperate under a 3-year-old will not cooperate for measurement of axial length. So all the pre-myopes which we did were definitely 3.5, 4.5 years of age, in which we had a data that it was actually progressing. Otherwise, you cannot start.
There is one question from a YouTube viewer, Dr. Smita. She has asked how to do the peripheral refraction. Can it be done using streak retinoscope?
So you can do peripheral refraction doing a streak retinoscope, but you don't know how much periphery you are doing. So the only good way of doing it is with an open field refractor, which has a transparent screen where you can tell the patient where to fix and you can do it. So there's a separate auto refractor which comes for that. The cost is around 8.59 lakhs. I don't have it. So if anybody is doing from the panel, please chip in.
Yeah, we are trying to get it actually for the documentation also. For accommodation lag measurement, it will be easier rather than subjective one. Yeah, so it's coming, but I think SN has it, isn't it?
SN has, LVP has.
And out of the topic, because many of our viewers or many of the practitioners are working in a periphery where the easy accessibility to the pediatric ophthalmologist may not be available, or where even the patients are sometimes reluctant to go to the travel far away. So any common tips we can give to the this group of the doctors who are practicing in periphery, so that how they should what all things they should communicate with their patients to hold the progression of the myopia, any modification in their lifestyle of the kids or anything.
I think first and foremost, we see a lot of prescriptions of atropine being given for astigmatism and other conditions as well.
Yeah, that is
so
what, yeah,
that
because
need to be curtailed, and this is purely for axial elongation as well as documented progression. So without that, starting atropine drops is not required. And the second thing is cycloplegic refraction in children is of utmost importance. Even if we are in the periphery, we can do that with a streak retinoscope. Cycloplegic refraction is possible. So we see many kids being prescribed myopic glasses, especially with this onset of near vision activity. We see a lot of pseudomyopias being corrected with glasses. And while doing a cycloplegic refraction, they might end up with a plus refraction sometimes. So cycloplegic refraction is also a must in children while prescribing, especially for the first time and while documenting progression. So any other tips, Laila madam?
Yeah, I think even in the periphery, all these things can be done, and counseling is very important, and follow-up. These can be done. Definitely patient can be followed up whether myopia is progressing or not. Of course, the axial length may be something which in a clinic, in a just an OP clinic where the institution is other than the institution, axial length measurement may be difficult, and some of the other things I think can be done. And follow-up of spherical equivalent is not a difficult problem. So if it is possible, all the parameters of biometry is better followed up if you start. When you start atropine, then we would like to know what is happening also. So that will be a good idea. But of course, the environmental factors, near work breaks, and all these things can be counseled. Counseling is very important before starting atropine. The parents and parents should be well educated before starting atropine. And I think, yes, that is for these two school-going children, where follow-up is also very important. I have had children who are using atropine for a very long time, and I've seen no progression also, but they don't come for follow-up of measurements. Of course, they've been using glasses for a very long time. They check only once a year or probably longer interval. So asking them to come more frequently, sometimes they don't adhere to.
In this context, I just wanted to add a comment. I think most of the, there's no definite guidelines that who has to prescribe atropine for the children. So is it only the pediatric ophthalmologist, or anybody else also can prescribe? Because I have seen even optoms prescribing atropine. Very rarely I have seen one of the pediatrician prescribing atropine for his kid. So that is the reason why there are not enough follow-ups from the patient side. I have seen retina consultant, cornea consultant, glaucoma consultant, all of them starting atropine for their patients. So is it like acceptable, or any guidelines that who has to prescribe the atropine?
On 15th,
if they
there is going to
satisfy
be
all
a
the
general consensus coming up on May 15th. They are going to come up with the consensus as to how to go about it, right, Dr. Sumita?
Yes. Yeah, and then it's free for all. Once the guidelines are out, you cannot blame a cornea consultant from prescribing.
No, atropine is at least safer, madam, but orthokeratology, if it is going to be handled by optometricians, I mean optometrists and others, like
They are
it's
better than us in fitting contact lenses.
Yeah, I think optometrists are the ones who are promoting orthokeratology now rather than the ophthalmologists.
yes,
From what I have seen.
Yes. Yeah.
You will be dealing with infections and adverse events, not the fitting. Yeah,
Okay.
or when the glasses have to be changed, then they will come to you. Yeah, how can 15 days?
Hello, sir. Pradeep Sharma, sir. Good evening, sir.
Evening, good evening.
Good evening, sir.
Interesting talk.
So if there are no more questions in this session, I think they can move on with the next session on myopia. Over to you, Dr. Dhrumil.
Yeah, thank you, Dr. Lakshmi, for chairing this session, and thank you all the speakers and panel members to making it fruitful for everyone. Now, I would like to invite Dr. Haripriya to carry forward the CME ahead. Dr. Haripriya, over to you.
Now, let us move on to our next session, which is on strabismus, a topic which resident ophthalmologists seldom have a thorough knowledge, but is often encountered by all practicing ophthalmologists. So let us hear more about it, of course, from the legends. For this, let me invite Dr. Satish Thomas, Professor and HOD at Believers Church Medical College Hospital, Tiruvalla. He did his MBBS from Kottayam Medical College and completed his MS from AIIMS, New Delhi. He did his fellowship on pediatric ophthalmology and strabismus from Shankara Netralaya, Chennai. I welcome you, sir, to chair the session.
Dr. Satish was here. I can't see him now.
Yes, ma'am, he was there a while ago.
Yeah. Might join back.
It's running a little ahead of time, that's why. Very
Uh,
rare.
Dhrumil, can you just give sir a call?
Sorry for the trouble. He just got logged out because of the technical issue. He's logging in back. Just give me 1 minute. Yeah. Hello. Hello. Yes, sir. I called him because of some technical issue. He got logged out. He's just trying to get in back.
Hello.
Yeah.
Am I audible?
Yes, yeah, sir. You are audible and clear, sir. Yeah, please.
Okay. Is it time for me to start? Sorry, I had got logged out.
Yes, sir. Yes, sir. Please go ahead. Go ahead, sir.
Okay. Yeah. Okay. Yeah, I'm sorry for the glitch. Welcome all of you to this session on strabismus in our pediatric ophthalmology webinar. So we'll begin with the keynote address by Dr. Pradeep Sharma. There is absolutely no need for me to introduce him, but I have to do that formally. So we all know him as the former professor and head of the Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology Department at RP Center, AIMS. He was my teacher and my introduction and inspiration to this subspecialty. He is currently the Director of Strabismus and Pediatric Ophthalmology at Center for Sight in New Delhi. There are lots of achievements and accomplishments which will take me a lot of time to list out. So I will not do that. Maybe I can just mention a couple of them. He was the first Asian to deliver the NAP lecture by American Academy of Pediatric Ophthalmology and Strabismus in Vancouver in 2016. And he was presented with the Achievement Award by the American Academy of Ophthalmology in 2017. He is the current president of SPOCI. And just the last week, he was awarded with the prestigious Dr. Baldev Singh Oration for Neurosciences by the National Academy of Medical Sciences for his work on childhood nystagmus. So it's a privilege and honor for me to invite you to deliver the keynote address.
Can I share the screen? Thank you, Dr. Satish. Am I audible?
Yes, sir.
Yes, sir. Yeah. So it's really always a pleasure to be with people from Kerala, as I always feel especially honored to be with you all. The first book I had launched in 1999 in Kerala, The Strabismus Simplified. So it's always going back to the roots, so I feel good. This is not getting started. Yeah. So is it clear? Is the presentation visible?
Yes, sir.
Yeah. So today I'll be talking on the pearls and perils in strabismus regarding diagnosis and management. And as I always like to say, the new goalpost for ophthalmologists is changed. It is not just Vision 2020 or 6x3 or even near J1 vision in each eye, but also to achieve good stereopsis with good fusion. And that is why the role of strabismus and pediatric ophthalmologists becomes huge, because we are not just treating strabismus, but we are restoring binocular vision and stereopsis. So the strabismus surgery is no more a cosmetic surgery only for improving personality or diplopia correction, but for restoring binocular vision and stereopsis. And that is why there is a role for early alignment. And here the two words to be noted are early and alignment. It's not just early surgery, mind you, it is early alignment that we are talking of. And this case history of this child who is born to be as a newborn with straight eyes, turns in at 3 months of age, esotropic, and then his father, who is the famous Kenneth Wright, does the refraction, proper cycloplegic refraction, gives him full correction at 6 months, and still finds that the child is esotropic on the Bruckner's reflex. So he does the surgery at 6 months of age, aligns the eyes early enough as we want, and restores stereopsis in this child. And this could be the story of each and every child of our country too. The critical periods we need to remember is just like the rule of cricket. The 4s and 6s are what we want to remember. For congenital cataract, we all know 4 to 6 weeks is the period to monitor and check any cataract and correct that by about 6 weeks onwards. 4 to 6 months, we should look for any infantile esotropia and correct it by the first year of life. And 4 to 6 years for any other problem like an intermittent exotropia, even if it is intermittent, nystagmus, refractive error, all should be corrected by 6 years of age. And if it is a constant manifest exotropia, then even earlier. Like this child at the age of 1 year, he has a constant exotropia, even this needs to be corrected early enough. So when we talk of strabismus, is it a spot diagnosis, spot management? sort of thing? No. We have to be very consistent in our learning. And I generally try to talk of a 5-pronged approach. The recipe in strabismus, I say, is OCIPE: observation, confirmation, inference, planning, and execution. So these are the 5 prongs which can yield happiness to each and every child. The first and foremost is having a very good observation to look for any strabismus, but there can be appearances which are deceptive. There may be pseudostrabismus, like this top figure shows you a child appearing to have an esotropia because of a telecanthus and epicanthus. The middle picture is showing you a pseudo-esotropia. Again, it's not a true esotropia, mind you, because of large palpebral apertures, the eyes are appearing to be esotropic. And in the third bottom picture, you see a pseudo-exotropia. So all these are not true squints. And how do we differentiate a pseudo from a true? By a simple cover test. So the second strategy is confirm. And we can do it by doing just a cover test, and we can know. The third thing is we have to then look for the cause behind it. And an age-appropriate cycloplegic refraction needs to be done in each and every child. And I always keep on stressing that for Indians, we are black pigmented irises. And so a simple cycloplegia may not be enough. We need to have atropine till about 5 years of age for any esotrope. And then we should prescribe it. A proper prescription. But the next step is it a compliant child? Is he wearing his glasses? Many a times we have failed. We think whatever is left over is a non-accommodative element, and we operate and we have a problem. So we need to look for, after the correction with the glasses, what is the residual ESO deviation. And if we see, like in this child, there is an ESO deviation for distance fixation. Mind you, here we are making the child fixate for distance, and we see that there is a esotropia in the left eye. If we are looking for a convergence axis, we should be looking with an accommodative target for near. So both are different and both will be dealt with differently. So a child may be having an uncorrected refractive error. He can have 2 paths. One is that if he is the kind who wants to see clear, he will accommodate and he will have an accommodative esotropia and may develop an accommodative esotropic amblyopia. On the other hand, a child may be a lazy kind, not very bothersome about accommodating. He will have both the eyes straight, but he will develop a bilateral ametropic amblyopia. So mind you, the same situation can give rise to 2 different reactions in 2 different kids. So when we have kids, again, we need to measure the squint. It's in very small kids that we can't do the prism bar cover test, then we can go by the Hirschbergs, but otherwise make your efforts to find out on the basis of prisms, because that is the real measurement, and that we should do by a prism bar cover test. When we use prisms, when we have loose prisms particularly, we shouldn't stack prisms one over the other. The simple logic is 2 plus 2 is not 4. It is actually 5, especially in cases of prisms, like the Hindi movie, Do or Do Panch. So we have to be careful about this. And especially when children are having correcting glasses, which may be high plus or high minus, this also will deviate or change your deviations. So error is significant for more than 20 prism diopters of deviations for more than 5 diopter power of the aphakic glasses, or a minus 5 diopter for minus glasses. So we need to always confirm and look into the tables to find out what is the corrected measurement of the PBCT. This would be changed by even 10 to 15 prism diopters for larger deviations. Now this girl you see here is having straight eyes, but actually whenever she's wearing her old glasses, she was appearing to have an esotropia. And what we found was there was an induced prismatic effect because of decentered glasses. So even people who have straight eyes may appear to have esotropia because of an induced prisms, and we should always look for centration of the glasses. The IPD may be faulty, and if that is alone corrected, the eyes become straight. So when we have to infer our problem, we will look into this, that the 2 eyes are having a play of 12 extraocular muscles in the 9 houses that we are going to look for, the 9 gazes. Just like our zodiac sign that we talk about, 12 houses and 9 planets, here it's a little change. We have 9 houses and 12 extraocular muscles, creating a problem. And we have to look for all the 9 gazes and see what is happening in these different gazes. Like this individual having a post-traumatic third nerve palsy is, you can see there is an exotropia which is changing in different deviations. In down gaze, the exotropia is gone. In up gaze, it is becoming more. But you will also see that there is a hypertropia of adducting eye in each case. And this is because of a bilateral inferior oblique overaction. So we'll talk about this, but we can just look into the fundus and we will see that there is a extorsion. When do we say there is an extorsion? Like in this picture on the left side, you see the fovea lies below the line passing through the lower pole of the disc. Any fovea should normally lie between the lower pole and the line joining the upper 2/3 and lower 1/3. The other picture is showing you an intorsion because the fovea is located above the line joining the upper 2/3 and lower 1/3. So there is an extorsion in the left and the intorsion in the right picture. And these can be again corrected by surgery. We can also look into the indirect ophthalmoscopy and the fundus pictures and measure it with the help of protractors. How much is the deviation? We can also observe the torsion with the help of the fields that we have, if they have properly been done. And in this case, you can see there is an extorsion of 15 degrees because the blind spot is far below the horizontal line. We can, of course, measure with the help of the diplopia charting, the Lancaster red-green chart, and the most dependable, the double Maddox rod, which is shown to you on the right side. And even the Bagolini loose glasses can be used. Synoptophore and Polaroid stereo projector can also be used. Coming to stereopsis, which is the hallmark of our science of strabismus, remember each eye is seeing the two things little differently. And these disparities are within Panam's areas of fusional limits, which are able to be fused, and these give rise to a 3D effect or stereopsis. We can assess the stereopsis with the help of the Rendot with the Polaroid glasses, or the more dependable one, according to me, is the TNO test with the red and green glasses. For distance, people may have Frisbee-Davis distance like we had in Ames, or the simple one that we usually use on the bedside is the modified Lang's 2-pencil test, which each one of you should learn. It is a very simple thing. You just need to play with the child. And if the eyes are in alignment and the eyes are both okay to see, the child will be able to match the tip of your pencil with the other pencil that he is holding. Mind you, it is not the two hands of the child holding the pencils, but one pencil is in your hand and the other is in the child's hand. And this is a very simple Lang's 2-pencil test, which judges gross stereopsis of about 2,400 seconds of art. We come to then planning and execution. The non-surgical approach depends on the proper refraction and proper prescription, as we talked about. Accommodative esotropias and partially accommodative esotropias would be managed, but even exotropes would be properly managed if they have been properly corrected. Any associated amblyopia needs to be treated. Orthoptic exercises may be the only thing required for more number of people who have convergence insufficiency alone. And then for small angle deviations, prism neutralization may be done. Finally, surgery may be required for people who cannot be corrected by non-surgical methods. This child is showing you use of the Fresnel prisms. Anything which is more than 14 prisms cannot be grounded easily on the grounded prisms, and we use the Fresnel prisms to correct an ESO or exotropia which is present in the child. Any associated amblyopia needs to be treated, and all of you know that the occlusion is the sheet anchor treatment for amblyopia therapy. A good compliant occlusion works at any age, but best before 6 years of age. And we have used even the penalization with the help of atropine in children who are not cooperative for occlusion at all, or we have used levodopa in the cases which are refractory to amblyopia therapy by occlusion. The occlusion schedule that we normally follow may be the dominant eye versus amblyopic eye, 2:1 as per the age up to 6 years of age, or we may use the part-time occlusion of 6 hours per day of the dominant eye, and then on the maintenance we can go to 2 hours of occlusion of the dominant eye. Remember, the concept of occlusion hours is really there. 120 occlusion hours has been shown to be showing an improvement of 1 logMAR improvement in visual acuity as per the studies of Motas and by Stewart in 2004. So if you are compromising on the occlusion schedule, you are also prolonging the amblyopia therapy. So changing times have yielded active vision exercises with the help of monocular video games, and we have found they do help in occlusion therapy. And even the binocular vision stimulation is the new paradigm to treat amblyopia, as jokingly said, iPads to iPads. So we do let the children play with iPads, provided there are binocular vision games which are played on them. And we have found that works very well for anisometropic amblyopes, but still better for maintaining stereopsis compared to occlusion. Even adults can be improved by occlusion therapy by the dichoptic custom-made action video games. When we are dealing with children, we need to observe the fixation preference. And look, the child is looking on the left picture with his right eye in adduction. And when we cover the right eye, he shifts the eye to the left side in adduction. Now, this indicates both the eyes have good equal vision, and he may have an adduction preference, which may be because of an adduction null, or it may be a cross fixation. So when we look the child in different gazes, we'll get more information. Now, when we look up and down, as we saw in the picture, the exotropia may vary. Here, it's an orthotropia in primary position, which becomes more in up gaze and eso in the down gaze. And when we look on the side gazes, we can see there is an inferior oblique overaction in each eye. So our surgery would be to correct the inferior oblique overaction by recessing the inferior obliques, and no horizontal muscle surgery, and that yields the desired results. Similarly, a V exotropia with an inferior oblique overaction in this case is indicating the role of both LR recessions and the inferior oblique weakening. But some cases of V patterns may not have inferior oblique overaction. These cases, you do not have to weaken the inferior obliques. These are because of a displaced LR pulleys, which is causing the V pattern, and these need to be shifted up and down. So that is what is done. Similarly, for the superior oblique overaction, an A pattern needs to be managed. And this is again because of the shifted pulleys if there is no superior oblique overaction. So we do the shifting of the horizontal muscles vertically by half muscle width to correct the associated V or A pattern if there is no associated oblique overactions. Even when there is an associated oblique overaction, when the V or A patterns are more than 30 prisms, we may add the vertical shifting along with the oblique weakness. Coming to the weakening procedures, the standard, of course, are the recession, which may be the conventional recession, or sometimes we may do an adjustable surgery when we are having more exacting situations. We may do a posterior fixation suture to add to the effect of weakening. We may also add on a marginal myotomy in re-surgeries when there is no more recession possible. On the other hand, strengthening procedures are the resection of a muscle, advancement, especially in cases of re-surgeries when the earlier surgery was recession, or we can have the plication, which is the newer strengthening procedure of choice. We may have the nomograms to follow, and you can start with these and change as per your own surgical strategies. The safe limits that we have to follow are lesser in children, and in infants and neonates, it may be as less as 5 millimeters, and we should go by the measurement from the limbus. And similarly, for lateral rectus, the upper limit may be just about 6 millimeters for a neonate or a 6 months old child. This is showing you a small video clip to emphasize the important steps on surgery, showing you an LR recession. The fornix incision is the newer incision technique that we do. And now the Jamieson's hook is inserted, hugging against the sclera. And then neatly the conjunctiva is unroofed, and we bring the muscle in our surgical field. Now it's important to do the intermuscular septum incision properly. We don't want to incise unless we have seen the pole. And this is the two-hook pole test described by Kenneth Wright, the pole test, which shows that, yes, we have hooked the full width of the muscle. The sheath should not be disturbed. The check ligament should be cut under direct view so that we don't have bleeding of the muscle. And then the 6-0 vicryl sutures are placed. One in the center knot is passed, and 2 interlocking bites are taken on the 2 ends of the muscle width. Full muscle width is now bridled with our suture of 6-0 vicryl, and then the disinsertion, leaving a 0.5 millimeter stump is left. And you may do a light cautery for this bleeding points. Whenever we are holding the muscle end, we are going to distort it by 1 or 1.5 millimeters. So never use the same point which has been held for marking. Like we are holding it from the middle, then you use the poles for marking for your prepared thing, and this should be perpendicular to the insertion. Then the needles are passed, spatulated needles, under direct view so that we don't perforate. And this is extra careful for myopes because the sclera is very, very thin. And the width should be ensured to be about 7 to 8 millimeters minimum between the two bites that we are taking. Then we can tighten these two ends. In small children, less than 2 years, I prefer to make two separate knots and separate bites so that they may rub it and not cause a slippage. The plication is the newer procedure that we talk about. And here the advantage is there is no disinsertion. So there is no risk of slippage of the muscle. There is no risk of anterior segment ischemia, and it can be easily undone in the first week. Here the muscle is being hooked just like what you saw earlier. And the conjunctiva is brought separately. And then we see the full width of the muscle. The check ligaments are cut, intermuscular septum is cut. And now we mark it just like we do for resection. And the 6-0 Weichel sutures are passed, interlocking bites, two separate interlocking bites at two ends. Mind you, whenever we have a muscle being strengthened, it will be made more taut. So it will be under more tension. So you should have extra bites in the muscle so that there is less chances of slippage. And once this is done, here compared to resection, we are not going to resect the initial part, but we take bites in front of the sclera and then like a figure of 8 back into the muscle. The muscle, sclera and muscle bites are taken. So this will form a figure of 8. Iris repository is placed in between and the muscle is folded on itself, tightening the sutures. This lump which is left in the first 2 or 3 weeks is visible, but gradually it will disappear and it will cause less inflammation than even a resection. The conjunctiva is then closed. So adjustable surgery is another technique which we all should be aware when we deal with more exacting situations, more demanding situations. Compared to the oblique muscles, we should be having a no myectomy approach. And I prefer to do a weakening of inferior oblique by recession or anterior positioning for all my inferior oblique overactions. It may be either a pure recession or it may be an anterior positioning by Elliott and Nankin's method, or it may be an anterior nasal transposition, which can be correcting even a 3+ or 4+ inferior oblique overaction. A divergence excess exo or a like situation may be there. So near distance disparity may be another thing that we have to take care of in some cases. And this can be done by doing another type of procedure that is a combined resection recession. The combo resection recession of the same muscle or the spot procedure. And this helps correcting the excess exo that we are getting on the side gazes. Finally, I would like to come to the end of my talk. The role of imaging in special strabismus is there. We can do a dynamic imaging on the MRI in different gazes and actually confirm the overactions of different muscles. Like in this case, there is a synergistic divergence of both lateral recti, and there is an innervational downshoot. That means the inferior rectus is contracting during adduction. Now, if that is so, you may do a different procedure. Like in this case, you can use the inferior rectus to increase the adduction in such a situation. To conclude, the goal is not just 20/20 vision or 6/3 vision, but as I said earlier, it is to treat restoring sight in stereopsis. We have to be squintellectuals. Each case is going to be a challenge and it is little different than another one. We need to look into it so that we can restore the sight, stereopsis, and alignment in the child. So we can spread the sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. Thank you very much for listening. I thank my family, all my colleagues who have been making a part in my evolution as a strabismologist. Thank you all.
Thank you, sir. That was a wonderful presentation. Actually, covered the whole gamut of strabismus in such a short time. Very comprehensive and yet clear. So since I was rushing into the session, I'll just explain how we plan to do it. So we've listened to the keynote address by sir, in which he's covered the whole scope, and we would have really understood the importance of binocular single vision and stereopsis. Now, in the next two talks, we will cover probably the two most common strabismus conditions that will be encountered by most of you. And after that, we'll have the panel discussion. And just before the panel discussion, I'll introduce the panelists. So our next talk is by Dr. Sumita Agarkar on intermittent exotropia. Intermittent exotropia is a condition which I feel can be easily missed by non-strabismologists in an OPD setting if they do not keep this entity in mind. So how to elicit this condition and not miss it, how to evaluate, when to intervene, and how to do so, all these will be addressed by Dr. Sumita Agarkar. Let me introduce her. Again, she'll be well known to all of you. She is Senior Consultant and Deputy Director of the Department of Pediatric Ophthalmology and Strabismus at Shankar Nethralaya, Chennai. She's also my teacher during my fellowship there. She's a wonderful mentor and troubleshooter to so many strabismologists all over the country because she's so approachable and an expert in the subject. My pleasure to invite Dr. Sumita Agarkar on a talk on intermittent exotropia.
Thank you for that very generous introduction, Satish. It's equally my pride to see you as the moderator of this session, and I'm so happy to see you here and so happy to be part of this symposium. So I'm going to talk on intermittent exotropia, and this is what is Satish brief for me. So why we need to talk about intermittent exotropia? Because it's far more prevalent in our situations. Almost some literature says in Asian countries it is maybe 4 to 7 times more prevalent than esotropia compared to Western literature. And so a lot of insights which you see about exotropia, a lot of it is very, very applicable to our daily routine of cases which we see in our regular OPDs. It appears seemingly straightforward, and yet it is very frustrating to manage because there are diverse thought process and each patient behaves in a very, very different fashion. And there are things which you probably difficult to explain despite, because recurrence is common, undercorrections are common, and target angles are not well defined, and most important, there are gaps in knowledge as to what is the best way to deal with these patients, who sometimes can be very young children when they first report to you. There is a very large gap in literature comparing various surgeries, and we really don't know if one procedure is better over the other, because the evidence for in favor of one or the other is thin. So in short, how do you define intermittent exotropia? It's basically a large exophoria which can no longer be controlled by fusional mechanisms at all times. So you will see patients who are looking like at one time like this, and another time within few minutes or within few hours. During the OPD examination, you can see child having a large manifestropia. So when it comes to evaluation of these patients, yes, a visual acuity, anterior segment examination, fundus examination, all that is part of comprehensive eye checkup, and every child needs to do that. Refraction, most important. But from the exotropia point of view, we need to assess the control, which can be done both subjectively using various scores. Newcastle score is a very easy to use score, or it can be used objectively. Subjectively is by the parents, their observations, and you should probably interview the parents more detail about how often you see it, when do you see it, all those questions need to be asked. And objectively, of course, using several scores which are available in literature. I have used the Newcastle score extensively, and I find it easy to use, and it gives you a very good idea when you are observing this patient from one visit to another, and you can see in your own notes. And it is a combination of a little bit of parental observation as well as your clinical acumen. So assessing control also basically tells you how easy it is to break the phoria into atropia, and how easily it is for a child to control, go back to being phoric or orthotropic once it's broken. So both these parts are part of your evaluation for exotropia. Then comes the most important thing, measurements. which difficult in children, but in older children and young adults, you can definitely do. We do suggest the angle to be measured for near distance, sometimes if possible for far distance, because it is intermittent exotropia is notorious for a large variation in the angles depending on the time of the examination, attention of the child, how sleepy he is, whether he woke up early to come to the clinic. There are so many factors. So not only measurements need to be repeated probably, but also if possible, we can do it in various ways and probably look at far distance, which is sometimes taking the kid out of the clinic and asking him to look really far away to get the real measurements. And also probably important to measure side gazes and patterns if there are any. Now, near distance disparity is one of the most important most important part of the intermittent exotropia evaluation. And we are grateful to this man here on the picture to provide a lot of insights on this subject. So if you do see a near distance disparity where the distance angles are more than near, you probably should add a monocular patching and a 3D and a measurement of the angles with a plus 3D lens in that order to see what is the true angle of deviation. If your near angles are less than distance consistently, then probably it's a good idea to patch for 45 minutes to 1 hour. And what does this uniocular patching does? It kind of suspends your fusional convergence. And if that is the mechanism for where the near angle is less because of the fusional convergence, once you suspend the fusional convergence, near angles will build up to that of distance and you can operate for that angle. However, if it does not happen, then the part 2 or step 2 is to rule out if it is indeed the accommodative convergence which is at play, and that can be done with plus 3 diopter lenses. So patching is first, and when you are looking at the near distance disparity, these two tests have to be done in this order which I am giving. That first you suspend a fusional convergence and then check angles. If that doesn't happen, then measure it with a plus 3D lens to take care of accommodative convergence or to suspend the accommodative convergence, and to see if there is patient indeed has a divergence excess or is it a pseudo divergence excess. So this is a short video which I'm going to play about how you can see this lady who has a fairly large angle for distance, and you can see she breaks fairly easily with a single cover for distance. And you can see it builds up when you do an alternate cover test. She builds up to a fair large angle, which is almost, you can see when you measure, it's around 35 to 40. But look at the same patient with a near target. As you can see, absolutely almost no or very small angles. And this is the case where you should probably patch her for an hour or for at least for 45 minutes. And you can see even after measuring, it's just about maybe 10 prisms with great difficulty after several. And we patch her. It's important to not let her have even a minute of binocular stimulation. So you should keep the cover on as soon as you remove the cover. And as you can see, she has built up and she has broken further, and you can see the angles are nearly same for near also. If she had not, then I would have, sometimes the near angles will actually be more than that of distance after patching. If she had not built up to this, the next step would have been to do the measurements with a plus 3 diopter lens over her correction. She is emmetropic, so I don't need it. She's not wearing glasses, but that is the next step I would have done if she had not built up to whatever her distance angle after patching. So now, once you have established the diagnosis, now you have to look at if you can offer surgery or you can get away with non-surgical intervention. So as usual, for any strabismus entity, correction of refractive error is most important thing in armamentarium. And it is more so in children who are younger and who are presenting to us. So any myopia, any and all myopia should be corrected. Any and all astigmatism should be corrected fully Do not be queasy about giving astigmatic correction just because it is plus minus 3 cylinder. Let me give minus 1.5, I will build it up. No, give 3. If you find 3, give 3. And hyperopia is a little bit of a tricky thing. Okay. How much should you give? Generally, up to plus 2 diopters or plus 2 to 2.5 diopters, you can ignore. But if it is anything more than 2.5 to 3, you can maybe cut by 1.5 and give. So if my patient is having plus 3.5, I may actually give plus 1, even though patient is exotropic. So correction, and a lot of times this correction of refractive error itself will allow you to kind of postpone the surgery for a while till you can get better measurements. And even in adults or older children, you can recheck the angles after giving a trial of correction, and you may find the angles may be modified by a little. You may have to actually reduce your surgical dose. In small angle, well-controlled intermittent divergent squints, you need not do anything. You can just keep them under very close follow-up, and don't even give alternate occlusion to break the squint if it is well controlled. If you are not able to see, occasionally mother says once in a while she sees it, it's a small angle and you are not able to see it in the clinic. Sometimes even the alternate occlusion is not required in these patients, because sometimes alternate occlusion will break it. So probably small angle, well-controlled ideas, do nothing, just watch. Again, if there is a fairly large angle squint, child is 3, you don't want to immediately jump in with surgery, does not have refractive error. Sometimes we do give alternate occlusion to improve control, and it does work in children where they are able to patch. It definitely works. If you see dominance, you can just give occlusion of one eye. That also helps you to control the squint. But if it is you don't see vision is equal, or you don't see any particular dominance, you can give alternate occlusion, and wear it 1 to 2 hours a day. Unlikely children will up to 3 hours is recommended, but I don't see in my practice any child wearing for 3 hours. Over minus glasses, my experience is low because I'm always scared about patients not coming back for follow-up, but it works like charm in children who are younger, in whom you don't want to do surgery. Sometime over minus glasses will work like really beautifully. Convergence and fusional exercises. Well, orthoptics as well as computer-based software is available for both exercising convergence and fusion. But in my experience, it's not very effective in children. Very difficult to get them to appreciate diplopia, which is what fusional exercises do. A lot of children just don't see double, and they don't. So you may give, actually, you may prescribe, but it just ends up in exercising the biceps, not really the convergence. So, but in young adults and those who are cooperative, it can be tried as a temporizing methods, but exercises can be boring, repetitive, and may not be a very, very effective method to control. It works in a small subset of patients who have a real convergence insufficiency along with the intermittent divergent squint. Convergence and fusional exercises do work, but that's a small subset. As I said, over minus glasses, they will induce accommodation and thus accommodative convergence and thus better control. This is the whole philosophy behind giving minus glasses. As I said earlier, useful in younger children. You must over minus symmetrically. Up to 1 to 2 diopters over and above their prescription can be prescribed. So if child is wearing 2, you can give 4. If child is 0, you can give minus 2. But they need a very close follow-up and watch out for any esophoria or any worse esotropia. If it is any of these 2 things happen, you may have to either reduce the over minus or you may have to discontinue the glasses. So follow-up has to be very, very meticulous, but it is a very, very good strategy to buy time in younger children. Prisms again can be used in small angle strabismus for people who are unwilling for surgery. You can give both ground in and Fresnel prisms. Sometimes we do give, if patients are diplopic, then you do give a relief from diplopia. And again, it's mostly a temporizing method, as patients usually end up requiring more and more prisms to maintain alignment over a period of time and may end up requiring surgery. Prisms work very beautifully in overcorrected esotropia. Those situations probably it has still use in a consecutive exotropia or a consecutive esotropia, it is really works well. Now coming to the surgical intervention, these are the usually indications where you should offer surgical intervention. And there are no arguments about any of these indications, and there are no two ways about it. So any of these situations, if you feel, you can probably look at surgery. Now, coming to the decision making in per se in surgery, these are the three very dicey things of whether what should be the timing of surgery, especially when you are having a 2-year-old child coming. I don't remember that many younger children coming to clinic with intermittent XTs, but now I see more and more younger children because of the awareness or anything. They are presenting to clinics much earlier and much younger. And so timing, when do you offer surgery is important. What should be your target angle? Do you aim for orthotropia, a small esotropia, or on point correction? This is something which is very, very personal decisions, and a lot of times evidence is very thin in one strategy versus another. And of course, the choice of procedure, unilateral versus bilateral surgery, these kind of decisions. So timing, if it is well controlled, it's probably better to defer surgery in very young children till reliable measurements are achieved. So you can use any of those non-surgical methods, which I have mentioned earlier in these situations. 3 to 7 years is the ideal age to operate if exotropia is really large and if it is not well controlled. So probably if you have reliable measurements, you don't have to be queasy about offering surgery for a 35 XT if the child is 4. So that's all I meant by that. Of course, sometimes patients are coming at 8, should you not do surgery? Yes, you should do surgery, but 3 to 7 is where you should probably actively advise them to go for surgery. So what is the target angle? Again, a lot of divergent views on this. 5 to 10 prisms of overcorrection means to aim for a small esotropia is desirable in children because chances of exodrift are more in these situations. However, beware of overcorrection in very young children, say 2.5 or 3, as they can become monofixators very quickly. And if you do end up with overcorrection, which does not go away in a week or 10 days time, then probably it's either you intervene for that overcorrection or reverse the surgery, whatever. But you cannot watch overcorrection in a very child who is under 3 for more than 10 days or 15 days. That's about it. In adults, orthophoria is probably the goal of your surgery, not really a overcorrection, because some of them just don't drift again and are diplopic and very uncomfortable. In myopic patients, especially high myopes, probably target angle should be a slightly undercorrected rather than on-point correction. This is my personal take on it. There is not much evidence to say this. Procedure of choice, again, unilateral versus bilateral surgery, one eye versus another. In children, probably it is probably safer to do a symmetrical surgery. But again, there is no conclusive evidence that RNR works better than a bilateral lateral rectus recession. Whether it there was a thinking at one time that basic exotropia where near and distance angles are same. RNR is a procedure of choice, and bilateral lateral rectus recession should be saved for true divergence excess or in whom patients whom angles are more for distance. But there is really meta-analysis have not proved any superiority of one procedure over the others. But as if I have to give my opinion on it, I would prefer a bilateral surgery in younger children. In adults, I usually operate for RNR, and RNR is associated with slightly better results in larger angles, and but is slightly more prone for producing overcorrections and lateral incompetence. That must be explained to the patient. It causes little bit of Barber-Fisher changes also, especially if you're doing for large angles, and that all must be explained to the patient when you decide on unilateral versus bilateral surgery. Near distance disparity also plays an important role in surgical decision making. But if it's a really large near distance disparity, and then you probably have to look at RNR as a better choice than bilateral lateral rectus recession. Pattern deviations, of course, with appropriate oblique or surgery shift of the muscles should be tackled at the time of primary surgery itself. That goes without saying. What are the factors which are affecting surgical outcome? Age, yes, younger children likely to have better outcomes. Magnitude of deviation, larger angles means more than 45 probably are associated with slightly more chances of undercorrection. Presence of amblyopia again is strongly associated with the recurrence of exotropia. Type of exotropia, basic exotropia, best results are probably with divergence excess exotropia, followed by basic type of exotropia, and the least are convergence insufficiency types and those who have high AC by ratio. Those patients are likely to do worse. And especially with patients who have really true high AC by ratio, you must talk about requiring another surgery if should they develop esotropia for near following your surgery. Post-operative deviation of whether you left him with under or over. Undercorrection is strongly linked with recurrence of exotropia, but there is no evidence to show whether how much you left over was it associated with good outcomes. No, not so much clear evidence on that. What happens if you end up with overcorrection? Yes, because that's something which sometimes you plan for it and sometimes it may be inadvertent. So as I said earlier, if it is lasting for more than 2 weeks in younger children, you must prepare for amblyopia and monofixation. So occlusion should be started. If there is any hyperopia, give full correction. Add prisms to the glasses if required. And of course, if it is more than what you anticipated, or you do anticipate a large esotropia because of a slipped muscle or lost muscle, then you must definitely plan for an early resurgery. Undercorrection also has to be dealt with, like a resurgery, depending on patient's willingness. Thank you for the attention.
So thank you, ma'am, for that wonderful talk explaining all the various aspects involved in intermittent exotropia. Our next and final talk in the series is on infantile esotropia, probably the commonest strabismus condition that many of you will encounter. When is the best time to intervene? What is the problem if we delay? These and other related issues related to the pathophysiology and management of infantile ESO will be addressed by Dr. Elizabeth Joseph. She needs no introduction to our audience in Kerala. She's the most famous strabismologist in Kerala and a South Indian representative to SPOSI.
She's first lady of strabismus, man.
She's the
first lady of strabismus.
Yes. if you give her that post. Yeah, she is now the HOD and Chief of Pediatric Ophthalmology and Strabismus at Little Flower Hospital in Andaman. Over to you, ma'am.
Good evening to all dear faculty members, panelists, and the audience. I thank Ksos and Dr. Satish for giving me this opportunity. I hope I am audible now. Okay, I am asked to talk on infantile esotropia, the neurophysiological concepts and management strategy. And infantile esotropia will not be present at birth. It usually comes just after 2 or 3 months of age, but invariably it presents before 6 months of age. Initially, the child may be orthotropic, but gradually becomes esotropic. And the esotropia will be very large and will be associated with the Ksos fixation, as you see in this photograph. Sometimes the right eye is squinting, sometimes the left eye is squinting. There is Ksos fixation. Almost all of these children will have abduction deficit. Most of them will have equal vision in both eyes. There may be associated latent nystagmus, inferior oblique overactions, dissociated vertical divergence, But anyway, nasotemporal asymmetry is seen almost in all cases. Dissociated vertical divergence is seen in about 75% of people with infantile ET. Dissociated horizontal deviations in about 10%. Nasotemporal asymmetry, as I told already, is nearly in 100% of cases. Latent nystagmus about 30 to 50%, inferior oblique overaction about 70%. One thing to note is that all these associated abnormalities occur only after about 1 year of age. It may not be present initially. And there are so many variants of infantile AT. One is Ciancia syndrome, like this child presenting with esotropia, abduction deficit, but during abduction there is a nystagmus. So abduction, nystagmus, and defective abduction characterize the Ciancia syndrome. Similarly, there is the Lang syndrome, in which there is infantile ET associated with DVD and abnormal head posture. Nystagmus blockage syndrome is also an extension of infantile esotropia, where nystagmus increases on fixation and convergence dampens the nystagmus, and that results in a convergence squint. Then there is the refractive infantile esotropia due to high hypermetropia, which is uncorrected. This is only a very small proportion of patients with infantile ET. Infantile microesotropia, where the angular strabismus is very small, that also is a small percentage. Coming to the etiology, in 20 to 30% of children, there is genetic preponderance. Environmental factors like perinatal hypoxia, low birth weight, prematurity, occipital hemorrhage, ventricular hemorrhage, and leukomalacia is often associated with infantile ET. And many children with Down syndrome are prone to develop infantile ET. Why does essential infantile esotropia develop? Or the other question, what is the etiology, real etiology? Actually, we still do not know the real etiology of infantile ET. Several postulations are there, several theories are there. But the fundamental thing is that there is a nasotemporal asymmetry. That is a clue to some evolutionary problem in the neurological problem. Even after surgical realignment, this nasotemporal asymmetry persists. So this shows that there is some neurological problem. This has been discussed in several publications, as I have noted. One publication in Investigative Ophthalmology, 2018, clearly says that there is a pre-nuclear involvement of the. There is a definite role of extended subcortical ocular motor plasticity in essential infantile esotropia. Means initially we thought that it is due to cortical problem. Now we are saying that it is due to subcortical problem also. Some people are saying that it is purely motor. So these are the three different postulations about the etiology of infantile ET. This is a diagram I took from Rosenbaum, and he clearly says that there is a definite neuroanatomic abnormality noticed in the ocular dominance columns. This is the ocular dominance column of a strabismic patient. There is absence of binocular connections, whereas in a normal person, binocular connections in the ocular dominance columns are there. So he is saying that there is a neuroanatomic basis for infantile ET. And there is a functional structural correlation. When there is a absence of binocular connections in the ocular dominance columns, then there will be lack of fusion and lack of binocular visual evoked potential. And the connections in layer 4 abnormality leads to asymmetric pursuit. So there is a connection between the structure and function. There is the old Chavasian hypothesis of motor cause. They say that there is a longer course for the sixth nerve, and so the lateral rectus matures relatively later, medial rectus matures early, and so there is a motor medial rectus tonus, high tonus. That is another hypothesis. Anyway, the current concept. Previously, we used to think that infantile esotropia reflects a primary disturbance of the visual cortex, but recent evidence suggests that it is subcortical. The esotonus is increased, driving the eye's nasal valves. So this is one famous editorial by David Hunter in JAPOS, and he, all of us know, and he clearly says that infantile strabismus can cause delays in developmental milestones like grasping the objects, crawling, walking, etc. And an early surgery will fix not only the eyes but help the whole child. Coming to the treatment of this condition, of course, we have to have a thorough examination. We have to assess the angle of the squint, and we have to make sure that the angle of the squint is stable, and do a thorough examination, do cycloplegic refraction, and if there is any refractive error, it has to be corrected by glasses. That is the first stay in the treatment. And what about occlusion? Occlusion has got a definite role. If you think that one eye is dominant and the other eye has got a tendency for amblyopia, of course, occlusion of the dominant eye has to be done. And if you think that it is a truly alternating squint and the vision is almost equal in both eyes, even then there is a role for alternate occlusion. And after that, a period of occlusion, we take up the child for surgical. Surgical management is the mainstay in the management of infantile esotropia. About botulinum toxin, it is still has got a role, and in certain centers, they do botulinum toxin injection to the medial rectus in infantile ET. We do Botox injection routinely for LR palsy, acute lateral rectus palsy, and convergent squint, and also in acute comitant esotropia. For infantile ET, I don't do botulinum toxin. I would like to get the opinion of the panel and the faculty members whether it is being given for infantile ET. But in some centers, it is given, I know. But my personal opinion is that surgery is more will bring about a more stable alignment than Botox. And a word about alternate occlusion. In alternate occlusion, you occlude for 1 to 2 hours, one eye one day, and the next day occlude the other eye. 1 to 2 hours is enough usually. And this will reduce the abnormal binocular adaptations like suppression, and it may prevent or treat any amblyopia which is missed due to difficulty in eliciting the fixation difference. And this will prevent medial rectus contracture and increase abduction and abolish gross fixation. So alternate occlusion has got a very good role in management of infantile ET. And coming to the timing of surgery, this is a greatly debated subject. The whole, you can answer this question, when to do surgery, if you are able to answer whether repair of binocular connection is possible by doing an early surgery. The current thinking is that if you attain a stable alignment in 12 months of life, the chance of repairing stereopsis is good. May regain stereopsis of the order of 60 to 400 seconds if you get a good alignment before 1 year of age. But if the stable alignment is not achieved even at 24 months, the chances of stereopsis is probably nil. That is the current consensus I got by reading all the articles. Kenneth Wright used to say that surgical intervention at 3 to 5 months is good if the deviation is more than 50% diopters. This is a child who had an esotropia. We did surgery at, I did surgery at 7 months. Kenneth Wright had advised the surgery even as early as 5 months. But the main problem with early surgery is that it can lead to consecutive Ksos later in life. Consecutive exotropia is more common if you do early surgery, but the chance of stereopsis is very good if you get a very good correction. See, these are two articles who have discussing early surgery, and Yogasaki et al. Has published that early surgery will decrease severity of DVD and the need for oblique surgeries. And early versus late infantile strabismus surgery study, which was published in 2005, they also say that early surgery is good if you have to operate between 6 and 24 months. Those children below 2 years develop good stereopsis at 6 years. The advantage of early surgery is that there is a good motor alignment, there is better chance for BSV that can prevent DVDs and inferior oblique overactions, improve ductions, and improve general motor skills like walking, crawling, climbing upstairs, etc. What about surgery done between 1 to 2 years? Helveston has published article in Journal of Pediatric Ophthalmology saying that if you do surgery between 1 to 2 years, what you may get is a monofixation syndrome. Bifoveal fixation is difficult. And what is the surgical procedure? The preferred surgical procedure is a bimedial recession and not recess resect procedure. And the optimal approach is cul-de-sac incision because this is minimally invasive. Up to 50 diopters of deviation, 2 muscle surgery is enough. If there is more than 50 diopters, you have to have more than 2 muscle surgery. I'm not going into the details of the surgery because this surgery was already shown by Pradeep Sharma sir. So I'm not going, but my method is slightly different from what sir has shown. But anyway, the result is the same, I hope. See, I have analyzed some of our patients. This is a child 6-month-old with infantile ET. We did surgery at our center at 6 months and followed up the child. And at the age of 4 years, you can see that this is at the age of 4 years, the same child. You can see that there is a stable alignment. The child is orthotropic, and we could measure a stereopsis of a good stereopsis in this data. So at the age of 6 months, surgery has with a good prognosis we can get. And surgery at 1 to 2 years, they say it's a monofixation syndrome. This is a child who underwent surgery at 1, but I don't have the details of stereopsis postoperatively because this is done only just last year or so. And this is a child who is already 2 years. We did surgery at 2 years and followed up at the age of 4 years. At 4 years, we examined the child. We can see that the eyes are straight, stable, parents are happy, patient is happy, but there was no stereopsis. So to conclude, the congenital esotropia observational study and several other studies suggest performing early surgery at or before 10 months to obtain optimal sensory and motor outcome. But then these patients should fit into the clinical profile, which include a large angle deviation with close fixation. And one more thing we have to remember is that the age at alignment and duration of misalignment, both are important. Duration, if you do the surgery within 2 months of misalignment, the result will be very good. So age at surgery is important. At the same time, the duration of misalignment is also important. With this, I am concluding my talk. Thank you very much for a patient hearing.
Thank you, ma'am, for that wonderful presentation. We are running short of time. Let me quickly introduce our 3 panelists. Dr. Laila Mohan is HOD, Pediatric Ophthalmology and Strabismus at Comtrust Eye Hospital, Calicut. Besides managing glaucoma, cornea, cataract, she is a true all-rounder. Dr. Gargi Satish is Additional Professor of Ophthalmology at Government Medical College, Kottayam. She has done a fellowship from RIO, Chennai. And Dr. Ramya Vivek is Pediatric Ophthalmologist at Cooperative Hospital, Payyanur. She did a fellowship from Narayana Netralia, Bangalore. So since we are really running short of time, may I request the 3 panelists to comment on these the 3 talks, anything related to these 3 talks that they feel was really important, or any pressing question that they have to address to add on to the discussion that we've already had. I think we just have about 4 or 5 minutes left.
Yeah, and I would like to know the opinion. I am a big fan of using over minus correction for children for intermittent exotropia who come quite early. And now with lot of, actually Krishna has done lot of studies looking for if over minus correction produces myopia later in life. Lot of studies are there. But even now, I firmly believe that it has a very big role, at least to postpone surgery, not probably in treating it, but definitely I have found parents very comfortable with using. If you start early, that is quite early. I don't know how the others feel about it. With a lot of this under correction and over minus myopic correction with the myopia strategies, I don't know, now I have to reconsider or not, but I'm still using lot of children are on over minus correction, and definitely the Newcastle control score follow-up has come down from 5 to 4 to 3 to even very, very low scores. What about Sir Pradeep Sharma, sir?
Yeah, I think over minus therapy is a strategy, but I feel its role is very limited. I have used it in very situations like we want to defer a surgery for a few months. Like I remember a girl whose mother was pregnant and she wanted to defer the surgery for a few months, and I didn't want the exotropia to cause any havoc. So I used over minus therapy for 6 months time, and then she came back after 6 months and I operated. So I feel over minus therapy, and then it only works not in all intermittent exotropes. It only works in younger children who are around 4 or 5 years of age, who have good accommodative reserve, and those who have a high AC by ratio. So people who have a normal AC by ratio, you may not be able to correct. For example, if you have a 30 prisms of exo, now to correct a 30 prisms of exo with a normal AC by ratio, you would have to give minimum something like 30 divided by 5 will be 6, which will not be feasible. Okay. So anything like 3 to 5, that's also the upper limit. So unless he has a 8 or 10 AC by ratio, it doesn't really become productive in your hands. So I would use it very reluctantly in people who are not able to get the surgery done and they want to defer it, and the child is also having a high AC by ratio, so that we can get the yield that we want.
Okay.
Then how about alternate occlusion and alternate patching in intermittent exotropia? We advocate for all the patients.
Again, alternate patching, which is being done very fondly by some strabismologists I have seen, I do not really feel that enamored by it. I only use alternate patching, or rather dominant patching, when I have a person having amblyopia or an active suppression in one of the eyes. Then I use a patching to reverse the suppression. And if a child is having a binocular vision, I would not like to do an alternate occlusion to actually suppress binocular vision. It's against the thesis of my binocular vision concept, that if you do an alternate occlusion, you're not giving a binocular vision a chance. You're only delaying surgery. So why are you doing that? It's better to then give fusion exercises in the intervening period and then plan for a surgery if it's still constant.
Yeah, I'm really concerned about patients who are 1.5 and 2, and who will not even, where you have to assess the angles at the door of your clinic because child won't even come and sit in. So those patients where you don't want to operate and end up with a esotropia, consecutive exotropia, I still feel there is a role for alternate occlusion.
You mean post-operatively?
No, sir. I'm pre-operatively. 1.5, 2-year-olds nowadays people.
Exotropes. She's asking about intermittent exotropes.
IXT.
Intermittent exotropia probably not much role, because fusion
I have heard of Krishna using and some people using. Some follow-ups have got some intermittent exotropes, divergent squints, who have been given alternate occlusion, and I have not been very much enamored by that. Intermittent, alternate esotropias, of course, till the time that you're waiting for surgery. Infantile esotropias also. I think there is a nice work by Jampolsky, which was published long time back, that there is a sort of reversal of the nasal temporal asymmetry by this approach of alternate occlusion if you do in the intervening period. So we usually give a 1 month of alternate occlusion in the time that we plan for a surgery in any infantile esotrope.
No, sir, for exotropes, 1.5-year-old, what would you do?
So that's what
observe.
Intermittent or exotrope?
Exotrope, I am saying that I would not use alternate occlusion. I would see that if it is breaking more than 70-80% time, as I had shown, I think, a slide of a child at 1.5 years of age who was having almost a manifest exotropia. So there I would operate. If it is less than 50% time, yes, wait. Defer the surgery as far as possible in an intermittent exotrope, as long as you see that the control is fairly good and it is less than 50% of time that he is breaking. But if he's breaking more than 40% times, then definitely surgery has to be done, even in an infantile exotrope or an intermittent exotrope. The same logic is working. Binocular vision is going to be hampered. It doesn't save an exotrope by having a manifest exotropia to develop binocular vision. Yeah. And alternate occlusion again will not work.
Intermittent exotropes, they present even much earlier. 1.5 years also we do see sometimes they come with, that is the age at which I give over minus if there is no active.
You may give over minus if it is helping. That means if they have a high AC by ratio, that cases you can do, sure, if they have. But if they do not have a high AC by ratio, and if they, I mean, unnecessarily giving them a minus correction is also really not good.
Yeah, time is up. So really want to thank Ksos and Dr. Sreeni, KOS and Dr. Dhrumil for giving me this opportunity. I want to thank the 3 speakers and the 3 panelists on my team for a wonderful session. We want to leave the audience with this take-home message that binocular single vision is what is most important. And if you have seen the management strategies, they are all related to that. We have to go in quite early in intermittent, in infantile ESO. We can delay the management of intermittent exo only because for a lot of the time their eyes are aligned and they have binocular vision. That's the only reason why we are able to delay it a bit. So I hope you'll carry home this take-home message. Thank you all for your patience here.
Thank you.
Thank you so much, sir.
Thank you, sirs and madams. That was indeed an enlightening session. And of course, hearing from the legend himself was really exciting, especially for us residents. Thank you once again.
Thank you.
Now, let us move to our next session, which is on pediatric cataract. Every ophthalmic surgeon is a cataract surgeon per se, but when it comes to pediatric cataract, everything changes right from the preoperative workup to the postoperative care. Let us hear more about it from the experts. For this, I invite Dr. Thomas Matthew, consultant ophthalmologist in Caritas Hospital. He did his MBBS from Kasturba Medical College, Mangalore, and completed his post-graduation from Aravind Eye Hospital, Coimbatore. He also worked as a consultant in Aravind Eye Hospital, Coimbatore for 8 years. I welcome you, sir, to chair the session.
So you're muted, sir.
You're muted.
Yeah. Am I audible?
Yes, sir.
Yeah. Good evening, one and all. I thank the KSOS, KOS, and the Scientific Academy Chairman, Dr. Sreeni Edakhlon, for this opportunity. Next 1 hour, we'll be discussing about pediatric cataract. Pediatric cataract surgery is very challenging because an infant eye is not a miniature adult eye. Wound construction and closure is important as ciliary rigidity is very less in infant. Posterior capsular opacification is 100% in children, and hence management of posterior capsule is imperative during the surgery itself. As IOL implanted in a growing eye, myopic shift is inevitable. Hence, IOL power calculation is very challenging. In pediatric cataract, postoperative management is more important than the surgery itself. Visual rehabilitation using contact lens, glasses, and amblyopia management is a team effort of parents, optometrists, counselors, and the doctor. We have a very experienced faculty to tackle this challenging subject. Dr. Sandra Ganesh from Aravind Eye Hospital, Coimbatore, Dr. Arun Samprathi from Samprathi Eye Hospital, Bangalore, Dr. Satya Ravila from Aravind Eye Hospital, Tirupati. We also have a very experienced team of pediatric ophthalmologists as panelists. Dr. Meena C.K., Senior Pediatric Ophthalmologist from Little Flower Hospital, Angamali, Dr. Soumya Nambiar from Comptress Eye Hospital, Kozhikode, and Dr. Rajesh Prabhu from Shankara Eye Hospital, Coimbatore. Thank you. Now I invite Dr. Meena to introduce the first speaker, Dr. Sandra Ganesh.
Good evening to all. I'm audible?
Yes, yes.
Okay. A happy Mother's Day to all the viewers, all the mothers in the group. And I'll be introducing Dr. Sandra Ganesh, who will be talking about pre-operative evaluation and biometry in pediatric cataract. And Sandra Ganesh did an MBBS from Kasturba Medical College, Manipal, and her post-graduation from RIO Chennai and Aravind Eye Hospital, Coimbatore. And she is presently the consultant at consultant in the Department of Pediatric Ophthalmology and Strabismus, Aravind Eye Hospital, Coimbatore. And she has done numerous clinical observations in very prestigious institutes, including the Children's Hospital, Boston and Wilmer. And she has presented several papers in almost all the prestigious conferences, international conferences, and numerous publications as a first author. So her special interests are complex strabismus and cerebral visual impairment. I invite Dr. Sandra for an informative talk.
Thank you so much. Am I audible?
Yes.
Yes, yes, yes.
Yeah, thank you, Dr. Thomas sir, and the KSOS team for this kind invitation. And I'm very happy to be a part of this very interesting session today evening. So I'm here to talk about and give an introduction on pediatric cataract. So coming to the Indian scenario, around about 7.4 to 15% of childhood blindness in India is caused exclusively by pediatric cataract. And there's a lot of inadequacy in the awareness of the causative factors. With special reference to the south of India, we have around 25% of cataracts which are hereditary, which can be autosomal dominant most commonly, and sometimes can be autosomal recessive or X-linked, and 15% being syndromic, the congenital rubella being the most common, and the rest fall into the idiopathic category. But again, 50% of the time we don't come across any particular reason for the cataracts, and nearly half of the non-traumatic cataracts are due to potentially preventable causes like congenital rubella syndrome and the autosomal dominant disease, which is mainly because of the high prevalence of consanguinity in this population. So the important thing to remember is that it's a significantly, it is possible to avert this disease by certain measures, and that can in turn lead to reduction in the disability adjusted life years. And the treatment is but often tedious, and it requires a dedicated team effort, the most important members being the parents of the children. So coming to the etiology, just a brief overview. As I said before, 50% is idiopathic, about 20% is familial. Most often it is autosomal dominant. Around 5% of it can be because of genetic, metabolic, and systemic diseases. Among the genetic causes, Down syndrome, Edwards syndrome, and Patau syndrome are more common, and it can be associated with craniofacial syndromes, musculoskeletal syndromes, myotonic dystrophy being one of the common etiologies of musculoskeletal. The renal includes the Lewis and the Alport, which are commonly seen, and the metabolic including the lactosemia, which is a reversible cause, Fabry's, Wilson's, diabetes mellitus, and hypocalcemia. And also maternal torch infections, out of which rubella is most common. And unilateral cataracts are most often associated with the ocular anomalies, which includes various diseases, including PHPV, aniridia, and other anterior segment genesis syndromes. Sometimes can be iatrogenic because of steroids or radiation, including the treatment of retinoblastomas. So unilateral is most often again idiopathic, sometimes can be associated mostly with the ocular anomalies, which includes the persistent fetal vasculature and the anterior segment dysgenesis. So the PFE cataract, sometimes if it is affecting the anterior segment, it will be associated with the microphthalmos and the microcornea. And the traumatic, we should always rule out child abuse also. So the goal of the modern pediatric cataract surgery is timely restoration of the clear visual axis and appropriate investigation as to the cause as per case-by-case basis, ensuring a safe general anesthesia for the treatment, and achieving a age-appropriate post-operative refraction. These would be the goals. And most oftentimes they present on incidental routine screening, and sometimes the parents notice the white reflex, or at times they notice the deviation of the eyes, which is mostly esotropia, because the poor vision develops very soon after birth. And some morphology have a better visual prognosis than others, like a faint lamellar cataract or a posterior lenticonus. They can all do visually, but dense bilateral cataracts do relatively poorly. So coming to the history taking, these are the presentations which I have said before: the white reflex, the deviation, shaky eyes, squeezing in sunlight, defective vision, and trauma. So the antenatally, we need to ask questions about maternal rash or febrile illness, especially in the first 3 months of pregnancy, any other exposure to other drugs or radiation, etc. And postnatally, we do need to ask about the birth weight, age at onset of symptoms, when the parents noticed, when was the cataract diagnosed, any history of steroid therapy, trauma, and if there is any prior documentation and ocular status on previous eye exam. So this will help us to know whether it is at birth or a little time later, and if there is a family history of cataract. So now that we have taken the history, which case to operate and when to operate. So if we see very small children with this dense cataracts, then there is no, all these children, as you can see, the white reflex is very prominent. So there is no doubt in our minds that we need to do the surgery as soon as possible. So for this reason, early detection is very important. So we need to educate and empower all the primary care physicians, including the pediatricians and even the immunization area, to early detect and look for a red reflex, and if they notice anything abnormal, to refer very soon for early detection, because it is very important to start the treatment before nystagmus sets in. So the critical period for the treatment of cataracts is around 2 months to 6 months, and for dense bilateral cataracts, the ideal time to operate would be as soon as around 6 to 8 weeks of age, provided you have the child is well and there is a fitness for general anesthesia. So if we operate less than 5 to 8 weeks, we get better visual outcomes. More than 10 weeks with a dense bilateral cataract, most often times nystagmus sets in, and that would be a predictor, the presence of nystagmus is a predictor of poor visual outcome. So that is the latent period, definitely. And as I said before, any cataract which looks like this, a total cataract, or in the undilated state, if it is a central lens opacity more than 3 millimeter, very close to the posterior pole, where you cannot see the retina very well, and there is documented progression, definitely we need to go ahead with the surgery. Whereas in verbal children, if we are able to measure anything, if we can measure very old children, visual acuity less than 6/9 N8, if it is close to the posterior pole and very symptomatic, we can decide on surgery, nearing around 8 to 10 years of age, I would say. And pre-verbal children, you would base your decision based upon if you can measure acuity with the Cardiff or Teller or fixation behavior, pupil response, and it is always an individual judgment based on the child's visual functioning, visual needs, and what is the best visual outcome expected after the surgery. So because the removal of the cataract will interfere with the natural mechanism of emmetropization and accommodation. So the blur created by the partial cataract, whether it justifies the extraction of the cataract, is what the surgeon should decide. So the cataracts can look varied presentation. Many of these in these pictures are partial cataracts, which do not affect the visual acuity that much. So in a very small child, you can wait and decide later based upon the effect that is having on the vision. So in older children, even above the age of 10 years, you can have the options of newer lenses where you can get some accommodation, or even multifocal lenses might be but very in few select cases. Unilateral cataract, the amblyogenic factor is more than a bilateral cataract. So early surgery by 4 to 6 weeks of age is recommended, followed by aggressive amblyopia management and immediate rehabilitation with contact lenses or glasses. So if you suspect rubella cataract, it's always important to look for congenital heart disease, because sometimes if we are diagnosing the cataract, it's better to refer to the pediatrician to rule out significant congenital heart issues and get a fitness before we take up the patient for surgery. And also they have to get their hearing evaluated, and rubella retinopathy has to be looked out for. Traumatic cataracts has varied presentation, and we need to again decide our surgery based on a case-by-case basis. Extent of trauma, presence of angle recession, zonular weakness, and and vitreous hemorrhage and the status of retina, all these has to be kept in mind. And if you see typical presentations like these, they are associated with syndromic like Alport's, the myotonic dystrophy and the shield ulcer with the atopic dermatitis and so on. So that you have to keep in mind. Lab workup is not necessary in each and every patient, but wherever we need it, we have to see the blood sugar, urine for reducing substances like galactosemia, Lewis syndrome, plasma, phosphorus, calcium, and red blood cell transferase, galactokinase, if there is a suspicion, and also torch titers if we are having a suspicion. Torch titers, the IgM, is what would be significant in a small child up to the age of 6 months, beyond which the IgM levels rapidly falls by 3 to 6 months, and the IgG could be even a transplacental transmission. So we need to look for a rising titer if you are looking at the IgG values. So coming to when we decided to operate, next we should look at the most challenging thing is the biometry, and whether to place a lens, when to place the lens, and what would be the ideal power of the intraocular lens, what formula to use, and what are the other clinical variables that we need to keep in mind. So the intraocular lens implantation has become the standard of care in certain select patients beyond the age of 1 in bilateral cataract, 1 to 2 depends upon the surgeon's preference, and a little earlier on in a unilateral cataract. But the accurate determination of the lens power remains one of the major challenges. So the keratometry, the axial length measurements, what material of intraocular lens to use, and we need to keep in mind the long-term issues which include visual excess opacification and myopic shift. So the challenge is because there is a very rapid growth of eyeball, especially for the axial length. At birth is around 17 millimeters, and by 1 year it is about 20 to 21. So there is a very rapid growth in the first year, and then there is a slow growth up to 18 months, and beyond 18 months the growth is very slow. Whereas the keratometry, the major change happens in the first 6 months of life, beyond which it almost stabilizes. So the lens power in the first year decreases by almost 10 diopters. Whereas in the second year, it reduces by about 3 to 4 diopters between the ages of 2nd to 10, considering that the child is not going to be myopic. So the most axial length elongation is in the first 2 years of life. So this is the famous curve by Gordon Donis, where you can see again that most of the refractive change is within the first 2 years of life. And this can lead to the myopic shift. So minimal age for lens implantation, again, it is based on the surgeon's preference, but most often the consensus would be the bilateral cataract over the age of a year. And provided the corneal diameter is more than 10 millimeters, which is a safe limit, and uneventful surgery with the guaranteed in the black placement, then we can place it in such a small baby. And the formulas to use, again, we have a lot of formulas. Most of them are based on adults. We don't have any specific intraocular lens calculation formula for children as yet. But there have been good results with the newer generation formulas. SRKT has been used for a longer time, and nowadays for the smaller sized eyes, we can look at Hoffa-Q or Holiday. And even for the bigger sized eyeballs, more than 24, again, we can look at SRKT and Holiday. And the newer formulas like the Barrett's and formulas are being used very recently in a few centers. So the errors of the lens power calculations are more if in very small eyes with actual length less than 20 millimeters or age less than 36 months. So the measurements needed for biometry includes axial length, keratometry values, which are very difficult in the office setting. Examination and anesthesia is needed, and there can be errors in measuring these values. So for the biometry for axial length, we can use an optical or an ultrasound biometer, which could be a contact or applanation or the immersion method. And for keratometry in small babies, we need to use a handheld keratometer, whereas in older children, we can use the IOL master. So the ultrasound biometry, the applanation is what is most commonly used, but there is a possibility of indentation of the cornea. So in very small eyes, there could be errors of around 2.5 to even 3.75 diopter per millimeter of compression. So the important thing to remember is that we need to take the measurement which shows us the highest value. And immersion is the gold standard, but it is cumbersome and it is difficult to do and it requires training. But definitely it is more accurate as compared to your applanation readings. So in immersion biometry, you use the scleral shell and then use the saline and then take the readings without indenting the cornea. And also remember to change the setting to immersion on the A-scan machine. So as previously stated, if you are using the contact technique, on an average, the readings are 0.27 millimeters shorter than those obtained by using the immersion technique. And so the IOL power that you are getting will be around 1 diopter stronger. So you need to keep that in mind, take multiple readings. And it's very important to look at the graph that you are getting, whether the spikes are perpendicular, and you need to get 4 spikes, the anterior, the cornea, the lens, and then the retina, and then the sclera and the fat. So you need to get all these spikes, which would show that you are getting a correct reading. Coming to the keratometry mainly changes in the first 6 months of age, and also girls have a steeper cornea than boys and steeper in cataract size, including the unilateral cataract and those with PHPB. Most significant changes are in the first 6 months. So in older children, it is possible to take awake measurements, but then in very small children, we have to do it under general anesthesia using a handheld orthokeratometer, and that is taken soon after the induction of anesthesia using saline to avoid corneal dryness related poor readings, and without the use of an eyelid speculum. So take multiple readings until you get 2 or 3 readings within 1 diopter, and you can select one reading from that. So as you can see here, one second, I'm sorry about the volume. Yeah, so this is readings which are being taken in our theater just before the surgery. So here the axial length measurement, the eyelid speculum is not put. You have to concentrate on the type of graph that you are getting and take 3 readings and take the one with the highest value. And here we are using the handheld orthokeratometer to take the keratometry readings again just before the surgery. And here, this is the calculation being performed. And so always it's important to take readings of both eyes. So you have to compare both. And if there is a significant difference between the 2 eyes, again, you have to keep that in mind and check your results. And coming to the optical biometry, the IOL master and the lens star are the 2 instruments being used. The IOL master uses the partial coherence interferometry technique, and the advantages is it is a non-contact technique that is increased accuracy and definitely provides more information. And so here you can see the IOL Master 700 being performed. The nice thing about the IOL Master 700 is it captures and gives a lot of information, including the OCT type of images, where you can see the anterior chamber depth, the corneal thickness, the white to white, the lens position, and you can make out primary posterior capsular dehiscences even preoperatively. And in this video, you can see the undercorrection being performed where you choose the target refraction. As you can see here, for example, this is the target with 0, we are getting plus 17, whereas with the target of 2, because the child was around 6 years of age, it is coming around 14.5. So this kind of measurements can be performed in older children who are cooperative to sit and in the IOL Master 700. And here in older children, nowadays we are preferring the Barrett's formula to calculate in our hospital, but SRKT and other formulas formulas as per the surgeon's preference, whatever is their preference, it can be used. And for the newer generation formulas, the advantages, they are taking a lot more readings. So the more number of parameters that is taken into account, the more accurate the results may be. And there has not been many surprises in the older children, but we are not using that for very young children also. So the theoretical formulas are definitely preferred over the older generation regression formulas. SRKT and Holiday 2 had the least predictive error according to a study performed by Vasavda sir a few years back. And Hofferque and Holiday 2 can be used for short axial lengths, and SRKT and Holiday for longer axial lengths. For short eyes, cutoff less than 20, and for longer eyes, cutoff more than 24 can be used. And we are mostly using the SRKT for very small children and Barrett's too, when they can sit on the IOL master. So how to undercorrect? Again, there are a lot of tables available. We find the Wilson's and Trivedi table to be the most comprehensive one, which has the target for each age. In the first year, even less than 6 months, and 6 to 12 months, we have the values. But again, we can modify it a little bit based upon whether it's a unilateral or a bilateral, and if there is a history of parental myopia. So you can modify it and tweak it slightly. So the factors to keep in mind would include the age at cataract surgery, status of the fellow eye, acuity, expected compliance, parents' refractive error, microphthalmia we won't usually place, and whether it's a bag or sulcus fixation. So take note of eyes that are very short and very long, especially in myopic eyes. You may be having a posterior staphyloma that you can make out in the IOL 700 with the fixation, and always measure between both the eyes and repeat if you find a significant difference, or if the consecutive measurements differ by more than 0.2, and repeat if the difference in the total K reading again differs between the eyes. And always you audit your results and aim for consistency in the biometry. And whenever you get a surprise, we should look at the reasons behind it, and that way we can come to better treatment protocols for these children. Thank you.
Thank you, Sandra. That was a very elaborate discussion on biometry and pre-op evaluation. We'll have the panel discussion end after all the presentations. Next, we have the keynote address by Dr. Arun Samprathi. He'll be talking about surgical management of pediatric cataract. Dr. Arun Samprathi did his postgraduate from Mysore Medical College and Arun Eye Hospital. He worked as a senior resident and then as a consultant at Arun Eye Hospital, where he specialized in pediatric ophthalmology and squint. He passed his FRCS from Edinburgh in UK in 2002, and later underwent training in strabismus at Walton Eye Hospital in UK. Dr. Samprathi has numerous scientific papers and presentation to his credit. He served the Karnataka Ophthalmic Society as the chairman, scientific committee from 2007 to 2009. He's currently running his own center, Samprathi Eye Hospital and Squint Center, which specializes in treating squint and childhood disorders. Over to Dr. Arun Samprathi.
Thank you, Dr. Thomas, for the elaborate introduction. I first of all thank Ksos and the Kottayam Ophthalmic Society, and especially Dr. Thomas for giving me this opportunity today to speak about surgical management of pediatric cataracts. So as we all know, pediatric eye is not a miniature adult eye, and there are a lot of challenges compared to adult cataract surgery. Important ones are the intraoperative difficulties because of the thrust and the elasticity of the capsules. They are more prone for inflammation in the postoperative period, poor cooperation, as I think Dr. Sumita was telling in the last session. Susceptibility to amblyopia because they're in the critical age of visual development, so they are highly prone for amblyopias, changing refractive state, and of course the high incidence of posterior capsular opacification. So the preoperative workup, Dr. Sandra has given a wonderful description. I don't want to go to the details, but I would like to emphasize the counseling. The pre-op counseling of the parents is extremely important, because pediatric cataract surgery is not a fill it, shut it, forget it surgery like an adult cataract surgery. The surgery is only 50% of the job done, as Dr. Thomas has very clearly mentioned. So parents should be ready for a long haul, means they should be given a good idea about what is the surgery, what is the postoperative management, what is the visual rehabilitation we are planning, whether it is an aphakic or an intraocular lens or contact lens. So everything has to be discussed, and parents have to be clearly told that this is not a short-term treatment, just a surgery. It is throughout almost at least till the teenage age, we have to be very careful with the follow-ups. So there are mainly two steps in pediatric cataract surgery. One is managing the anterior capsule and second is managing the posterior capsule. Coming to the options, the most commonly done is the phacoaspiration with PCIOL with a primary posterior capsulotomy and anterior vitrectomy. But however, in very young infants, we may not be able to implant an intraocular lens, so we just do the phacoaspiration with the PPC and AV. Very rarely in patients who have some ectopia lentis and other conditions, we may have to go for a lensectomy. Instrumentation is very, very important. You can see here the wonderful good red glow. This is very, very important because if you have a good glow, you can do a very beautiful rhexis. So good microscope with a good coaxial illumination is very important. Here I am using the this thing from OmniGlow. I don't have any financial interest with that, but it's a wonderful innovation. It gives a very, very clear red glow and the rhexis becomes very easy, and many times even you can do without trypan glue also. The other important is the anterior vitrectomy machine. You should have a good vitrectomy machine with a good cut rate so that you can do a good anterior vitrectomy. Micro-rhexis forceps and scissors are also important because they play an important role in critical conditions. High molecular weight OVD like a Hilon or Hilon GB is very useful. And most important, you should have a good anesthetic team who understands your requirements, because if they can give you a soft eyeball with a good deep anesthesia, your surgery becomes much more easier. Coming to the first step, that is the incision. Incision sclera is very elastic and the sclera has a very low rigidity. So previously we used to do only scleral tunnel incisions, but of late most of us have switched to clear corneal tunnels also. I normally prefer a superior side because it is covered with the lids and safer in a child. And I always prefer to suture the tunnel at least up to the age of 6 years, because even though we are making the same incision in an adult, we are not suturing. Sometimes in adult child, because the child rubs the eyes, the chamber may collapse, plus the low scleral rigidity also contributes. The next step is the anterior capsulotomy. Anterior capsulotomy, here we have to remember that this capsule is not like an adult capsule. It's highly elastic and tends to always run away towards the periphery. So you'll often tend to end up with a runaway rhexis. So that's the reason we have to plan for a very small rhexis and deepen the chamber with a good high molecular weight viscoelastic like a Hilon, so that if you have a flat capsule, it will be easier to get a good rhexis. And trypan blue usage definitely enhances. One is the visibility, and the second thing is it also makes a difference in the texture of the capsule. It makes capsulotomy easier. How can we do the rhexis? We can do in whatever way we are used to in adult cataracts. Either we can use a cystitome to do it, or you can do a utrata forceps, or sometimes we may need to use a vitrectomy cutter also to get a good rhexis. So again, coming to the technique of the anterior capsule, we initiate a small nick like in an adult dressing, but you should be very, very careful because it tends to run away. So you have to repeatedly grasp and re-grasp the edge of the rhexis, and your tension should always be, the pull should always be towards the center. So if you plan for a 4 millimeter rhexis, you'll ultimately end up with a 5 or 5.5 millimeter rhexis. So here again, you can see the importance of a good red glow. So if you're having a good red glow, you can see the margins of the rhexis very clearly, so that you don't end up with a runaway rhexis. And that is the completion of the rhexis. This is another case of pediatric cataract. They're doing a rhexis. So repeated grasping and re-grasping of the edge is very, very important. And unlike in an adult where we can just go one quadrant at a time, here it's very, very important that repeatedly you just catch and re-grasp. So you can see here, gradually you are pulling towards the center. The traction should always be towards the center. And sometimes you may not be able to complete the rhexis. Then I use a micro rhexis forceps through the side port, and you can complete the rhexis. So anterior rhexis is extremely critical in pediatric cataract because this facilitates implantation of the lens in the back, and thereby we can reduce the postoperative inflammation and all the complications. Sometimes you may have a very fibrotic capsule with a lot of calcifications. where you may not be able to do a normal rhexis with either the needle or the forceps. So in such cases, we can use a vitrector itself to make a nice anterior rhexis. Definitely the tensile strength of this edge of the rhexis will not be the same as that with a needle or a forceps, but you can get a good round rhexis so that you can facilitate a in the bag implantation of the IOL. So you can see here, after the cortical wash, a nice round rhexis is there, and we can implant a lens in the bag in this patient. This is the IOL implanted inside the bag. Now coming to the IOL placement, as I already emphasized, in the bag is very, very critical because uveal tissue in a child is highly reactive, and in the bag placement significantly lowers the incidence of post-operative uveitis and its complications. IOL power, I would like to skip these slides because Sandra has given a wonderful description about the power calculation. And material which we use is normally the hydrophobic. Previously, we were preferring the PMMA lenses, but now the shift is towards the hydrophobic. Hydrophilic, we normally tend to avoid in children. Square edge lenses definitely reduce the risk of PCO, and foldable lenses can be used with the smaller incisions, so they are preferable. And as I said, in the bag implantation is necessary. So normally we use a 6mm optic with a 10 to 11 to 12mm overall length. But of course, if it is a smaller eye, you have to make the this in white to white measurements and accordingly adjust the diameters. Multifocal lens I'm presently not using. I don't have much experience because the changing refractive state in the child negates the whole purpose of using a multifocal lens. But there are some people who are using multifocal lens in pediatric cataracts as well. Coming to the next and the most important part of the pediatric cataract is management of the posterior capsule. I would like to say this dialogue for all the residents or postgraduate students there. Any child below the age of 6 years, if you do not have an access to an automated anterior vitrectomy machine, please do not do a cataract surgery, because your cataract surgery will make the opacity 100%. If the cataract was only 50%, by doing a surgery and leaving the posterior capsule unattended, you will make it a 100% opaque visual axis. So you should never attempt a pediatric cataract if you don't have access to a vitrectomy machine. I do the posterior capsulotomy with the help of a vitrector because this is a very easy and very controlled rhexis you can get. See here, I just make a small nick and then go ahead with a vitrectomy probe and make a round rhexis, whatever the size we need. So normally we make about 3 to 4mm posterior capsular rhexis, whereas the anterior rhexis will be about 5 to 5.5 millimeters. So the posterior rhexis will be a little less than the anterior rhexis. So it's very important to clear the vitreous also. Just doing a capsulotomy is not sufficient. You have to do a anterior vitrectomy so that there is no scaffold for the cells to accumulate and cause the visual axis opacification. Some people also do this posterior capsulotomy with the help of a needle and a forceps. So it depends on the preference. So there again, you can do it either before implantation of the IOL or after implantation of the IOL. But managing the posterior capsule is the most important step in pediatric cataract surgery. And lastly, the suturing the wound is necessary because, as I said, low scleral rigidity and the children have a tendency to rub their eyes. So I always, at least in the children below the age of 6 years, I always suture the wound. And I, in fact, even suture the side ports also, just to ensure that we don't have a shallow chamber post-operatively. So post-operative medication, one thing I forgot to tell during the primary posterior capsulotomy and anterior vitrectomy, there you can also use a tricot to get this thing. If suppose some strands are coming out and getting into the anterior chamber or to the side port, you can use tricot to ensure that you've done a meticulous vitrectomy. Regarding the post-operative medication, with the present day equipments and the meticulous surgery, we don't need the use of oral steroids. Previously, we were using oral steroids for all pediatric cataracts, but it's now not necessary considering the side effects which can, systemic effects it can cause. So topical steroid, almost similar to the adult dosage, is sufficient to take care of the inflammation. We can use cycloplegic agents to keep the pupils dilated so that we can prevent the formation of posterior synechiae. So as Dr. Thomas has very clearly told in the introduction itself, surgery is only 50% of the job done. Follow-up is very, very important, and here comes the importance of the parental support. So parents need to understand that pediatric cataract surgery is not like an adult surgery. So the most important we have to look for is the secondary glaucomas, which can happen anytime, even after 1 decade. I have seen secondary glaucoma developing after the cataract surgery. Uveitis, PCO, amblyopia, and of course the chances of retinal detachment. So visual results depends on, as Dr. Sandra has highlighted, the timing of the surgery and whether the cataract is unilateral or bilateral, the surgical technique, associated anomalies, and the aphakic rehabilitation and the cooperation of the parents in management of the amblyopia. Especially unilateral cataracts are very, very difficult to handle, and parents should be very, very motivated to get good results there. So to conclude, the future trends search for newer techniques in wound construction and capsule management, new designs of IOLs and IOL formula to have a more accurate biometry, and techniques to prevent posterior capsular opacification without doing a anterior vitrectomy. So in conclusion, management of pediatric cataract is essentially managing the anterior and the posterior capsules, and surgery accounts only for 50% of the management. The rest is the follow-ups and the meticulous post-operative treatments. Thank you.
Thank you, Dr. Arun, for that excellent talk with excellent videos and very practical points for everyone. Thank you very much, Arun.
Thank you.
Next, I call upon Dr. Soumya to introduce the next speaker, Dr. Satya Ravila.
Am I audible now?
Yes, yes, yes.
So it's my privilege to be introducing Dr. Satya Ravila. She did her MBBS from Sri Ramachandra University. She was a gold medalist during her MS in ophthalmology at Arvind Eye Hospital, Madurai. And then she did her fellowship in pediatric ophthalmology and adult strabismus. Now she's heading the Department of Pediatric Ophthalmology and Strabismus in Arvind Eye Hospital, Tirupati. She has multiple publications in index journals like JAPOS and Community Eye Health. She has also been an author to book chapters in the famous books like The Payments Principles and Practice of Ophthalmology and in the AIOS CME series. She has won the first place in Lockdown Jugaad series for her innovation of X-Box, which is a collapsible aerosol box created during the COVID pandemic for safe administration of anesthesia. And another instrument by her is a squintometer, wherein she has innovated a prism holder for measuring strabismus, especially useful for large angles. She has been a part of an instruction course in the esteemed ACRS in New Orleans and ECRS in Paris. So I welcome you, madam, for your talk.
Thank you very much for that elaborate introduction, and thank you KSOS and Dr. Thomas sir for giving me this opportunity. So as has been, is my screen visible?
Yes, yes. Thank
you. As has been repeatedly been mentioned, pediatric cataract is much different from adult cataract. So I'm going to be talking about what next after the pediatric cataract. So as Arun sir has beautifully said, it is only 50%. The surgery is only 50% of the management of pediatric cataract. So it's cataract extraction and the IOL implantation, which can either be primarily done or done later when we are doing in a very young eye. We prefer to do the secondary IOL later. So I will be discussing about the secondary IOL and also about the other 50% in the management of pediatric cataract. So one of the most important thing is the spectacle correction, patching therapy if there's any amblyopia, all that we explain to the patient that we are only doing 50%. The rest of it is involving the family with them coming back for regular review to rule out glaucoma and to change correction or patching therapy as needed. And to put this in perspective, when we look at data from blind schools, and this is a study from 9 Indian states, where it shows that around 12% of the blindness was due to poorly managed cataract, either not operated or having uncorrected aphakia and any associated amblyopia or glaucoma still attributes. This is an old data, but even current data also shows it's around 7 to 8% in current blind schools. So that portrays how important it is in managing cataract after the surgery also. So to start with the spectacle correction, in very young children who do not cooperate for not verbal or do not cooperate for the Snellen chart, we rely a lot on the retinoscopy to decide on the glasses. And in aphakic corrections, we need to remember that we don't start bifocal immediately. So in less than 1 year, their world is more in the near vision target we will look at. So if they have a +20 retinoscopy, we can give a +20 glasses in itself. And in those with aphakia, when do we go on to a bifocal? So earlier we used to say 2-3 years. Now, even at 12 to 18 months, we can start on bifocal, because the children now, as we see, milestones are also much quicker. So they also have both distance and near target. So we can start bifocal around 18 months. In pseudophakic children, whether it's bifocal or progressive, unlike adults, children adapt to progressive lens quite quickly. So when we look at the bifocal adaptation here, it is also not a problem. They don't have the jump effect or anything. They do not complain. So the progressive adaptation, usually the decision here is based on the cost factor. So we say bifocal initially, and we have a stable diffraction and the child is understanding how to use a spectacle, then they can switch to progressive. And always remember that the family involvement is important in any of the spectacle correction in children. So the family acceptance is as important. Coming to amblyopia management, which is a main cataract. More of a concern when we have aphakia very young eye and we are only removing the cataract here. Remember that children will very well tolerate spectacle correction. But older children, we can think of contact lenses. In young children, the question of having a high power in one eye and a low power in one eye is the anisoconia is still quite adaptable in them. And also patching therapy needs to be adjusted on every visit. Coming to when to plan the secondary IOL. So we prefer to do it after 6 years, and most studies also recommend this. And also the other factor that we're looking at is stable refraction. So on the repeated visits, when we're seeing them every 6 months, we keep looking at their refraction. When we are going close to planning the surgery, we can also do a repeated IOL calculation around this time, but we still need to undercorrect. When we are planning a scleral fixation, it's better to go for this after 9 years of age, because the scleral rigidity is much better here. Early treatment should be considered in unilateral cataract or when the compliance with spectacle is poor. Following trauma, we want to plan early. Again, based on the age of the child, we'd like to put in an IOL early, especially when it's a unilateral, which will be the case in a trauma. But multiple sutures, we have to wait for the sutures to be removed and then keep doing repeated A scan until we get a stable A scan and to plan surgery in such a situation. And based on the support, we can also do a single haptic fixation. But also remember, during the secondary surgery, we need to make sure the visual axis is clear. And in such cases where there's a central scar, we can also plan for a bit of increasing the pupillary size, like an iridectomy here. Coming to what type of IOL to place and how to fixate it. So the most preferred IOL in a secondary IOL would be either the PMMA IOL or the 3-piece acrylic IOL. So to begin with, in the bag placement of the IOL is theoretically the ideal to do, but is often cumbersome to do in this when you do it as a secondary surgery. So whenever possible, we can open up the bag, remove the Sommer ring, pearls and all that, and then try to place the IOL in the bag. But again, there is a risk of disturbing the vitreous too much. So the next best place to place it is in the sulcus, and this can be done only if you have inadequate capsular support. Our options are the iris fixation or the scleral fixation of the IOL. Going on to sulcus support of the IOL, and I'd like to thank Dr. Fatima ma'am for these videos. So as I said, this is the next preferred site because this is as close to the anatomical location of the IOL, whatever IOL calculation we have done, but we still need to take into account that we are placing it a bit anteriorly and need to undercorrect for this also. So always do any synecholysis to ensure that we have opened up the whatever area is there to place the IOL. We ensure both haptics are placed within the capsular rib. The advantage of this over the scleral fixation is that there is no suture extrusion of haptics. We can also place a 3-piece acrylic IOL. I prefer also in cases where there's a small pupil to use iris hooks and then open up the iris so you can see, visualize exactly where your haptics are going and you're placing it in the sulcus. And whenever possible, we try to capture the optic into the residual capsular opening. So this helps in preventing any decentration and therefore better visual outcomes. Iris fixation can either be done with an iris claw IOL or a single haptic iris fixation using a suture. And this is the preferred technique when you have adequate capsularum on one side and inadequate capsularum, but good iris tissue. In such cases, we can go for this iris fixation, which can be single haptic. In this case, it's being done on both haptics. So you can see the needle is being passed through the iris, removed through the main tunnel. And after you do this, we pull the sutures out using a Coughlin's hook and then twist it around the IOL. So once we secure the IOL on one side, we can then, as you can see now, the IOL is being secured to one side. So once it's being secured, and when you tie the second knot, you can ensure centration of this. Moving on to iris claw IOL, we have prefer to do the retrograde. So we suture it behind the iris in such cases. An iris fixation, this is a much quicker procedure. So the optic is about 8 mm. I mean, the entire optic, entire diameter is around 8 mm and the optic is around 5 to 5.5. This one is an XL lens that is made in India. So we hold the IOL in place and use a Sinski or a spatula through a side port to tuck it into the optic. This is a quick surgery that can be done, but we do not know the very long-term effects with the iris claw IOL. So studies have shown that, there are studies, but we do not have very long-term effects. So most of the studies have shown that there are no serious complications. In the early complications, they are wound leak, hyphema, most of which resolve over time. And when they look at endothelial cell count, it was higher in the first year and drops over 3 years, and whatever complications seems to stabilize over 3 years. So we have been seeing good results even with the iris claw IOL in children. Coming to scleral fixation IOL, in a sense, longer follow-up that we have seen over the years compared to iris fixation, this seems to be an ideal option to go for. We'll have better centration also and less irritation because the iris tissue is not being manipulated here. But we have to wait for 8 to 10 years so that we know that the scleral rigidity is better to hold it. So the earlier thing was using a transscleral fixation with sutures. Now it's mostly without sutures that is done. It requires more expertise, but has no significant complications post-operatively. So to conclude, one of the things that we have to look at for is the prediction error when we're doing secondary IOL implantation. So you see IOL master whenever possible. And now that we're doing secondary IOL, it's in older children. So it gives us an option to do the IOL master, much better chance of doing IOL master in older children. And whenever we're going to place in the sulcus, we need to remember to undercorrect for that. And whenever possible, we need to look for in the bag placement. Thank you once again for this.
Thank you, Dr. Satya, for that excellent presentation. Now we are running short of time, so we'll have a short discussion. Dr. Rajesh, you have anything to say?
I think, sir, almost everything is covered.
Dr. Meena?
I have a question for Sandra. What is the prediction error like? Most of the cases when we try to undercorrect, post-operatively what we see that most of the patients are emetropic. So how to explain that? I have seen in many cases, like we try to undercorrect, but still we see it's a good thing, but still what could be the reason?
I think most of the surprises that we get are in very small children. Like when we do the evaluation under anesthesia, the A scan readings could vary. So because if you use immersion compared to applanation, we are using applanation only in our center. So sometimes there are, we predict, for example, if we predict a +7, sometimes it comes a little lesser than what we expect. So that could be because a little more than what we expect. That is because of the compression errors that with the A scan. But in older children, if we are able to take awake measurements with the IOL master, we do not see that many surprises. Most of the times it is within plus or minus 0.5 of what we are predicting. But in the very young children, less than 2 years of age group is where we sometimes come across surprises.
Dr. Satya was mentioning like they do secondary IOL at about 6 years of age. Don't you think it's a little too late?
I said 5 to 6 years. Again, I prefer to be a bit conservative so that we know that the refraction is a bit stable, but we will poor compliance to spectacles.
Again, for a bilateral, I think I wait till 8 years of age. So for bilaterals patients, I think more you wait, better the results are. For unilateral, it's totally different scenario. You have to start thinking about putting a lens right from second year of age. For bilateral, I think we can wait till the metroposition is completed.
But we used to see so many patients who come with nystagmus when the IOL is.
She has mentioned again, madam, there is a poor compliance or any other signs which shows anything vision is going to be less. You can intervene early.
So, all this IOL power, what we are doing, no, it's mainly for before 8 years. So in our hands, we have seen that we usually put by the time the corneal diameter is 10.5. And no other risk factors we put at 1 year. 1 to 1.5 years we usually put.
Even in bilateral?
Yes. There's no difference in bilateral or unilateral.
Secondary IOL. Secondary IOL or
secondary IOL. And if it is coming at that age, we immediately put you don't go for a secondary as a primary procedure. We put. 1 year is usually taken as the cutoff and a corneal diameter of 10.5.
No, I'll be definitely more conservative. I'll not be so aggressive to put in a 1-year-old secondary IOL. I agree with Dr. Satya. 5 to 6 years is usually the age even I go for secondary IOL, because you want the refraction to stabilize, because first 2 years especially, the refraction will be changing very rapidly. So the whole idea of making the child aphakic and then going for the secondary implantation is defeated if we try to go and end up with huge errors.
Yeah, but we have been doing it for more than 10 years now. So okay, it's like we get very good results.
Okay.
And also about the iris claw lenses, somebody have any opinion? Like we have seen that iris atrophy is very common when we do it in children at the site of enclavation. So can any one of you can comment on it?
Like I said, ma'am, we also prefer to go for serial fixation whenever possible. Yeah. That is where we know that the long-term results are much better. But that single haptic iris fixation, I have done in quite a few cases when there is a good capsular support on one side. With iris claw, I will agree with you. In pediatric, I would be very concerned.
That what you showed, no, that's really good. Single point fixation. We usually don't do that. And what we have seen with the iris claw lenses, there is so much of pseudophacodonosis we see.
Yeah,
unlike it is more stable with a scleral fixation. So when it is an iris claw, especially we do in cases of subluxated lenses, no? Yes. In cases where we can't put a normal IOL. So many cases we see pseudophacodonosis. So in my hands, I have felt that scleral fixation is a better option in children.
Even the patients complain of that. Vision
some
fluctuating
patients complain, and sometimes you can see that there can be an optic capture also when the lens moves too much. And a trivial trauma can cause a detachment of one of the haptics. So scleral fixation, I feel, is a better option than iris claw lenses.
That is very much true, madam. Iris claw is the last option. I mean, amongst all these lenses available, iris claw will be my last option.
Yeah, true.
Traumatic, I just wanted to ask Dr. Satya, traumatic cataract, you do the surgery in the first go, or you wait for 6 weeks before you go in for surgery?
Would depend on the corneal scar. If the corneal scar was very minimal and astigmatism was very minimal, we can plan it even in the first. But if it's a larger scar and we put multiple sutures, I would wait for suture removal once we get a stable astigmatism. I would, in fact, have much closer follow-up for these patients, sometimes even every 3 weeks, because I also want to do early surgery, but also needs to balance within a stable refraction to get there.
Also depends on whether the anterior capsule is torn or not, because if there are a lot of cortex in the anterior chamber, then it's worthwhile doing immediately than waiting.
Dr. Sandra?
That can be aspirated immediately, but the secondary lens can be placed after the suture removal. Yeah.
Dr. Sandra and Kalpana madam would have got experience with toric IOLs in children.
Yeah.
Are you implanting regularly?
Not regularly, but over the age of 10 years, in select patients, occasionally we do implant.
Anyone having experience with multifocal IOL?
Yeah, multifocal also, sir, like a few patients like unilateral cataracts, which not with a good prognosis. Like if it is a blunt trauma or something like a small PSCC, which is unilateral, we go for multifocal or bilateral also, provided there is we are not undercorrecting over the age of 10 years. Like steroid induced, those cases without glaucoma and all. Like if their vision prognosis is, there are no other risk factors. Older children, few cases we have placed multifocal and it seems to have good results. But the number of patients is too few for us to generalize.
Even I have put multifocals, but I didn't get very good results. Stopped doing it now. I'm a little afraid to do actually. You put a small rexus and you can't even exchange the lens. So in children, I feel it is little tricky to go for multifocals.
In older children, not very young children.
Yeah, that's true. Older children also. I've done in a child who was more than 8 years of age. Anyway, maybe we are afraid of doing it, but maybe in the coming times it will.
So the near vision is pretty good. Like if you, if it is especially in unilateral cases, they are able to read unaided like N8 also. So like most often when we give the glasses, sometimes they don't use the glasses. So they are mostly doing like monofixation, like, you know, one eye for distance, one eye for near types. So I think in certain patients, whomever we have placed, we didn't have any situation where we had to explant the IOL or they didn't. Usually the children are tolerating better than others.
They don't complain. I think mainly the reason is children don't complain like the adults. No, the adults, we are afraid they come with complaints of glare and so many things. So maybe the child doesn't know to differentiate the difference or whatever. They don't complain. That is one good part of it.
Because they are not driving, so that is one major thing. Once they
compared to multifocal, I don't know whether you have this personal experience, because we have been doing regularly eye hands techniques IOL for children. I mean, I don't have personal, financial interest in that, but usually they do very good with near vision and intermediate vision. So in case patients are affordable, I think you think about this lens rather than going for a multifocal. Eye hands do really good in children.
BVT we placed few cases, similar results. So that seems to be EDOF lenses are also coming up in a big way now. Eye hands is having very good results in adults.
Yes, adults and children as well.
What is the amount of cylinder you correct for toric lenses? What's the cutoff limit for toric?
Sir, above 1.
Above 1 in children.
Children. Not for every case, only if it is fitting all the other criteria. Like not in very, whenever we do have to do a PPC and all, we are not doing, sir. Over the age of 10.
And high hands, is that for all ages or above certain age?
Because eye hands is good for even about 2 years. Eye hands is a very good lens for children. It's similar to Technis platform.
I think we have run out of time. Thank you very much, all the speakers and the panelists. Thank you very much for the good discussion we had.
Thank you, sir.
Thank you, Dr. Thomas.
Thank you, sirs and madams. The session was indeed full of priceless knowledge. With this, we are moving on to the final session of the day, which is on pediatric retina, a field which was ignored in the past but has gained momentum recently, and of course, is a challenging specialty. Let us hear what the best of the brains think about this interesting topic. For this, I invite Dr. Natasha Radhakrishnan, Professor and Senior Retina and Uvea Consultant at Amrita Institute of Medical Sciences. She has numerous presentations and publications to her credit and has a special interest in pediatric retinal disease. I once again welcome you, ma'am, to chair the session.
Good evening, everyone. Thank you, KSOS and Dr. Sreeni, for this opportunity to chair this session on pediatric retina. It's a pleasure to have as our keynote speaker today, Dr. Subhadra Jalali, who has done immense work in the field of retinopathy of prematurity. To introduce her formally, she did her MBBS from the Government Medical College, Jammu, and MS from PGI Chandigarh. She completed her 2-year fellowship from LBP and further fellowships from the USA in ocular genetics, visual electrophysiology, and ROP. And presently, she is in LBPI since 1993. She was one among the first group of pioneering women in India to go for retinal surgery, and she has over 800 presentations, including orations. She's a co-investigator in various multicentric international studies and a recipient of state, national, and international awards, including the AAO, APAO Achievement Awards, the ISCEV Travel Grant, the P. Shivareddy Award, to name a few. Her crowning glory, she claims, however, is the 350-odd trainees who have trained in ROP under her from Mexico to Azerbaijan to Indonesia to Bangladesh to all over India. We all know her as a favorite dancer during our AIOS conferences, and she loves to dance. And along with that, she is known for her slogan that she has introduced in ROP, which is 30 din roshni ke, which means in 30 days, if you screen for ROP, you can save the vision of the child. So with great pleasure and excitement, let me welcome Dr. Subhadra Jalali to this session to give us our keynote address on 30 years of expertise in the field of ROP and lessons learned. Over to you, ma'am. The rest of the panelists and the speakers I'll introduce as the turn comes. Subhadra, ma'am. Ma'am, are you here? Subhadra, ma'am? Subhadra Jalali, ma'am? I think we are about 10 minutes early. Maybe that's why that she has not switched her video on. Are all the panelists here? Dr. Sunil, Dr. Dhrumil?
Yeah, ma'am, I'm here.
Dr. Sheera is here. I can see her.
Dr. Anubhav, I'm here, ma'am.
Dr. Anubhav. Hi, everyone. I think ma'am is waiting for, probably thinking that it's 6 o'clock to start. Let me introduce the Niranjan. Are you here? Niranjan was here actually. He has some electricity problems, he was saying, so maybe he's just logged out for some time.
Natasha, we can start with any talk speaker who is available. We can start the talk, and once ma'am joins, her keynote address can happen.
Okay, then I'll go on to my talk.
Yeah.
Oh. So my talk is on pediatric retinal disorders, a window to systemic diagnosis. Is my screen visible?
Not yet.
Now?
No, Natasha. Yeah. Yes, Natasha.
Good evening, everyone. So my talk is on pediatric retinal disorders, a clue to systemic diagnosis. We are going to see a wide range of diseases in which pediatric retinal examination can give you a clue, as in genetic and chromosomal anomalies, phacomatoses, metabolic disorders, infectious diseases, craniofacial anomalies, muscular disorders, inflammatory disorders, and some miscellaneous rare ones. Let me start with a case, a 12-year-old girl with progressive lower limb weakness. And now when she came to us, she was wheelchair ridden, a daughter of an NRI staff nurse, so extensively investigated outside, but ophthalmological examination was never done. And the fundus examination showed this classical fundus picture, which is a cherry red spot. You can see the classical yellowish white appearance with the dark brown red appearance of the center of the fovea, which was there in both eyes. And this particular patient had mucolipidosis or sialidosis, but other differential diagnoses include Tay-Sachs, Niemann-Pick's GM1 gangliosidosis. This is another baby, a 3-month-old baby with failure to thrive. And it was a retinal examination that gave the clue that this patient is suffering from hypertriglyceridemia. This is lipemia retinalis. You can see the light pink colored vessels, both arteries and veins. We should remember that lipemia retinalis appears first in the periphery and then only in the center. So if it's only borderline elevated, you will find it only in the periphery. And it comes when triglyceride level goes above 2000 milligrams per deciliter. And this was the other fundus eye picture. This patient had familial LPL deficiency, and a dietary modification, if instituted early, can save the life of the child. These siblings were sent to us for evaluation of ataxia. Progressive ataxia with the elder child was wheelchair bound, and the younger one was then showing the same symptoms. And this is what the conjunctival picture was, which is telangiectasia of the conjunctiva. And this child actually has ataxia telangiectasia, which is one of the autosomally recessive inheritance, Lewy-Barr syndrome, progressive ataxia with oculocutaneous telangiectasia. This is a very common finding that we find. This is iris coloboma along with the fundus coloboma. But when you see it in a newborn child, you must remember to think of Charge syndrome. Charge syndrome is when there is a non-random association of coloboma, heart defects, corneal atresia, retardation of growth, and ear anomalies. And it can affect vision if macula is involved, and often requires multi-system care because of all the systems that are involved. This is again a common picture that we find in our OPD when a child walks in with history of night blindness, sometimes some family history of night blindness. And this is a retinitis pigmentosa picture with the classical triad of arterial narrowing, disc pallor, and the proper bone spicule pigmentation. You can have it atypical when it is central, sectoral, or paravenous. You can have it white instead of bone spicule, then it is called retinitis punctata albicans. But we should always remember that retinitis pigmentosa, especially in its autosomal recessive appearance, has a lot of systemic associations, which include the A-beta lipoproteinemia with its classical the acanthocytes. Basen-Kornsvig or A-beta lipoproteinemia can have ophthalmoplegia, acanthocytosis, ataxia, and treatment is with vitamin E, A, K, and a low-fat diet. Phytanic acid 2 hydroxylase deficiency, which will have polyneuropathy, ichthyosis, cardiomyopathy. Again, dietary modification with a phytanic-free diet and plasmapheresis can help these children. Usher syndrome with profound deafness, early onset blindness. We should remember that 15 to 20% of all RP and 5% of all deaf children have Usher syndrome. Onset of RP will be delayed. It may be more than 10 years, and early diagnosis is sometimes possible only with the ERG. Prenatal counseling is of great importance since these children are deaf and blind at a very early age. Bardet beetle or Lawrence moon beetle was the old name. Polydactyly, obesity, short stature, and mental handicap are the signs that we can see in these children. They may have a typical bullseye maculopathy. The other causes of bullseye maculopathy in children and young adults are advanced Stargardt's, Batten-Mayu or neuronal ceroid lipofuscinosis, benign concentric annular macular dystrophy, autosomal dominant cerebellar ataxia, and Haller-Walden-Schwartz syndrome. The other group of conditions in which retinal examination and eye examination is very important is the phacometrosis. Here we have the classical tuberous sclerosis with its astrocytomas in the fundus. Of course, it's an innocuous finding when it comes to retinal findings, but it is of great use for the neurologist to prognosticate and to diagnose tuberous sclerosis. And this is Sturge-Weber. It is one of the phacometrosis that is non-inherited and is sporadic, but it can have grave eye prognostic problems with the onset of secondary glaucoma. This is the choroidal hemangioma with the advanced glaucomatous cupping in this child with Sturge-Weber, the normal other eye. This is another condition which we are often sent to screen for retinal angiomas, and this is in Born-Hippel-Lindau syndrome. You can see the retinal angioma with its feeder arterial vessel and the draining vein vessel, which is well delineated in a fluorescent angiogram. And this is, if you do not treat, it will go on to develop exudation and severe exudative retinal detachment. In the early stages, it can be easily treated with laser and cryo. In the late stages, it becomes very difficult to treat and can cause vision-threatening complications. This is a very common finding again that we find Lish nodules that are signifying neurofibromatosis. There's a subluxation of the lens in Marfan syndrome, superior subluxation and inferior subluxation in homocystinemia. This is another anterior segment finding that we are often asked to comment on, which is the posterior embryotoxon. It is a sign of Alagille syndrome, and the patient presents with neonatal cholestasis, where often the gastrosurgeon is stumped for a diagnosis. A simple eye examination will give them the clue that they are dealing with a syndromic child. Of course, KF ring is very common and very well known to everybody in Wilson's disease. This child with hearing loss, you can see she's wearing a hearing aid, 7-year-old girl, and this is the fundus picture. It is just a small mottling of the posterior pole, which is showing hyper and hypopigmentation, mainly confined to the posterior pole. There is no arterial narrowing, and you can see that there is no significant decrease in vision or night blindness, and that is a sign of salt and pepper retinopathy, suggestive of congenital rubella, and the picture will be the same in both eyes. In toxoplasmosis, other maternal infections can also be diagnosed by examining the eyes. In toxoplasmosis, you can have a punched out macular scar. In signs of intrauterine herpes and CMV, sometimes you can see as active retinitis in a neonate. This is the classical macular scar in a congenital toxoplasmosis. Congenital cataract and congenital glaucoma comes together in Loewe syndrome. This child, one of the rare cases that we have seen and in which we played a major role in the diagnosis, a 10-month-old female baby with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight. General examination showed pallor, edema over hands and feet, depigmented hair, hypopigmented scaly skin lesions, and oral candidiasis. This was the eye picture with a festooned pupil. The retina was not visible because of some cataract. This is the child was less than 1 year old, and bilaterally that was the same picture with a pupillary membrane and festooned pupil. There was microcytic hypochromic anemia. Skin biopsy showed ill-formed granulomas. Liver biopsy also showed granulomatous inflammation, and histology showed multinucleated giant cells and Schaumann bodies. Stool was positive for occult blood. There was granulomatous duodenitis, granulomatous colitis, and we had the Blau syndrome mutation was negative, and the diagnosis was infantile sarcoidosis. This child improved well with systemic immunosuppression and topical steroids, and she's presently a sprightly 3-year-old with near normal vision in both eyes. This is another story of 2 siblings, elder with progressive spasticity, mental retardation, seizures, and lamellar ichthyosis. The younger sibling is now having the same phenotype, and they came for investigation. The fundus showed multiple yellow-white dots at the fovea, which was absolutely symmetrical in both eyes and the same in both siblings. And this is a very rare condition called the Sjogren-Larsen syndrome, which is another neurocutaneous disorder, which early onset ichthyosis, progressive spasticity, and mental retardation. So an eye examination, and specifically a retina examination, many times provides a missing link in the diagnosis of many systemic disorders in children. But you need a close interaction with a geneticist, pediatrician, and often a neurologist when you need to treat these children, and a follow-up counseling and rehabilitation is absolutely essential so that they can have a near normal life. I thank you all for your patient hearing. I hope Subhadra ma'am has now joined. Thank you. Ma'am, are you here? Yes.
Yeah, I'm here only.
I would like to introduce you once more, ma'am, because actually you were not here when I was introducing you before.
was not unmuted. I was here.
No? Okay. Okay. We'll go ahead with your talk. Newborn eye health and ROP do's and don'ts. Over to you, ma'am.
Thank you. Sorry, that time, no, I could not answer.
No problem. No problem.
I joined on time. So thank you so much for that lovely introduction. And we'll straight away go to the talk. Thank you, everyone, to spend your Sunday evening here. So this is, of course, based on more than 30 years that we've been doing the ROP and other works. So the learning objective is to understand about eye health screening of newborns, because we cannot talk of ROP if we don't talk about the other newborns, and learn what are the best practices that we've picked up over the years and a basic management about the approach. So, we've come a long way from 1930s, and this is the time to say thanks to Dr. Cooney on this wonderful Mother's Day, who, took the babies from their mothers and put them in the egg incubators in, exhibitions, because he was not allowed to put them in the hospital. And he saved so many lives. And it was only in 1941, which was almost after 10 years, that Boston Children's Hospital allowed the incubator to come to their hospital. And immediately 1 year after that, the ROP blindness happened. And today we are in an era where at LV Prasad Institute we screened a 375 gram, 25-week survivor. So, so there's a great Mother's Day, and, great day for all those mothers who, have these very tiny, tiny babies. And it's our, pleasure to examine their eyes and treat them. So what I wanted to, show is that the premature babies, they have certain screening guidelines. So we are not going into the literature. We should all follow the RBSK guidelines. That is the Rashtriya Bal Swasthya Karyagram. And this is the book which is available free on their website, on the Government of India website. And we should all follow these guidelines, because these are consensus statement, both of the government and all the doctors who deal with children here. And it deals with various guidelines. So I'm just going to speak from that book, some of the important lessons that we should remember. So whenever we have newborns, ideally it would have been very nice if we were able to do a universal eye health examination of every newborn, including dilated fundoscopy, but this is not practical. More than 3 million children born, and we don't have that many ophthalmologists or people to go and see the retina, and a yield may not be high. But what we want to do is to triage all the newborns into 3 categories, and the higher risk categories will undergo all the procedures which the low risk category undergo. And I'll tell very briefly how we can triage and examine the newborns. And this is what we need to teach our health workers, whether it is Asha health worker or it is the pediatrician or pediatric nurses. So the basic thing is that at the time of birth, once the baby is stable, they should open the eyes, as we are seeing in this picture, and look at the eyes. And look, are the eyes normal? So, so if the cornea is hazy, or the eye is big or small, or there's some opacity, or the eye looks very deviated, or there's a eye which looks small and the other eye looks big. So these patients need examination. The more important is if there's any swelling around the eye, then these are emergencies. They need to be sent immediately. The other thing is beware about the skin changes around the eyes. Many times the pediatricians and nurses, what they see is the child has some watering, and because NLD block is so common or conjunctivitis is so common, they don't open the eye and they just put tobramycin or prescribe some antibiotic eye drops. I think it's very important to teach them to open the eye and at least look at the cornea. The cornea should be transparent, clear. So this baby here was treated almost a week as conjunctivitis before they thought of sending to us. And by the time we saw, child had pseudomonas, endophthalmitis, and scleral abscess, and that eye was already lost. So on their rounds, they can put a drop of plain tropicamide in these babies' eyes and try to look at the red glow and just see that the fundal glow is there. So besides a torchlight examination, a red glow test is very important. Niranjan is here and he has shared these slides. Many other slides also in this presentation by him. That this is how we can look at the red glow test. The child can be taken to a dark room, or we can put a drop of tropicamide and then look at the reflex. And usually we should be able to see a red reflex. And if the reflex is different in 2 eyes, or one eye has a white or yellow reflex, then that child needs urgent referral. So this is to be done right at the time of birth, and then at every health visit, at least once in 6 months. And of course, every time the mother complains, because it's the mother who will complain first, that there is some white reflex from the eye, we should not brush it aside. This is what we need to teach our pediatric colleagues, that they should dilate or they should refer. So coming to the triaging, so this torchlight examination, red glow has to be done in all the babies. After doing that, we will divide the babies into 3 groups. One is the low risk. These are normal, healthy term babies where there is no family history, no antenatal or intranatal or postnatal problems, and there is no non-syndromic status. So these babies can just undergo the torchlight and the red glow. That's all that is required. In the moderate risk, these are healthy term babies again, but there is either a positive family history of eye problems. So this question needs to be asked. Does anybody in the family have any eye problem? Any sibling was blind, or one of the parents' eyes is not functioning? Or there was any postnatal events like birth hypoxia or septicemia, DIC, or there's a syndromic state. So just few examples. So here we have, again, Dr. Niranjan has shared this from Vijayawada, that this younger child was brought to us for cataract surgery. And on inquiry, we found that 3 of the siblings were in a blind school because nobody had screened them for cataract. Whereas cataract is very much treatable and it could have easily been diagnosed on a red glow test or even an eye, torchlight examination when they were born. So here we have another case where the mother is clearly having an artificial eye on one side because she had eye removal. She doesn't know why it was removed, but nobody told her that your child can get some eye problem. And her child, a girl, after chemotherapy, you can see, has bilateral retinoblastoma. And, she went into very severe retinoblastoma, possibly lost her life because of metastasis. But the thing is that nobody told. So if there is a family history of eye removal in childhood, or there is a family history of retinoblastoma, then these children need to be screened right at birth by a full fundoscopy. Here we have FEVR. We have been working for many years on FEVR. This is an autosomal dominant disorder or an X-linked disorder like Norris disease. And this is the mother who was blind by the time she was 16, 18 years old. But we had warned her that her child is going to get the same disease. And the mother came to us immediately after birth. And we can see already the retina having some bleeding. And by treatment, they would not go blind. So this is just to say that if there's a family history of any eye problem, screening at birth with full fundoscopy is required. Not only that, in fact, if we have an idea that there is some sibling or somebody in the family who was born blind or developed blindness soon after birth, then antenatal counseling, maybe a genetic screening, and working with the parents during the pregnancy, and then deciding what is the best time to deliver and then treat them. There may be requirement of amniocentesis. So those things are required if the patient comes to us on time. So those dialogues have to be done. Incontinentia pigmenti again is a condition which does not have very clear-cut information of when to screen. So our experience shows that these patients can develop serious eye problems just like ROP, and the signs are very subtle. It is not a very obvious signs because they don't have the plus disease. They have only mild. So this patient actually has lost one eye and the other eye has avascular retina. So they need screening right at birth, and then repeated screening every 2 weeks should be done. And if any avascular retina is found, that should be lasered. And this could happen, like, you may have to see under anesthesia these children because these are usually term babies. They are big babies. You may not be comfortable examining them right away. And as I said, the findings may be very subtle. And, if we don't treat them on time very quickly, they can go into leukocoria and retinal detachment and then eyes loss. But if we screen them and found the problem on time with laser, they can do very well. So if the child has any systemic infection, so here we had a shunt which was put there and the eye looked white, and this patient was referred as ROP, but this is not ROP, this is endogenous endophthalmitis, leukocoria, fusarium. Or on ROP screening, this baby was seen, had Candida. This is a spot diagnosis, doesn't require any microbiology. Anything white, fluffy on the retina like that is Candida. It is treated by intravitreal and systemic antifungals and everything can clear. So if there is any periorbital swelling, this is a sign of very serious underlying infection, like I said, gram-negative infection. So, any child who has a red eye, they must not just treat by antibiotic. Always the eye should be open and seen. Again, we have here torch infections like herpes. The baby was told has conjunctivitis and mosquito bites, but actually had primary herpes. Nobody opened the eye. If they had opened, they would have seen that the cornea was not. So these are the second risk. And of course, the high risk are about premature babies. And we define them as anybody less than 34 weeks or less than 2000 grams, that is 2-3-4 rule, 2 kg, 34 weeks. If the baby is premature and more than 35 weeks, but they had other problems like, severe multiple blood transfusions or lung prematurity or sepsis, then even larger preterm babies need screening. So normally, if there was no event, then only 2, 3, 4 rule. But if there was an event and the baby was sick, then bigger preterm babies should also be screened. So we need to have our own guidelines. So here I am just showing this game of Coco, which doesn't, those who have played this game know that we win this game if we are very fast, quick and do a teamwork. And ROP is just like Coco. We have to do fast, quick teamwork. And we have to teach the others from other countries about how to take care of babies. We should not be following guidelines from countries where hardly any children are born. We produce the largest number of children in the world. We have the largest number of preterm babies. So we should be giving the guidelines of how to look after these babies. And we are very happy that the government of India under the RBSK guidelines has provided India-specific guidelines which have been based on evidence-based medicine. So it is the 2, 3, 4 rule. All the PGs, all the doctors, they should follow this 2, 3, 4 rule, 2 kg and 34 weeks. And if they don't know the gestational age, because a lot of our mothers don't know their last menstrual date, we don't know accurately, then even if the baby is big or unknown gestational age, but they think it is premature, then we should do the ROP screen. Now the screening not only for the prematurity, even if there is no other risk factor, but baby is just premature, even if they have not received oxygen, but even if the weight is more, but they are premature, they can get ROP. So prematurity alone is a major risk factor and a standalone factor. All premature babies, as we defined, need to be screened. And we should not think that because the baby was healthy or did not get oxygen, they cannot get ROP, they can still get ROP. So birth weight is only a surrogate measure if the baby is less than 2 kg. But if baby is premature and 2.5 or 3 kg, still they can get ROP. Now, if the mother has received antenatal steroids, and we are very happy that in India, there is a Janani Suraksha program under which all the pregnant mothers should receive antenatal steroids if they are high-risk pregnancies, and this is given in second trimester. Then this also prevents lung problem and it also protects against ROP. So this question you should ask the parent whether the mother received any injection for lung maturity. If there is poor antenatal weight gain or maternal anemia in the mother, then it can cause more severe ROP in that mother. And if there is fluctuating or unblended oxygen, then they can get more ROP. So these are only surrogate measures. As I said, prematurity alone is the major factor. Now, once the baby is going to have ROP or we want to prevent ROP, that is the secondary prevention of ROP. Of course, primary prevention is not to get premature delivery, but that is not happening. We are actually getting more premature deliveries because of all the IVF and strict monitoring of the baby, and we are delivering babies early. So the secondary prevention can happen by systemic management. The ROP is not an eye disease. It's a systemic disease which is spilling over into the eye. So if we perform the systemic management of preterm baby at a high quality care, then they will not get ROP, or even if they get, they will get very mild ROP. So the basic thing is the lungs and the oxygen policy. The lungs are directly related to the eye because lungs require VEGF for maturing. So if the lungs are immature or lungs have infection or there's pneumonia or their child is not breathing well, then they will deliver a lot of VEGF into the bloodstream from the lungs, and that will come into the eye and create problems in the eye. So the education of the nurses, the number of nurses which are there per baby is less. We don't have enough nurses. So we need to educate the nurses that at least the small baby, the sick baby, the baby with the abnormal retina needs to have very strict oxygen control policy, only blended oxygen to be given. And the pulse oximeter reading should not go beyond 93%. It should not show 95 or 98% or fluctuating oxygen when the baby is on oxygen and the pulse oximeter is there. So always blenders. Again, blenders are very expensive. We are very happy again that there is an attempt in Hyderabad by the Fernandez Hospital to build Make in India blenders, and very soon these should be in the market, and then the cost of this care will come down. The other thing we have to discuss with our gynecologist and our pediatrician is that in the first golden hour of birth, the practice usually is that as soon as a baby is born, especially if it's a preterm baby, they immediately put that baby on oxygen without realizing whether the baby requires or does not require oxygen. So this is a very bad practice. It causes very severe ROP. So what they need to do is that once the baby is delivered and they clean the baby, they should put the pulse oximeter and watch for 4 to 5 minutes and see what is the oxygenation. And there are international guidelines as to when to give oxygen, when not to give. So, this practice has to be improved, the labor room practices of how to give oxygen. And then, of course, the hematological monitoring is very critical. So many times I get phone calls from my ophthalmology colleagues that I have done laser or I have given Avastin and the baby is not responding, the ROP is not going. The reason for that is that we have not taken care of the anemia. The moment baby comes to you and you see there is some ROP, please get hemogram done, and the hemoglobin should at least be 10 or more. If it is 6, 7, 8, they need a transfusion or they need some treatment. Otherwise, your ROP will worsen and the ROP will also not, resolve with treatment. And even if it resolves, let's say with anti-VEGF, it will come back. So the oxygen, lungs, and anemia, they are important. Again, the infection control and sepsis is extremely critical. The hand washing, barrier nursing. And then there's something called bundle care. Bundle care means, in the crib, the baby is there. It requires a lot of rest. It should not be handled multiple times. So if there are multiple procedures to be done, let's say 2D echo has been done, ROP screening has to be done, blood sample has to be taken, some nasal secretions have to be collected. So all this should be done at one time. And the whole team should be there. They should do all this, and then they should allow the baby to rest. So it should not be that multiple times we are intervening and disturbing them. So weight gain, again, there has to be a nutrition policy. The express breast milk is best. And we are now very happy that many places have started having the milk bank, where those mothers who cannot produce milk, they can take from the milk bank and give to the baby. So express breast milk is best. So every 1 or 2 hours, the express breast milk to be given to the baby, and that improves the weight gain. And if there is a slow weight gain for whatever reason, or there is a prolonged weight loss, these are the babies who are going to get very severe ROP. So all these should be discussed with the parents when they come to us for screening. Now, other important thing, what we learned is that check the baby at every interaction. These babies can suddenly die because of hypoglycemia or hypothermia. So make sure that the mother has fed the baby. Baby is burped, baby is not hungry. Sometimes they have traveled long distances. Baby has vomited on the way and baby is lethargic. Then make sure that, somebody is looking after the baby. And that the baby, this I just wanted to say, check the baby at every interaction. We had a condition where the optometrist has put the dilating drops in the waiting hall, and after 15 minutes, when the fellow doctor went and brought the baby, it was already dead. And when we asked the optometrist that when you put the drops, was the baby alive? They had no idea. They didn't know whether the baby moved their eye or moved their head after putting the drops. When we asked the mother that when the optometrist put the drops, was your baby alive? She had no idea. She didn't know. She was carrying the baby. When I asked her, when you brought the baby to the hospital, when do you remember last, noticing that the baby is alive? She had absolutely no clue. So nobody knew that in the last 45 minutes, when was the baby alive? Did it arrive dead in the hospital? Did it become dead after the drops? Did it become dead before the drops? So this is something very shocking. So I think it's very critical that all the health team members, you should move the baby and make sure baby is okay. General condition is good, then put the drop. Again, tell the mother to watch the baby, watch the respiration, watch the movements of the baby. Same way after screening, during screening, after handing over the baby to the nurse in the NICU or completing your screening in the NICU, call the nurse and hand over the baby to the nurse and tell her, please check the baby. It is okay. When you hand over to the mother, so every time at every interaction, speak up. If you find baby lethargic, a couple of times I found baby lethargic and the fellow doctor is like, madam, it seems that the baby is lethargic. No, you have to raise an alarm. You have to be very proactive. The moment you see baby is lethargic, immediate action has to be taken. Baby should not be lethargic. They should be, moving and healthy when you're examining them. Otherwise, you cannot examine a baby who's lethargic and dull. So then coming to the how to dilate safely. So again, we should put the proper eye drops. We should watch the pulse and respiration. And a pain relief can be given during the screening process or during the laser. Sucrose pellets are now available in our hospitals and in the country. So this is having very good pain relief. Even paracetamol drops are available for babies for pain relief. But if you are giving paracetamol drops, you should know what is the dosage. For most of the tiny babies, it's just 1 or 2 drops. It should not be like half TSF or 1 TSF or whatever you like. There's a specific dose which is weight-based for every baby, but these are good pain relief measures. Now the recent advances are the ROP cameras. So many types of cameras are there. The RedCam shuttle was the first one. The problem is it is very big, expensive, difficult to move, and the servicing is not all that optimal. Now we have this MI RedCam. It's a simple holder to hold the 20D lens and take pictures on a smartphone. And this can be used in places where we don't have big cameras. We have also tried to make an endoscopic camera. Then you can also use a flying baby position and use your adult cameras. So these are on the Claris. Our team along with Dr. Akash has taken. This is by Dr. Sushma She's now in Bhutan, and she, along with Komal, they use the Optos machine. So many cameras are available. The more popular now is becoming our own made in India Forest Neo Trinetra camera, which is both FDA and Euro marked. And this is still it is 12 lakhs. We hope that it will come down 12 to 18 lakhs, but this is something very useful. But if you don't have a very specific camera for the ROP babies, as I'm showing here, there are multiple other cameras which can be used to take a picture. If you take a picture and show to the parents, their compliance becomes better and they understand better what you're talking about. Otherwise, they don't know what you're talking about. From outside, the eye looks normal and they don't understand why the baby needs to come back multiple times for evaluation format. So the other thing is when to screen. So we are very happy that this is the slogan we have given, Tees Din Roshni Ke. That means that the screening should definitely be completed by 30 days of life. Now, this was very important slogan because in the American Academy guideline, the ROP screening is mentioned as 24-week or 25-week baby to be screened at 9 weeks, 26-weeker to be screened at 8 weeks, 27-weeker to be screened at 7 weeks. I mean, this is something which is absolutely difficult to follow. Our health workers, their mothers or doctors cannot understand this if it is gestational age based because they don't even know their LMB. And then it's very difficult to benchmark whether the baby was seen on time or not. And then with all that, the table, if you look at the American Academy guideline, it puts an asterisk and says based on insufficient data. So the guideline says that it is based on insufficient data, especially for the small babies. Because when that guideline was made from cryo-ROP study, these small 24, 25, 26, 27 weekers were not in that database. They were not surviving. So I think what we have done is simplified it. We just said that every baby must be screened before 30 days of life. That does not mean that we should not screen them at 20 days or 15 days. So if the baby is leaving town, if you think that baby is not going to come back to the city or to the NICU or to the ROP screening, there's no problem in screening them early and sensitizing them for the need for follow-up. At the first visit, you might find retina is already mature at 15 days or 10 days after birth, then they don't need to come back. If you see some immature retina, then at least you can sensitize and arrange for them to see somebody in the town where they're going to be. So the other thing is so this is just to highlight, if the baby is smaller, then it's better to screen a week earlier. Smaller means if it is less than 1200 grams or less than 27 weeks, because they can get severe aggressive ROP, previously called as aggressive pustular ROP. So they can get AP-ROP or AROP, and we want to screen that much earlier. So even we have seen very severe ROP at 15 days of birth. So if they're smaller babies, better to screen them earlier rather than later, which is against the American Academy guideline. They say that screen them later, but we say screen them earlier. So between 20 to 30 days of birth, all the babies should complete their first eye screening. So the ROP is such a nice disease in the sense that it has a very well-known natural history. There should be no difficulty. Today I was taking a class of the nurses and I was trying to teach them how to take photographs. And initially they were a little hesitant because they did not understand the ROP. But what I told them is, when you are giving IV line, and sisters, everybody is giving IV line. So if you see this type of vessel, you know that I can put an IV line very easily. If you see this type of vessel, you know that I cannot put an IV line. And in premature babies, many of the vessels, when the sisters are putting IV line, even their hand vessels are very tortuous and thin. So they know what is a difficult IV line and what is an easy IV line. So like that, I taught them about normal, vessels and abnormal vessels. So normal vessels in a term baby, you can see a mature retina, how it looks like. It has dichotomously branching vessel. Each vessel is very clearly seen. There's a very good ILM reflex which is coming, and the density of vessels is more. So this is what a term baby mature retina will be. An immature retina will have dichotomously branching vessels. The vessels will be few. It will not have the ILM reflex, and there will not be many vessels, but there will be no tortuosity. So this is a normal preterm. In an immature retina, we will have dichotomously branching vessels, but they will not move forward. They will just, just be diffuse, but there will not be any line. And after 20 to 30 days, this will land up into a severe ROP, which is these conditions require systemic therapy, as I said, and treatment. If we don't treat this on time, then it starts going down towards the blindness, which is stage 4, 5, and 4A, 4B, and 5. So we have a window of opportunity here going up, like it's like snakes and ladders. You can go up the ladder and win the game, or you can go down the snake and lose the game. So the thing that somebody who's trying to learn ROP screening is you only have to learn how to look at the vessels, whether the vessels are normal or abnormal. When ROP starts, always the posterior pole vessels near the disc will start having tortuosity. So your first view of the disc will tell you and the surrounding retina whether there is ROP, yes or no, because there will be tortuosity. That's the first sign. And of course, there should be no difficulty in saying that these are dilated vessels and this is normal vessels. And when the vessels are abnormal, then they will not dichotomously branch. They will loop and fall on themselves. So there is no difficulty in seeing whether the vessels are normal or abnormal. So here you can see these are normal and this is abnormal. So these are dilated and they are, shunting on their own. They are not dichotomously branching. So sometimes people can miss the APROP. These are difficult to follow, but if you just look at the pattern, what I said. So here we can see vessels are dichotomously branching. That was normal, and suddenly they have started looping. This is ROP. Here the vessels are branching, but here they have started looping. So this is ROP. So we should be able to differentiate normal from abnormal. And here we have a doctor who has drawn very nicely. See, he has drawn these abnormal vessels, and here he has written no ROP come after 10 days. And this baby developed very severe ROP. If you see abnormal vessels, this is ROP. You should not misinterpret it. You should not say that there is no ROP because I'm not seeing a ridge or I'm not seeing a dilated vessel. Any abnormal pattern which is not dichotomously branching is ROP. You may not be able to classify it. You may not know what is the stage, zone. It doesn't matter. If they are dilated tortuous vessels at posterior pole and you see this abnormality, this requires immediate treatment. This should not be called after 7 to 10 days. So once we do the laser, again, the way that we do laser is very important. All the avascular retina has to be treated. And if you have done good laser treatment, then within 3 to 4 days, you will see a dramatic change. All the vessels will start becoming smaller. All the hemorrhages will start getting white-centered and disappearing. Here you see in this area, after the laser is done, this was the hemorrhage. It has not gone. That means it is not adequate laser. The reason is because we have not lasered these pockets. So you have to laser right up to the last area of the retina which has abnormal pockets. So the avascular retina and the posterior retina which has abnormal areas need to be lasered, then the disease will just go away. So sometimes the patients come late or the laser doesn't work and the retina starts showing fibrosis and elevation. Now this is the time to refer for treatment, for surgery to the retina surgeon. And before you refer, again check the anemia, give the transfusion if the hemoglobin is less than 10. And only then refer. So here I learned my lesson. This was the baby. I had done laser. I thought everything is good. There's just little blood. And then I saw after 1 week, everything looked nice. And then in the next week, you can see the whole retina has detached and we operated and saved this eye. But we should have operated here. So unlike diabetic retinopathy, where we wait if there's a nasal traction, here, any traction more than 1 clock hour, we should refer and operate immediately because they will always progress. So now here we have learnt our lesson. Here you can see retina is nicely lasered. There is not much of ROP, but there's an elevation here. So immediately we have done surgery and everything goes away and the eye has a perfectly good macula and there's no worsening. Now recently we have come up with anti-VEGF injections. So many people have a lot of questions on anti-VEGF. I'm not going to take a lecture on anti-VEGF here, but just this is a very nice article by Dr. Klufas and Paul Chan in 2015. What we know after 7 years of treatment, and they have very nicely told where is the work of laser and where is the work of Avastin or other anti-VEGFs. And most important thing is that after anti-VEGF, they can get recurrences, they can get delayed recurrences. So we need to follow up indefinitely for a very long time till we are sure that the disease is not coming back. So Dr. Tapas from our group, he has very nicely drawn. So this we had to learn. This is not like laser, so we should not extrapolate what we learned with laser and ROP to anti-VEGF and ROP. Anti-VEGF and ROP is a completely different ball game. All of us have to start learning. So after you give the anti-VEGF, then in the first few weeks, the ROP goes away and then we see these remodeling of the vessel. This is all normal. This is normal. We see circumferential vessels. We see sawtooth vessels. So multiple publications on that. He has drawn each vessel and we see that all of this then disappears. So this is not recurrence. If there's a recurrence, then you will see that the pupil doesn't dilate or there are hemorrhages or there are abnormal vasculature and so they need treatment. So we need to learn what is a remodeling where the disease will go away after some time and what is a recurrence where we need to intervene early. So here again, sometimes we can see here the anti-VEGF was given and there are hemorrhages. So sometimes after giving the injection, suddenly new hemorrhages appear. Again, this does not require surgery or laser. It will go away after some time. So we can see here So these photos on optos taken by Sushma show that it goes away. So we have to learn how it will go away. However, these injections can cause problems sometimes. They can cause some choroidal ruptures, they can cause choroidal detachment, they can cause some vasculitis. If you give it with the fibrosis in the eye, we should never inject an eye which already has traction, then you can develop these breaks and the tractional detachment will go into reg RD. The tractional detachment we can operate, reg RD we cannot. So don't give injections if there is traction. So coming to the outcomes, yes, the outcomes are extremely good. Most of the children, whether with treatment or those who regress spontaneously, most of them will have myopia. However, they will have very good vision. More than 90% of them will get 20/50 or better vision. The most important thing is the time. That is why Teestin Roshni is so important. So the other thing is that if you see a child, having bad retina, there's a psychiatrical ROP, don't give up. Don't think that this child will not read or the prognosis is poor or the child is going to be blind. You can see with proper low vision aids, with proper training right from birth, this child's handwriting at 5 years is better than mine. And now he's a university topper, actually, this boy. We saw in 98. Of course, we don't want to see these cards. If we had treated on time like this child, the doctor's child from Punjab. So our student did this. You can see the retina actually grows. So sometimes people have a lot of apprehension and they will tell the parents that, child will get field loss. Actually, they don't get that much field loss because the retina grows and the laser marks also grow peripherally. And we get a pristine retina disc very well. So this should be our aim, that every child who is treated for ROP ultimately is left with a pristine macular disc, a straight eye, smiling mother, a good fixation. And of course, as I said, that they need refraction and care in follow-up. So I will stop here. If any questions, I'll be happy to answer.
Thank you so much, ma'am, for that wonderful talk. We would like you to stay on for the panel discussion in the end. Next, we'll go on to Dr. Niranjan Pehre. It's a pleasure to introduce him. He's an alumnus of our own Amrita Institute, the pediatric ophthalmologist with special interest in cerebral visual impairment. He started a center for interdisciplinary care for children with CVI at Vijayawada, where he was working before. And now at present, he is at the Liberia Eye Center run by LV Prasad Eye Institute in Liberia in West Africa. And it is the only modern eye care facility in that country providing clinical care for a wide range of eye diseases. He says he has a little bit of a electricity problem there, as in most of Africa. So we'll just go over to him without any further delay. Over to you, Dr. Niranjan. Happy to have you
in our
here.
country also now with the cold.
Yeah, true.
Okay.
Okay, thank you, Natasha ma'am and team Ksos for having me here on this CME. I think Dr. Jalali has created a very nice background, and with that now we can move on with my topic. Actually, I thought that this was a pediatric ophthalmology symposium, so I had put my topic just as cell-based therapies for CVI, just to talk something different about CVI than what we usually talk. But later I realized that it is for a pediatric retina symposium. So I included some aspects of the vision issues in children who are prematurely born, apart from ROP. So apart from ROP, the children are predisposed for high refractive errors, amblyopia, squint, cataract, glaucoma, and late retinal detachments, even in regressed ROP. Apart from these ocular problems, these babies are at risk of delayed visual maturation and CVI. And visual pathways in a premature baby are vulnerable for delayed development, especially the magnocellular pathway and the dorsal stream. And the maximum vulnerability is in the first 3 to 6 months of life. Most of the prematurely born children, they are predisposed for some or the other brain injury in the form of periventricular leukomalacia, intraventricular hemorrhage, hydrocephalus. All these are together called as encephalopathy of prematurity. And these brain problems often involve areas of brain concerned with processing of vision. And some of the children may manifest vision problems only later in life, around the age of 7 to 8 years, which are related to the visual processing and not the clarity of vision. And that is called as cognitive visual dysfunction. So there is abundant evidence to suggest that every prematurely born baby requires a long-term follow-up, even if there was no ROP in early life. But unlike ROP, CVI has not received much attention, and there are no guidelines about the regular long-term follow-up of the children if they did not develop ROP. So based on our experience of handling these babies over the years, we follow these guidelines. Number one is babies who received some form of treatment for ROP, either laser or surgery. They are at increased risk of several of these ocular problems. So they need to be followed up every 3 months till the age of 1 year, and later every 6 months till the age of 4 to 5 years. Babies who did not develop ROP or did not require treatment for ROP, they need to be seen at age of 2 months. If they developed central, steady and stable fixation and they have insignificant refractive errors, they can be seen every 6 months till the age of 1 year. And if they are fine at 1 year, then yearly till the age of 4 to 5 years. Now, what do we look for in a baby when we see at 2 months of age? So if the child does not have a normal fixation and following, we need to look for the cause for the same. First, ruling out the treatable problems like refractive error, accommodation problems, cataract, retinal complications. If the ocular examination does not explain the vision, then the CVI or delayed visual maturation should be thought of. In such cases, the vision intervention should be started immediately. And despite adequate vision stimulation activities, if there is no improvement in vision or no significant improvement in vision, then we are probably looking at CVI, and child needs to be put on the track of the functional visual assessment and the guided interventions which are embedded in child's daily routine activities. At each visit, what should we look for? The age-appropriate visual acuity assessment, accommodation by dynamic retinoscopy, cycloplegic refraction once in 6 months or a year, ocular alignment and extraocular movements, lens status, intraocular pressure, and posterior segment examination. Sometimes these children, they do not have much vision problems in early life, but after the age of 4 to 5 years, they come with some complaints like the child is unable to find toy or people or is upset in busy places. This could be because of the visual processing related issues. And instead of just sending them away saying that eyes are normal, we should go deeper into their visual functioning with the help of different tools that are available and plan intervention strategies for the same. So to summarize, every prematurely born child needs regular ophthalmological examination till the age of 4 to 5 years, irrespective of whether they have had ROP or not. At age of 2 months, a comprehensive eye examination, look for visual behavior and treatable ophthalmological problems, delayed visual maturation, and thereafter the child should be seen every 3 months if treated for ROP, and every 6 months if no ROP till the age of 1 year, and then yearly till the age of 4 to 5 years. Now coming to the cell-based therapies for CVI. The reason for bringing up this topic is that all of us in pediatric ophthalmic clinics do come across these children, and parents are asking this question whether we should go for cell-based therapies. So we should know something about these therapies. So as we all know, stem cells are undifferentiated cells with a capacity to both differentiate and multiply into multiple cell types that form our body. So most of the literature that I reviewed and presenting here actually comes from the work on cerebral palsy, because there is no studies that talks about the vision aspect of it. So we have to just extrapolate what is described about the cerebral palsy. So why should stem cells work for cerebral palsy? So the brain injury in CP happens by various mechanisms, and the most common ones are the inflammation, swelling, cell death, and scarring. So what do stem cells do to it? They have anti-inflammatory effect, immunomodulatory effect, cell repair, replacement of damaged cells, and protection of the vulnerable cells. So out of this inflammation and the immunomodulation, these mechanisms are emerging as the predominant mechanisms of brain injury and the mechanism by which stem cells work. Even in adults in their 20s, they have found that inflammatory markers are much higher compared to the typically developing age-appropriate individuals. So it is basically the immunomodulation by which these stem cells work. Now, how are these cells administered? Intracerebral, intra-arterial, intraperitoneal, intravenous, intranasal, different routes are described. Initially, I used to think that intracerebral would be the most desirable one because you inject cells right at the place where there is cell damage. But just now we have seen that it is basically the immunomodulatory effect, and that's why intravenous is the most commonly used route for research as well as for various clinical trials. Now, outcomes, what do we expect about vision. As I just said that there is nothing much written about the vision per se, but I would like to review some literature that is described for the cerebral palsy. Now, this is an excellent review published in 2019, and I particularly like the way they represent the results. So they basically talk about the safety, and they have used these color codes as red, yellow, and green. Green means it is safe, so you can do it. Yellow means there is ambiguity, so probably it may work, it may not work. So in that, again, what one can go ahead and do it, and one should avoid that. Also, they have divided and drawn a worth it line, and the red means it is known to be unsafe, so it should not be done. So in this, they have studied 7 to 8 aspects of cerebral palsy. In that, if we talk about the motor aspect, they mention that the umbilical cord blood stem cells, they are known to be safe. Now, how do we extrapolate this to vision? As we know, actually, there is no motor milestone which is motor in isolation. It is usually visio-motor. And most of the vision milestones also, they are not really isolated vision, but they are visio-motor. So if something is helping for motor development, it is quite likely that it may help for vision also. And that way, maybe we can say that umbilical cord blood stem cells may help. But we must remember that all these therapies are done along with a regular rehabilitation program and not in isolation. I was curious to check what is the effect of these cells on communication and cognition aspects. And actually, there is no significant effect, and there is no mention about vision on these parameters. Interestingly, they mention hypothermia as a modality which is safe to do, and it is noted to prevent cortical visual impairment. This especially is important for developing part of the world. And in some of the countries like even Rwanda, they have published RCTs about how hypothermia is effective in preventing long-term consequences of brain injury. So in that connection, this looks like something important. We should be wary of some unsubstantiated claims about efficacy of stem cell therapy for vision improvement. And one report is from China in year 2014. And they report that 1/3 of their patients had excellent visual improvement. And there is one study from Delhi which talks about, again, very good improvement. But if you look at the profile of these institutions and the authors, you don't really get convinced about what they talk about. And we who have seen hundreds of the children over the years, these results appear too good to be believed. There is an interesting consensus statement released by the Indian Academy of Neurology, and they have basically talked about the use of stem cells for different neurodegenerative disorders in adults. They don't talk about cerebral palsy per se, but a lot of corollaries can be drawn. And it's a nice article to read. It's in question answer format, and I would recommend all of you to go through it. And particularly this question, how should the neurologist counsel patients seeking use of stem cells in the hope of ameliorating their neurological condition? There's an interesting answer. They say that in keeping with the principles of autonomy, the neurologist should not, under any circumstances, dismiss the patient's intention to explore or undertake a stem cell procedure in the country or abroad as futile. So they say that we should educate the patients and let them make a decision. So in summary about stem cells, what we would say is that we should not dismiss the desire of the family to go for stem cell treatment. Give them the scientific information. The article that I just mentioned is a very easy to read for general population also. In addition, it also gives references for several websites and resources where patients can check on their own. And we have to make them wary of these various YouTube videos and other unsubstantiated publications, and then let them make a choice on their own. There are centers in India, reputed ones, where if the stem cell therapy is done there, it is safe. We have seen several children who have gone there and come back, but we have not seen any efficacy, but they are safe. So there is no proof of efficacy yet on vision, neither in the literature nor in our experience. Thank you.
Thank you so much, Niranjan, for that amazing talk to put new light on a lot of things. We have with us an expert panel here. that we have put together with mainly ROP experts. So let me just quickly introduce them. Dr. Prakash, he is a consultant VR surgeon at Comtrust Eye Hospital, Kozhikode. Dr. Anubhav Goel is a VR surgeon and ROP practicing surgeon at Giridhar Eye Hospital, Kochi. Dr. Sheera KR is a consultant VR services and ROP in Aradhana Eye Institute, Trivandrum. And Dr. N. Sunil is a vitreoretinal surgeon at Kaumudi Gramina Netralaya, Kasaragod. So welcome to all of you to this panel discussion. And we'll just quickly go along a few questions that we have kept ready for our keynote speaker. So Dr. Prakash, would you like to go first? He has a case scenario to discuss with ma'am.
Yeah, thank you, Natasha. And it was a great talk as usual by Jalali madam, and it was amazing to see her dedication to this cause. And you remain a motivation for most of us, madam. Thank you. And my case, I just wanted to have your opinion on a difficult case I'm facing right now. It's a baby, actually twins, actually, slightly lesser than 28 weeks born, had a very turbulent perinatal period, and we had seen this baby only at around 40 weeks or 41 weeks. And baby at that time had a zone 2 disease with a few 1 or 2 clock hours of stage 3, no plus at all. So we had kept consideration. Baby was on CPAP. Baby had some intraventricular hemorrhage, and baby had a hypophosphatemic hypocalcemia, which they didn't treat. The neonatologists didn't feel it to be treated because they treat only if the hypocalcemia is symptomatic. But what we didn't expect was by the next time when we visited the baby has a dense cataract. And we can just see the posterior pole. There was no plus disease, but periphery totally not visible. And by the next visit, the baby became a total cataract, no view at all. The other twin also has a cataract, which is preventing perivisualization of periphery, but no plus disease. And so our plan was, we thought we'll go ahead with cataract surgery as early as possible and treat the ROP on table itself. But due to some systemic issues, we are not giving fitness at this point of time. So the question is whether we should give an anti-VEGF injection because it's 41 weeks. We don't know. It may not be effective because it's already phase 3 of ROP. It may not be effective, and it might cause a crunch syndrome. So all these fears are there, and we are not having a visualization at all. So should we give an anti-VEGF, or should we just wait another couple of weeks, 1 or 2 weeks for the baby to become fit for cataract surgery? So because I'm facing a cataract and ROP together for the first time.
Yeah. So we have faced this situation a few times where there was total congenital cataract or almost cataract, and then by the time we are thinking the cataract has become more. So you can hear me?
Somebody's having in the microphone.
Dr. Barun, you can switch off your mic. Dr. Barun Nayak, please. So what we do is, number one is, of course, you were very lucky that you were able to see the retina at some point of time. And, if you have a drawing of that, that will help you to know, is this going to worsen or not? Usually after 41, 42 weeks, if the baby is under good care, the ROP will not worsen that much, but it was still in zone 2 and the baby is still not out. So the other clue you can get about worsening is from the pupil dilatation. This is a very important clue. If the pupil dilates very easily, you put the tropicamide, you put 2 times and the pupil dilates fully, then it's unlikely that there's plus behind. If the pupil was dilating fully and now it is not dilating well, or it is taking too much time to dilate, or you have to put multiple times the drops, that means that something is brewing. In eyes with any amount of plus, they will have difficulty in dilating. It may dilate ultimately, but it will not dilate fast. So that is one clue you can have there. The second clue, of course, is that what is the systemic status? If the baby is gaining good weight, in between did not get sepsis or pneumonia or something, then it is likely that that ROP will not worsen fast. Now, if we are not very sure of the findings or we are in doubt, there is no harm in giving the anti-VEGF, because when you had seen, it was not having a lot of fibrosis. It was still in stage 2 or early 3 and there was not much of plus. So these 2 guidelines can guide you whether you should give anti-VEGF or not. If you give anti-VEGF, then obviously, baby will need additional laser once you remove the cataract. So we had few patients where we were not able to, decide what to do. So we have given the anti-VEGF, and then as soon as the baby is fit for surgery, we have done the cataract surgery. and done a good capsulotomy. And then intraoperatively if we saw, or after 1 week we saw, and then we went ahead and did the laser in follow-up. One of the babies still developed tractional detachment and we had to do vitrectomy, but we were able to salvage all the eyes. So I think discussion with the family, explaining what is the problem, and see, because your ultrasound is not going to pick up, but if you have good ultrasound, at least you can pick up, is there some traction developing? So if there's no traction and you had already seen, I think you can wait and watch. But if you think that the pupil is not dilating well, or there's some other systemic issue, you can inject.
Okay, thank you, ma'am. That was.
But at 41 weeks, 42 weeks,
41.
Unlikely that it will worsen if they were in care and it was not very severe ROP when you saw.
Yes.
Can I quickly take up the rest of the questions? One was about anti-VEGF injections, ma'am. Currently, other than AP-ROP, are you giving anti-VEGF for any other indication? And secondly, are you giving second injection if there is recurrence after laser?
So initially when I started in 2007, I was only giving anti-VEGF if the laser failed, or if I was not able to do laser because the baby was sick. Although even sick babies on ventilators, we have lasered very well. There is no issue about that. But sometimes, very rarely, we are trying to do laser, baby desaturating again and again. Then we have given injection. But now, over a period of time, as I showed, we have learned a lot of things about anti-VEGF. We are feeling more comfortable. The only thing is that I give only Avastin, that is bevacizumab. I don't give ranibizumab or azumab or any other drug because I'm not still conversant with that. I'm quite comfortable giving Avastin both in adults and children. We allocate it in our place only. Now, currently for AP-ROP, only I'm giving the anti-VEGF, both eyes, and then the second injection very rarely. So if the first injection did not show any response, okay, so this happens either because the drug was kept outside, not in the cold chain, then it becomes inactive. Or, it was allocated for too many days. Normally, we use it within 2 weeks. Or, when you are injecting, because you're injecting very tiny volume, sometimes it regurgitates out and, it comes into the conjunctiva. And so you don't know how much actually went in. So even 1/10 dose or 1/5 dose is more than enough to, do the thing what it is supposed to do. But sometimes we see that somebody has given an injection or we have given an injection and we are not seeing the changes that we were supposed to see. Then I will immediately inject once more. Now, the second injection for recurrence, the disease has gone, but the vessels are not growing further. And then again, the pupil is, becoming smaller or the disease shows a recurrence. So repeat injection, again, very few babies I have given. Most of the times I would rather do a laser, but it's not true for all cases. And some cases I have given a repeat injection. And I have also given repeat injection. Actually, one patient, they had received eccentrics and twin babies, 4 eyes. So they came to me after 3 weeks of the injection and there was very severe ROP. So I thought maybe it has not worked or there's some issue because there was so much severe ROP. Normally it should go away. At least it should quieten down. Then I was in dilemma, if I now inject Avastin because I only like Avastin, will it cause a problem because there is some ranibizumab in the eye and I don't know how much of it is there. But anyway, 2 eyes I went and injected one baby. Other baby I said I will still wait and watch and see will something improve. Maybe the drug is taking slower time. But that baby again it showed recurrence. So again I injected Avastin and now the babies are doing absolutely okay and the whole retina has grown well. So if we are doing monotherapy, I think we can just wait and watch. If we are not going to do monotherapy, we are going to do combined therapy. Then usually I laser within 4 to 5 days or 10 days, depending on the schedule when patient can come. So yeah, that's my policy. It may change over a period of time, but currently second injection only in selected cases, and also document why I'm giving that second injection, why I'm not doing laser, so that there's a clarity. If I go back to that case sheet, there's a clarity what happened, so we can learn.
Yeah, ma'am. I think that is almost what we all practice too.
And just one question, can I discuss with Jalali, ma'am?
Go ahead, Anubhav.
Yeah, ma'am, I recently have 2 or 3 baby scenarios. Recently seen a twin baby, gestation age 32 weeks, birth weight nearly 1.2, 1.3 kgs, or both the babies nearly. But mother was COVID positive in 3rd trimester. And the baby showed, babies were having no unwanted episode after the birth, no oxygen requirement, nothing. And I screened baby after 3 weeks and baby were having ROP. Stage 3, zone 2, no plus. Next week they converted into pre plus. So seeing the pre-plus stage worsening, I injected even at pre-plus, and now babies are doing well. So similarly, approximately a year back, I saw a baby in Delhi. I shifted to Noida for some time. So there also I saw one aggressive ROP disease in zone 1 in a COVID positive mother in 2020. And instead of giving injection, I gave laser. So after laser, baby didn't improve. In fact, it worsened, landed up into stage 5, underwent surgery, and then ended up into macula hole later on. So have you ever seen a similar scenario of COVID positive mother during pregnancy landing up with the early ROP in all these babies without any event, with the unwanted events immediately after the birth?
I think we are just passing through the COVID and we will be seeing this type of cases and we need to report. I have not seen, but yes, what is known is that if there's any inflammatory episode during pregnancy, chorioamnitis or HSV or anything, any inflammation, the ROP can worsen. Even in the baby, like Niranjan said, if there's an inflammation. So this role of inflammation in ROP has not been very well talked about. Now we are talking about role of inflammation in CRBO, BRBO. We are saying give Ozurdex. In diabetic maculopathy also we are saying there's an inflammation. In ARMD also we are saying there's inflammation. In PCV we are saying inflammation. So we did vitreous studies and it is published in a very good journal in Frontiers of Genetics, and we showed that actually as the ROP starts worsening, there's a huge amount of inflammatory mediators, MMP9 and complement pathways which get activated. And so there is a huge amount of inflammation. So if the mother had any inflammatory disease or the baby had any reason to get an inflammation, then the ROP will worsen. So that we know. So about COVID, because you are the people who should start reporting these cases. Anybody who sees COVID-related things, we should start reporting. But what we have shown definitely is that inflammation, and actually when we are operating these cases before we do surgery, and even in your cases, if you have given an anti-VEGF, you move the eye, you can actually see the cellularity of the vitreous. There's a haze, it doesn't go. And you think that it is improving, pupil is dilating, but you see a haze, you are not seeing complete clarity. True. This is a smoldering disease. It will worsen, it will come back with a bang. So that inflammation sign, if you can see with your indirect ophthalmoscope, you can see the vitreous is still hazy, then you know that my treatment is not complete. You should treat that eye till the vitreous is completely clear. Otherwise, they will need surgery. So even a Japanese group and even myself, I have operated cases in stage 3 where the inflammation was not going. We were trying to do some laser. The laser is not working. That is the time, there's no detachment. That is the time we went ahead and removed that inflamed vitreous, and the babies have done very well. So even from Japan, APROP, one of the treatments suggested is a vitrectomy because it will remove that. If you just inject and do laser, actually the inflammation worsens, and that is what you're describing. So try to look for signs of inflammation. In fact, Dr. I forgot her name, from Bascom, she said she's even injecting steroids during vitrectomy or after vitrectomy, or she even gives subtendon steroids. I have not given that, but yes, the inflammatory role in non-regressing cases should be looked for and managed by vitrectomy.
So your experience, whether with these inflammatory signs, baby should be injected first or direct laser is okay, or what will be your take?
It will depend on the findings that I see. If there's too much inflammation, I may still inject and then operate early, as I said, if the baby is not responding. So different babies will respond differently. Their systemic status, what is the level of antibodies, what is the level of circulating immune complexes in their bloodstream would be different. But the basic thing is that if there's an inflammation going on in the mother or baby, then it can worsen. So we should be warned. Same way metabolic, somebody talked, calcium is not okay. I had a baby who had this saline deficiency. She was not making sodium chloride. And I saw the same thing. She had mild ROP one day. And I was just following her like a routine baby. And before I knew, she just landed into stage 5. In hindsight, I'm thinking baby had a systemic problem, calcium problems, sodium chloride problem. All of them can influence the vascular growth. So I should have been more aggressive in my follow-up or management. So that lesson learned, that if baby has other issues, then we should either treat little earlier, or if we are not treating, then keep them under more close follow-up than a routine baby.
Thank you, ma'am. Thank you so much. For lack of time, we will wind up this discussion here. Thank you, Subhadra ma'am. Thank you, Niranjan, for being here. And thank you all the panelists for being here with us today.
Madam, one small question, madam. Madam, in a case of a hybrid ROP,
how to plan our management? First to give injections and then wait for reactivation and then to give laser, or madam directly to
that's what we are doing. We
give laser, madam, in a hybrid ROP.
We published a study saying whether laser first or anti-VEGF first in routine eyes. So we found that if you do, ultimately the outcome was good, but in all the groups, we did one eye injection and then laser, and in the second eye we did laser and injection later. So we found that injection first eyes did much better in terms of not needing additional treatment. So we injected and then laser and they did much better.
Okay.
But in those where we had done laser first and then injection, there generally we had to do in 60% cases a second sitting of laser. So the reason is obvious, because if we are doing laser after anti-VEGF, the pupil is dilated, media is clear, so we are better able to deliver the laser. But if you don't want to do both eyes injection same day, then you can inject one eye, do laser in the other eye, and after 3-4 days you can inject the previous eye and laser this eye. So no eye waits for the treatment. And Niranjan, just one thing, you said that at 2 months we should see the pigmentation falling and all. I think that is 2 months of corrected age, right? Means
yes, corrected age.
Like, you know, if baby is 6 months born, then don't check at 8 months. So, but it is like after 2 months after the EDD.
Yes.
Yeah.
Yes. Corrected age. Thank you.
Thank you, everyone. I think Dr. Sreeni is rolling his eyes at me. I think we should wind up the session now.
Thank you, madam.
We are phone call away. We are only an email away. Anytime, any queries.
Thank you, ma'am.
Absolutely, ma'am. Thank you so much for being there.
Yeah. And please share these cases. Please publish these cases. We are all here to learn.
Sure.
Thank you, madams and sirs. It was indeed an interesting and thought-provoking session. With this, we have come to the end of our academic update. On behalf of KSOS and Kottayam Ophthalmic Society, I thank all the speakers, chairpersons, and panelists.
Okay.
Hello.
Happy Mother's Day. Thank you.
Thank you.
Happy Mother's Day, ma'am.
And we have the inauguration of KSOS on demand coming up next. For this, I hand over to Dr. Dhrumil.
Thank you everyone for staying back for the inauguration of KSOS on demand. Because this is such an important project, and it was the dream of our dear president, Dr. Arup Chakrabarti, to have something like what you have in ESCROs on demand and ASCROs on demand, what is there in AAO and all. So we had a real great, wonderful scientific sessions during our Drishti 2021, organized by the real meticulous Dr. Rajesh Sugmaran. So as I took over as a scientific committee chairman, my plan was to split up all these talks and keep sending it. Dr. Arup said, no, that's not the way. We have to have it on our website. So he worked on it, and so it's Dr. Arup Chakrabarti's baby, and we wanted the #1 man in ophthalmology in India, the president of All India Ophthalmological Society, Dr. Bharat Naik sir, to inaugurate this session. He had a very busy day today. He was at the inspection site, at the site for our next All India conference at Mumbai. So he had to rush back home to join this meeting. I welcome Dr. Bharat Naik sir to this meeting. Welcome, sir.
Thank you, Sreeni. Thank you, Sreeni.
And I welcome Dr. Gopalas Pillai, our General Secretary. He's there. He's the live wire of KSOS. He's there with us, and Dr. Rajesh Sugmaran is there. Whatever is there on the website is his project. So whatever he has done during the last conference, it's all his work. It has been segmented and kept on the website. That's it. So Dr. Rajesh Sugmaran will be making a presentation on what is KSOS on demand. And after that, once Naik sir sees that and gets an idea about what it is, we'll have the official inauguration of Ksos on demand by sir. Rajiv sir.
Good evening.
Yeah.
Shall I present?
Yes, sir. Yes, sir.
Okay. I'll do a small presentation on the navigation of the site. Is it visible?
Yes, sir.
Yes, sir. It is visible. Oh. So, first of all, let me thank Arup sir for coming out with such a beautiful idea. It's a brain child of Arup sir. He wanted all the programs in the previous Drishti to be categorized and uploaded in the website. And one good thing about the previous conference, even though it was online, was that it wasn't live. All the speakers gave their recorded version so that the quality of the videos and the presentations were excellent. So we compiled all that and we made it deferred live. Only the discussion part was live. So the quality of the video is unlike the Zoom videos which are recorded live. This one is far better than that, and all of them were in the high definition quality. Now, so the website is ksos.in. It's very simple to remember, ksos.in. So in the web, this is a beautifully designed website where we have so many features there, the journals, the newsletter, books, archives, everything is there. Yeah, and today what we are going to launch is the Ksos on demand. So it is there on the main screen itself where you need not log in to enter this site. So next, once you click that, you enter, you get a dialog box which gives an introduction to the site by President Arup sir. And once you proceed, this is actually not my work. It is the contribution of nearly 620 faculties. So there are so many people behind this, even though it is being presented today by me. It is the work of so many people's sleepless night has come into. So I'm extremely happy those hard works are not lost. And most of the conference after that, nobody knows what happens to the recording, where it goes. But here it has come in all in one place, and anybody can retrieve it and see it. Hope the subsequent office bearers continue this beautiful program. And the site is so well designed that it is very simple. You have the instruction course, the free papers, the sponsored programs, e-posters, journal club, PG classes, and webinar. It is categorized in this way. Till e-poster, it is the previous Drishti conference, a journal club, PG classroom, and the webinar are the present office bearers projects. So if you click on one of the icon, for example, the instruction course, it will give you the list of instruction courses that have been conducted last year. And underneath each topic, there will be numbers denoting the number of courses which is conducted last year. So if you click on any particular, for example, the cataract, if you click on that, it will give you the list of ICs already conducted with the topic, the IC number, as well as the chief instructor's name. Underneath that, it will show the number of talks in each IC. So then if you further click on one of the ICs, for example, Dr. Minumathan's thing, if you click, it will show you the subtopics each speaker has done. And if you click on a particular person's talk play, it goes to the video. It is as simple as that. So once you have reached there, it goes to the high quality video playing without any interference. And the videos are very smooth in it because it's all pre-recorded. And one more best feature about this is the search feature. If you look at on top, there is a search. You can search by the name of the speaker, the topic, or anything within the program. Any word, anything you have entered in the full program sheet. If you enter there, it will appear there. For example, I'm putting our Dr. Sreeni's name there. Look at that. When you enter there, it will give you the list of presentations he has done. Not only the IC, the webinars, or wherever his name is there, it will appear. That's the beauty of this. Then you can click that particular topic and see. That is the importance of this search, which is very, very customized. And this site can be seen in mobile, tablet, any, whether Apple, any form, it can be seen because it's built in a hybrid format. And the other thing is e-posters, sponsored program, free papers, are award sessions. It consists of 9 awards. Sponsored programs are by the trade people. E-posters are already there. Similarly, we have the journal club, which was being conducted now, and we have completed 4 of them. The 5th one is in the pipeline. It is scheduled for the Friday, 13th of this month. And of course, the PG classroom by Gopal Pillai is excellent. And the webinars by our scientific committee team headed by Dr. Sreeni. And these are the topics. You can click on them and see, watch them anytime. And I should thank the 2 people behind this, Mr. Naufal and Ankit, who has designed the site for us. And I thank them for all the effort they have taken. Now, it's time for this site to be launched. And I request Sreeni to invite our All India President, Farooq Naik sir, to officially launch this site.
Thank you, Rajesh sir. That wonderful presentation. Now everyone can see what great work you, Arup sir, and all Ankit, Naufal, and all have done with the scientific material that we have with us. Now I invite Dr. Marun Naik sir, President of All India Ophthalmological Society, to officially inaugurate this Ksos on demand. Sir.
Thank you, Dr. Sreeni, and entire KSOS. First of all, before I inaugurate, I must congratulate the entire team, the scientific chairman and Dr. Rajiv Sukumaran, who has really spearheaded this wonderful program. And I was just, while sitting here, I just thought we missed the bus by just few days or weeks, because we also have similar program ready for the AIOS, but always the credit will go to the person who has launched it first. And because it's always, there are either you are a leader or you are a follower. So even if AIOS is such a big society and we will be launching it very soon, and it is ready, we will be launching it soon, but we have missed the bus that we will not be called as the first one in India to start this. So that credit goes to you all for giving this, for materializing this kind of thought. And I know that Arup Chakrabarti is a great mind, so he must have given a lot of ideas in this, and it has made very simple. But I also have one apprehension, because if you make everything so simple to approach, I know for you, those who have designed it, those who will be working hard even in future for upgrading it, it's a big task. It's not that it is very, very difficult task, but it will be really utilized, because if there are plenty, then sometimes it just gets lost, because, okay, we will see, we'll say, okay, now it is there with me, we'll see it tomorrow. Then that tomorrow never comes. So, but if it is not like that, then you always feel that, oh, now this program, if I miss, I will not get the opportunity to again learn from this program. So it's both there are pros and cons. But this is a great effort, and I must congratulate. And I'm really, I understood the entire your what is KSOS on demand, and so I once again, because I congratulate, and I can't stop thanking you, because you really, Sreeni waited for me, because he said, between sir, from this time to this time, anytime you are free, then you just let me know. And I said, okay, the end time, because I thought I'll reach home by that time, and so that I can log in comfortably. But unfortunately, I got caught traffic in between, and so I was feeling bad, and I thought just I'm going to give a call And I don't know what happened. Then people says, no, that you have life of 100 years. So Sreeni probably has life of 100 years because within 10 seconds, his call came. Then I thought it must be Sreeni, and I saw it was Sreeni. So it means you are also following it up very diligently for this program and for this inauguration function. So once again, I apologize for delay. And so with these words, and again, after congratulating all the entire KSOS for leading this to this country with this program, I inaugurate KSOS on demand.
Prashob.
Can somebody mute Prashob, please?
Thank you, Barun Naik sir. It was a great privilege for us to have you inaugurate our KSOS on demand. Now I request Dr. Gopalas Pillai, our Honorary General Secretary of Kerala Society of Ophthalmic Surgeons, to deliver the vote of thanks for this official ceremony. Gopal.
Thank you very much, Sreeni. I'm sorry, I'm in a car. I'm just reaching home only from the airport. First of all, let me thank Dr. Barun Naik sir. Between his very, very busy schedule, he had made his time to come and inaugurate this program. Thank you very much, sir, for that.
Thank you.
I would like to thank Arup sir, who constantly drives us to actually perform. And that's a quality that we have to see. Then there are a lot of people who have taken the work of this particular, design of the website and the thought process that went in. Dr. Rajiv sir requires a standing ovation for this, actually. Sir,
yeah,
it is amazing. And Sreeni and his scientific committee team, the three giants that are helping Sreeni with, and they have really put in a lot of effort in trying to design this website and find out how the contents are, etc. And there are a lot of people, all the faculty who contributed, about 600 of them, who have put in their videos into this. And then, of course, the Kerala Society team is very, very happy and thankful to Barun Naik sir for having said that we are the first in the country to do this. And there are a lot of people, who played in the background also, like Naufal and Ankit, who are actually the people who designed it. Thanking all of you, and let us hope that this venture will actually give benefit to a lot of youngsters, not only ophthalmologists as well. I'm not sure whether I would have missed anybody, but it's a great effort. Thank you very much.
Thank you, Gopal. Barun Naik sir, thanks once again for joining us and inaugurating this project, KSOS on demand of Kerala Society of Ophthalmic Surgeons. Sir, any final words from you, and we'll wind up the session.
No, final words. Just I thought I should say that even today's meeting, what we had, extensive marathon meeting, means it's what I had, and plus with the experience that I am gaining in organizing the conference, it will benefit you all, because you are the next in line. So that is going to benefit. Of course, there are many experienced persons, but this magnitude of conference is not easy to organize. But we had another challenge, that it had to be organized means whatever we could have planned in 1 year, in just 3 months or 3.5 months. So that was, and plus also along with that, always there were scare in mind that still it is there, that we don't know whether we will be able to do it or not, because of suppose suddenly the wave comes, then we are nowhere. And you should also pray that it should not come Otherwise, your conference also will get affected. So you should also pray wholeheartedly that no new wave should come, and for your conference also it should go smoothly. So this is what that all I am wishing, and I want to wish, because right now nothing is coming to my mind except AIOS conference, this one and the next one, next year's. And I'm
Thanks
sure
a lot, sir. With the
enthusiasm that you all have, it will be a great success in this next conference, AIOS. And I remember, because I told somewhere that I was very much impressed some time back when I had gone to KSOS meeting, that you are very particular about the time frame, that all the programs should start on time and finish on time, when the speaker should stick to their time. So that is something which is great thing to achieve. So if you can do that, then all this conference organization will not be a problem at all. It will be a cakewalk for you. Thank you.
Thank you, sir.
Thanks a lot, sir. In fact, we had our first physical LOC meeting for AOC Kochi today at a Grand Hyatt. I'm just back from that. Thanks a lot once again, sir. Now, with this, we'll wind up this official inauguration session. Thank you, sir.